Good morning, everyone. It is my honor to welcome you all to today's CME on cervical cancer. Cervical cancer continues to be a significant health concern, but with right knowledge and timely intervention, we can make a real difference. In the context of today's gathering, I would like to begin with a Sanskrit shlok that highlights the value of knowledge in guiding our actions as medical professionals. विद्या ददाति विनयम विनयात याति पात्रताम पात्रत्वात् धनमाप्नोति धनात् धर्मम तथा सुखम. Meaning, knowledge brings humility, from which comes worthiness, leading to success and fulfillment. For us, the knowledge we gain today will not only enhance our skills, but also allow us to serve our patients with greater precision. With this thought, let us move forward with today's sessions as we explore the various facets of cervical cancer care, from prevention to cutting-edge treatment options. To chair the first session, may I invite Dr. Vidya Tirankar Madam and Dr. Meena Gunzotikar Madam. Dr. Vidya Tirankar Madam is undergraduate and postgraduate teacher, head of the department and examiner at VMGMC and Civil Hospital. She has presented many papers in state, national and international conferences. She has many publications in international and national journals. She has worked hard for upgradation of labor room and OT under Lakshya. She has played a pivotal role in setting up of HDU and ICU at Civil Hospital. And in near future, she plans to start a 100-bedded MCH wing. She has recently done very huge and commendable work in cervical cancer vaccination. Dr. Meena Gunzotikar has done her MBBS and MD from VMGMC Solapur. She is presently consultant at Gunzotikar Nursing Home and SSNJ Ayurveda Hospital Solapur. Her special interest is non-decent vaginal hysterectomy. She has participated in many social activities. Over to you, chairpersons.
Good morning, all of you. We will go with the starting the first session. I invite Dr. Vijay Pawar sir for the talk. Vijay Pawar sir is a consultant at SIMS Fertility Center, Solapur, Associate Professor, VMGMC Solapur and Unit in charge, ex-Clinical Associate Genesis Center for ART Endoscopy and Fetal Medicine, Fellowship in ART 2016 and Fellow of Minimal Access Surgery, India. I request Vijay Pawar sir to start the talk.
Yeah, a very good morning to all of you. I'll straight away start with my today's topic. The topic given is guarding the gate, the power of cervical screening and vaccination. So this is a very important topic. We all know that cervical cancer has a big magnitude of the problem. It is around, we get around 5 lakh to 6 lakh cases. Now this is the official figure, but we all know how the statistics works in the underdeveloped countries and developing nations. So this is what is reported, but I think the statistics may be at least 3 times what we are actually seeing. So the deaths because of cervical cancer are around 3 lakhs documented deaths that can occur per year. And what is important is majority of these cases are occurring in developing countries. So if you see in India, around 20% of the cervical cancers all over the world are present in India. So that is the amount of load that India has of cervical cancer. And so because of this, the important topic of today, that is the screening of cervical cancer and vaccination. This is a very important topic. The primary prevention is what we are supposed to do. So as far as India is concerned, about 1,23,000 new cases have been found annually. Second leading cause of cancer in India, and the second most common female cancer in women aged 15 to 44. So many women from the reproductive age group do succumb to this disease. So if you see this Indian contribution, the volume of load that we have, so the amount of at-risk patients are around 483 million in India. Then annual number of cervical case cancer, as I told you, is around 1,23,000, and deaths are around 77,000. Now 77,000 women die each year of cervical cancer in India. So if you see per day, it is around 200 deaths just because of cancer. And if one plane crashes, it's a big news all over the world. The whole media gets attended towards that news. So here you are having regularly, daily, 200 women are dying of cervical cancer, and it doesn't get that much attention from the government and as a society also. So it's a very important cause of death, and most important is one of the preventable cause. So because of the vaccines and the screening program, if we all implement this program properly to the heart, then I think this lot of these deaths can be prevented, because maximum number of these patients come late for us. Like in our medical college, most of them come after the they are in the inoperable stages. So stage 2, 3 and above they come. So not much can be done. So then just it is the palliative surgical treatments. So that we'll be discussing later on. So there are a lot of things that we think that it will affect only the lower class patients. Upper class patients will not be affected. So she is the Bollywood actress who has suffered from this cancer. So the important cause that cervical cancer occurs is because of this HPV virus. So there are two different, the 16 and 18 virus, which is the most important. So 83% of the cervical cancers are because of this 16 and 18. So we have a vaccine which covers this to HPV 16 and 18. So we'll discuss about that later on. So if we prevent or get the women and also the boys vaccinated for cervical for HPV, then I think most of the load of cervical cancer will be reduced. So WHO has made certain goals for cervical cancer. We'll be discussing that. So first, coming to the when you are screening. So what is screening? Screening is you have to take the general population. So it is not the high risk population. So that is first we have to understand. So every lady which comes into this age group has to be screened for cervical cancer. So all the patients coming to our OPD, if they are eligible candidates for the screening program. So if we are doing cytology, we are doing VIA, or we are doing HPV DNA. So we'll go into that later. So all women coming to our OPD, pregnant, non-pregnant, the smear has to be taken, cytology or whatever program which you are applying in your hospital. So I would like to just ask one question. So many gynecologists are here. How many of you have actually done your own cytology pap smear? So if you see, this is the so out of I think around 25-30 doctors, 4-5 hands are up. So this is the state of affairs. So since my residency, this program is going on: a vaccination, Gardasil, then the screening program, the colposcopy. Everybody does only for the exams, the NMC inspection, the colposcopy is kept, and only during the inspections the room is opened. And this is all over India, that is the situation. So actually the attitude and the belief system of our mindset is only a problem. So first we have to believe, and we all should first do our own screening first, and those who have not got vaccinated should get vaccinated, and then we can tell the public to how to go about this program. So I think this, I myself am attending this screening program in, if I think 10th program I am attending in the last 15-20 years only on HPV, and the statistics are remaining the same, the slides are remaining the same, the content, the load of deaths of cervical cancer is still remaining the same. So I think it has to go from the conference to our practice. So like in our habits, it has to come to do screening of all patients. So awareness right from only I think in the medical colleges the smears are taken in the OPDs, but in private practice hardly any smears are taken. So I think that is a big problem. Even in tuberculosis is the same. So and these are both preventable. So I think we have to look for the risk factors. So we all know about the risk factors. We know we can prevent it by education and awareness, vaccination. In our medical college, the awareness program has been conducted by Madam Tirankar, and our residents are also going to different colleges to create awareness for vaccination and also for the screening. So that also is important, and screening is all at the hospital level. So there are a lot of myths that can occur, that cervical cancer is hereditary, HPV is not common, HPV infection clears on its own, so you don't need any vaccination. I don't need to be screened because cervical cancer doesn't run in my family. So these are different myths that are present in the society, which as a doctor I think we all have to be aware of and see that these myths are not there. So screening, why it is important? Because we all know that cervical cancer from development from CIN early stages, CIN to CIS, and then to the invasive cancer, it takes around 10-15 years time. So it gives a lot of time for us to screen. So a lot of time is available. So very important, and the organ of interest is also very easily accessible. And lot of, I think we are in the Foxy, there are around 35,000 to 40,000 gynecologists right now. So if we screen, everybody screens at least 5 patients per day, so we can meet the target. But the problem is we are not that accustomed and don't want to screen because everything costs. So let's see how we can try to use these screening methods, different methods that we have. Like the pap smear, I will not go into the details of the pap smear, we all know about pap smear. This liquid based cytology is the new thing that has come. It is now available in Solapur. So previously I think 5-6 years where this LBC was not available. So now this is available. Now this is also clubbed with the HPV DNA which you can do. I think it comes cost around 1500 to 1800 rupees. But when you try to deal with the laboratories in private practice, they are ready to do the liquid based cytology for 500 rupees, and but then you have to give a volume workload. So the price can be dropped down once the number of patients samples receiving to the lab can be increased. So currently I think not many people are using this, but I have been using this liquid based cytology along with HPV DNA. They cost around 1500 right now. But when you bargain with them, they can come to 500. That is what I found out. So lot of possibilities regarding liquid based cytology that is there. The concepts of liquid based cytology, all cells are transferred, that is important compared to your pap smear, and the detection rate and false positive and false negative rates are less in compared in liquid based cytology. So liquid based cytology is better than the conventional pap smear. But again the problem here is regarding the screening. So when you want to screen, all patients should be available for screening, and this facility has to be available, and it should be, when we are thinking that this should be available at the village level also. So the newer WHO, that what WHO says is these two different approaches what the WHO has made. So in all my presentation, if you remember this slide, my presentation is over. So if you just remember this slide, it is first is screen and treat approach. What is screen and treat approach? That means the patient comes to you, you screen the patient by two tests. So WHO has given two options. Either you can do a visual inspection with acetic acid, that is 3 to 5% of acetic acid you apply to the cervix, look for the acetocyte areas, and further I think in colposcopy section the further things will be discussed. So visual inspection of acetic acid, very important, that is one of the tests, or the other is the HPV DNA. Now HPV DNA is one of the very important tests which has come in the last 5-6 years, easily available, and I think by the time in the next 5-6 years the whole focus will be on testing for the HPV DNA. So these are the primary two tests that you have to do. You screen and treat. What do you mean by treat? Treat means if there is a cervical erosion, you see acetocyte area, or you see any pathogen in the cervix, you do the treatment. So treatment can be by if the patient is feasible for ablative therapies. Okay, so we have cryotherapy, you have thermal ablation, and large loop excision of the transformation zone. So if the patient is a candidate for ablation therapy, then you can go for that, or if there is a lesion, you can do the biopsy. So that is screen and treat, one visit, end of story. So that is, this approach is especially done in settings which are low resource settings. Now there is another thing which is called as screen, triage and treat approach. Screen, triage and treat approach म्हणजे it is something like when we used to do for HIV. आपण पहिले ट्रायड आउट करायचो किटवर, नंतर ते पॉझिटिव्ह आलं तर अजून एक टेस्ट करून कन्फर्मेटरी टेस्ट, आणि देन वी यूज टू अनाउन्स द HIV. So similarly in here, you do the first screening test, or you do the screening test, either you do the visual inspection or you do the HPV DNA, either of the screening test, and then you do the these different tests that are available. The second line of test can be cytology, that is pap smear, or you can do a liquid based cytology, and which is followed by the colposcopy. So colposcopy role comes into this triaging, or you can do HPV DNA, or you can do HPV DNA along with VIA. So there are multiple permutation combinations. So high risk HPV DNA along with colposcopy, or HPV DNA with cytology. So mix and match are done. So these are the different options that the WHO has suggested, that you as a doctor, you decide what is feasible in your setting, whether your setting is low resource setting, yeah. So whether your setting is low resource setting or good setting. So this is the question that as a doctor we should ask ourselves: do you presently screen for cytology? If the answer is yes, then can your hospital or patient afford an HPV? So that is screening is with cytology, that is the first test, and then you do the HPV, whether you can your hospital can afford or not afford. Now the WHO has very specifically said there are only two special tests. One is the HPV DNA, which is they are aggressively recommending to do. So so all the hospitals now, we should consider ourselves as a high resource setting, not low resource setting, and all of us should do this HPV testing. And if the HPV screen is positive, that means the HPV test comes positive, then the patient goes for colposcopy, or you can go for the biopsy, depending upon whether you have the colposcope or you don't have the so this is the basic, very simple setting that is to be done. So if you are not doing cytology, so if you are not doing pap smear, so what can we do in your patients? You can just do a cervical swab, or the patient can do a self sampling also is allowed. So these two, and you send it for HPV DNA. So that is what is recommended, or you do the HPV genotyping. So these are the different ways of doing the same thing: screen, triage, treat. Screen, triage, treat. Now there are two different group of patients. One is the general population group, where you can do this testing every 5 years if it is negative. And if the patients are from the immunocompromised, that the patient is having HIV, then all this testing, if it is negative, you have to do it every 3 yearly. So that is the difference. So if you understand these two slides, rest of the slides that are there are the same permutation and combination. So what I have done is these all slides are available by the FOXI guideline. There are two important guidelines that you all should see. One is the GCPR guideline of 2018 regarding the screening of the patients, from where I have taken these slides, and the second is the just June 2024 they have released another guideline, which I will show you later on. So these are the different guidelines that are available. So there are different charts available. So don't get confused with so many jargon things or what is given. So what I have told you is only those simple two things that you have to remember. पहिल्या काय स्क्रीनिंग करायचं, एकतर HPV करायचं किंवा VIA करायचं, आणि त्याच्यानंतर मग सेकंड लाईन ऑफ स्क्रीनिंगच्या ज्या आपल्या टेस्ट आहेत, पॅप स्मिअर, सायटॉलॉजी, दोज आर द सेकंड लाईन. सो दीज टू इम्पॉर्टंट इफ यू रिमेंबर, अँड देन यू फॉलो अकॉर्डिंग टू दॅट. म्हणजे पॉझिटिव्ह आलं तर काय करायचं, निगेटिव्ह आलं काय, एव्हरीथिंग इज व्हेरी प्रॉपरली गिवन इन दिस स्लाइड्स. I cannot cover everything in a 15 minutes presentation, so I will have to run through all these slides. What I would like to come now is on the vaccination part. So in the vaccination part, we have the HPV vaccine that is available. with us. We all know about the role of vaccine. So what this vaccine does is there's something called as virus-like particles. So virus-like particle, there is a something called as capsid, that is a protein on the HPV virus capsule. So against the L1 part of the virus, the antibodies are prepared. So now these antibodies are prepared. This L1 protein is prepared, and this is injected on the deltoid muscle, and the body prepares the antibodies against that. This is the principle of this. All the vaccines that are available, there are different vaccines available. There are 4 that are available. So what in India now recently, because our country has gone for the made in India approach. So Cervical is the vaccine that is available, and we have started this program of vaccination in our medical college in coordination with the Serum Institute of India. So for the age of vaccination, we all know the target group is 9 to 14. So you have to give 2 doses, and if the girl is more than 14 years of age, then you have to give the 3 doses. So the dosing schedule is 06 or 026. Very easy to remember. This is the dosing schedule that you have to remember. Administration is into the deltoid muscle. You have to keep the patient in the OPD for 15 minutes after the injection is given. Not much of the major side effects that we have seen. Only thing is to if you're using a multi-dose vial, within 6 hours the vaccine has to be used. Otherwise, you have to discard the vial. So multi-dose vial should be preferably not used. Then in pregnancy, it is not to be used. Lactation, you can use it. There is no problem. So these are the advantages. It's an Indian made cheap vaccine. All boys also should be given. So the Fox is only focusing more on the girls. So I think the boys also should be contributing to that. And 9 to 26 years is the recommended age for this vaccine for the boys also. And we have to promote both girls and boys for the vaccination, but the WHO is more focused on giving it to the girls. So these are the, if you compare, these are the different four types of vaccines that are available. One is by the GSK, 2 are by the MSD, and the last one is the Cervavac. So we were previously using the Gardasil 4 and Cervarix. Now the nonavalent, the Gardasil 9 is available. I think Gardasil 4 has gradually been withdrawn. It is available, but supply problem is there. But Cervavac is available, quadrivalent vaccine. So as I discussed, 6, 11, 16 and 18 are the antigens that this works on this vaccine. So Cervavac is what we are supposed to use because of the price. So if you see the comparative price, the price difference is very high. I think we are giving around 1200 rupees for the patient. So even in a medical college, if the patients are sent, so they get around 1200 for a single shot. So 2 shots around 2400 to 2500 is the current scene. So maybe over a period of time, as the usage of this vaccine will improve, the price may come down. So there are different recommendations, the same recommendations that we have discussed regarding the vaccination. Nothing much to be discussed regarding that. Now suppose we have given one vaccine of one, and then the patient does not, the vaccine is not available. So can you give the other vaccine from the other brand? It is allowed nowadays. And if the patient gets pregnant after one vaccine, the second shot द्यायचा की नाही, high confusion असतो. So now the recommendation is that you can actually give the vaccine. So it is slightly controversial, but you can give the vaccine for the second dose in pregnancy also. So that is what the newer guidelines say, that you can actually give it during a pregnancy also. So that is a slight different thing that has happened. HIV positive असेल तर vaccine द्यायचं का, तर vaccine द्यायचं, ते त्याचं उत्तर आहे. So that is very important. Single dose of vaccination, if the patient comes out of this age group, can you give the vaccine? You can give the vaccine, there is no problem. Sometimes even a single shot of vaccination is also given. So multiple permutation combinations have come now, so you can give. So आला patient की vaccine द्या. एवढं माझ्या लक्षात आलं की बाकीचं सगळं कन्फ्युजिंग गाईडलाईन आहे. पेशंट आला की वॅक्सिन देऊन टाका ॲटलीस्ट यू सो अँड बिकॉज वाय इट इज इम्पॉर्टंट बिकॉज द गाईडलाईन्स आर सपोर्टिंग अस सो यू विल मे नॉट बिकम रॉंग यू हॅव गिविंग द वॅक्सिन. सो लॉट ऑफ फिअर फ्रॉम द डॉक्टर साईड ऑल्सो टू गिव्ह वॅक्सिन द्यायचं की नाही बिकॉज एव्हरीबडी विल कॉल यू अँड वॅक्सिन देऊ का माझ्या मुलीला देऊ का डॉक्टरांच्या मुलीला ते दे विल आस्क यू 10 टाइम्स मग दिलं तर साईड इफेक्ट होईल का काही होत नाही देऊन टाकायचं. इट वॉज समथिंग लाईक द सेम विथ अवर कोविड वॅक्सिन स्टार्टिंग लॉट ऑफ negativism was there but people approved and we have seen the results of the vaccine over a third wave and fourth wave generally has gone down. So HPV vaccine, I would suggest all of you should take it to give all patient, all your candidates coming to your OPD. So screening, when to screen again, this is just to take home message what I would say age of screening. Now again here this is controversial, some people say 25 years, some people say 30 years. कुठे स्क्रीन करायचं तर फॉक्सी आपल्याला काय सांगतं ते ऐकायचं. आपल्याला 25 सांगितलेलं आहे. सो गुड रिसोर्स सेटिंगमध्ये 25ला करा, तुमचं सेटिंग पुअर असेल तर 30ला करा. तर आपलं सगळ्यांचं गुडच आहे असं अज्युम करायचं, नसलं तरी त्याला गुड करायचं आणि 25पासून स्क्रीन करायचं. सो ॲज अर्ली ॲज पॉसिबल स्क्रीनिंग बिकॉज इफ यू सी अमेरिकन गाईडलाईन्स 21 इयर्सला स्क्रीनिंग चालू करा. सम विल से आफ्टर द पेशंट द गर्ल्स हॅविंग सेक्शुअल ॲक्टिव्हिटी आफ्टर ॲज अर्ली ॲज पॉसिबल. सम से आफ्टर 3 years आफ्टर स्टार्टिंग सेक्शुअल ॲक्टिव्हिटी. तर आपल्या इथं इफ यू सी द एज ऑफ मॅरेज 15-18 यंग एजमध्ये होतं. सो ॲज अर्ली ॲज पॉसिबल स्टार्ट स्क्रीनिंग. तसं काय तुम्हाला 25च्या आधी स्क्रीन केलं म्हणून कोण जेलमध्ये नाही टाकणार आहे, त्यामुळे घाबरायचं काही कारण नाही. ऑल पेशंट आला की स्क्रीन करा हे एवढं लक्षात ठेवा. HPV DNA सगळ्यांचं स्क्रीनिंगला पाठवा. व्हेरी चीप टेस्ट यू कॅन दे मेट्रोपॉलिस पॅथकाइंड लॅब दे डू दिस टेस्टिंग. आय एम नॉट प्रमोटिंग द लॅब बट आय एम टेलिंग यू. बट इफ यू बार्गेन विथ देम दे विल कम टू 500 rupees. दॅट इज वॉट आय रिअलाइज्ड. ते सांगताना 1800 रुपये सांगतात, 500 रुपयापर्यंत खाली येतात. आणि जनरल आपलं पॅथॉलॉजीमध्ये पण आता पॅप्समेअर पाठवलं इट इज कॉस्टिंग ऑन 500-600 rupees. सो इट इज नॉट दॅट बिग थिंग. सो जस्ट टेक अ स्वॅब. तुम्हाला याचं कंटाळा असेल तर स्टाफला सांगा, आपले सगळे सिस्टर नर्स आहेत त्यांच्याकडनं घ्या, पण ॲटलीस्ट सगळ्यांचे स्वॅब पाठवा. एवढं आजच्या लेक्चरमधनं घेऊन गेला तरी खूप झालं. सो स्क्रीन अँड ट्रीट अप्रोच हे मी मगाशी सांगितलं त्याप्रमाणे आहे की पेशंट आला की स्क्रीन करा आणि ॲब्लेजिव्ह ट्रीटमेंट असेल. मॅडम नंतर आपल्याला कॉल्पोस्कोपीमध्ये ते आपल्या डिस्कशनमध्ये येणारच आहे कसं ॲब्लेशन करायचं आहे, कुठले कुठले मेथड आहे. तर पेशंट आला की स्क्रीन करा आणि ट्रीट करा. ह्याचा डिसॲडव्हान्टेज काय आहे की जर तुम्ही क्रायोथेरपी यूज करताय ऑर यू युझिंग थर्मल ॲब्लेशन देन यू विल नॉट गेट द स्पेसिमेन फॉर HPR. So that is the problem. Now what WHO has very smartly done is that they have removed cytology as the first screening, if you remember, because cytology has failed over years for mass as a screening methodology, because you don't have those many technicians, those many people, pathologists to actually screen and report to you in in all for when you go for the whole population, because the load of patients is so high. So what WHO has thought out, this has been I think around 30-35 countries सगळ्यांचा रिसोर्स घेऊन तिथले एक्सपर्ट्स घेऊन त्यांनी ते ओपिनियन बनवलेलं आहे की HPV DNA नुसतं ते सॅम्पल घ्या आणि मशीनमध्ये टाका आणि दॅट सॅम्पल कॅन ट्रॅव्हल्स टू अदर एंड ऑफ द कंट्री अँड इवन यू त्यामुळे सॅम्पल पाठवल्यावर नंतर रिपोर्टिंग हे नंतर येतं. ते जसं आता आपल्या इथं सोलापूरमधलं सॅम्पल बॉम्बेमध्ये प्रोसेस होतं. So it takes 2 days time and come back. So in 2 days nowadays you can go to any part of the country. So because of our courier services also improved. So now HPV is the screening methodology that we all have to go. So from this lecture I want all of you to just remember that from tomorrow सगळ्या पेशंटचे HPV पाठवा आणि मॅडमना अपडेट करा, म्हणजे because that will be one big contribution that our society can start. And it can become a all other societies can take inspiration from us that we have started screening. So as I told you ki आपल्या gynecology मध्येच and this actually this question I had asked in when 10 years back, I think 2010-11 City Park मध्ये होती CME on pap smear. So that time also the same thing. आता पण 12 वर्षांनी it is the same thing. People are not ready. They will talk but they will not walk the talk. So that is the problem, that all of you should screen yourself first and then screen others. Vaccinate your family members first. Advertise that, promote that you yourself and your family has been advertising in your OPD. You can do that, and then the patients will start getting motivated to get vaccinated. So this is regarding vaccination and screening. I hope I have not confused much. Thank you so much.
Thank you, Dr. Vijay Pawar, for enlightening the whole crowd to start with the screening methods. I would like to add that in civil hospital, we are doing HPV testing. So if your patients are not affording, you can send them to the hospital. Thank you. Any questions?
Madam, sir.
For a lady who is coming to you at the age of 26, 27, because we know majority of the HPV tests will become positive if you do it before 30 years. Almost 80% women, they get infected with HPV, but that infection gets cleared on its own. So if you do the test and the test becomes positive, unnecessarily the anxiety of patient as well as you and unnecessary further investigation. HPV positive alay chala colposcopy kara, lesion diste jara treat kara. So unnecessary over treatment and everything will be there. So if you are doing an HPV testing or using HPV as a primary screening modality, start doing it after the age of 30 years. Thank you.
Immunity in young girls is very good, and that's the reason why the HPV can get washed out. So as you said, it should be done after the age of 30, that is recommended, and if it is done. And another thing that I wanted to highlight was the counseling of the patient before starting the screening test is very, very important. Because if it comes positive, because this is it has got cervical cancer has got a long period for a follow-up. If you do a screening today, maybe she at the age of 55, 65, you will stop the screening. That's another thing, when you will stop the screening. I think you should elaborate it. Yeah, now we have put the slide. But that's another thing. So the counseling becomes very, very important for the patient. Any screening, any further investigations that you are going to do, and the follow-up is mandatory. And we must keep a registry of our patients. Another thing that you said that in private people are not doing it, but it's not the fact. I think we are all doing HPV screening, we are doing LBC, and just wanted to give you input.
No, madam, no, what I mean to say is, if you see the number of cases that we are doing is very less. I am not saying we are not doing. What I was trying to tell is that all patients coming to our OPD, are we doing pap smear? Are we doing, see what slide I had shared was screen and treat approach. There are different methods of screening. So what WHO has done is for screening. Screening हे सगळ्यांसाठी आहे. It is not for high risk population. That's what like madam was saying is 30च्या वर करायचं आहे. So what is the definition of screening? PSM मधलं जर आपण definition बघितली, स्क्रीनिंग म्हणजे सगळ्यांचं स्क्रीनिंग करायचं आहे. हाय रिस्क पॉप्युलेशन विल बी नॉट बी अ स्क्रीनिंग पॉप्युलेशन. तर एज ग्रुप काय आहे, तर हा चालू होतो 25 पासून, मीन्स आफ्टर युअर सेक्शुअल ॲक्टिव्हिटी the HPV, the girls get exposed to the HPV virus. So when they are active sex, that's why these guidelines are varying in different. So what happens if I am following SOG guideline and practicing in India, तिकडे 21लाच करा म्हणतात. आता मॅडम म्हणतात कोल्हापूरला 30ला करा म्हणतात. आता फॉक्सीचं स्लाईड आहे, माझी स्लाईड नाही आहे. व्हॉट फॉक्सी इज सेइंग इज टार्गेट एज इज 25 to 65 and your modalities of testing is either visual VIA. They have not put pap smear as the testing. That's what I'm trying to tell you. Pap smear is now there. This is testing मध्ये, screening मध्ये दोनच टेस्ट त्यांनी सिंपल दिलेले आहेत. When the WHO puts it, they see that it is available everywhere. Now you say I will do cytology first, I will do HPV also, or I will do high risk genotyping of the HPV also. Very good. Your setting may be at a higher level. Like in our institute, we are not doing for all as only काय म्हणतात त्याला HPV for all patient. Possible होत नाही. नंतर किट संपून जातात चालू केलं की. So there is a lot of logistic issues. But how many patients are we screening from the OPD? That's what I was trying to make the point, that we are not still you are leading gynecologist, we all are
it's not a
following your
question, but I think it
hey,
would be a
but there
overstatement
are
if you
no
say
no no, I am
practice.
saying there are 200 gynecologists in this society. How many of them are doing? I am not saying there are 5 or 6 who are doing regularly, I don't deny that. Institute मध्ये होतं, पण institute मध्ये I also work. I know how many, if I am getting a 50 patients OPD, how many pap smears are going.
Anyway, it's
It
okay.
doesn't go.
But I want to ask another question to Dr.
So
Chairperson. In civil hospital you have this HPV testing. So may I know which methodology you are doing, and whether you are doing genotyping as well, because there are
No,
150
we are not doing
viruses.
genotyping. This is a study because we have been included in ICMR studies. So we get the kits, we take the samples and send it to the microbiology department.
Okay, which methodology?
Which methodologies I don't know about.
Any idea?
नाही नाही मला नाही माहित. Because what happens most of the times तिकडे ICMR has their own way of doing it, and they after the study will be over, the program will be wrapped up. So this is this is realistic talk. I am not talking about ideal things. What is happening realistically? मध्येच किट असते, मध्येच गायब होतं, मध्ये येतं, मध्ये ते येतं, सगळं होतं. दॅट इज वॉट हॅपन्स इन इंडिया. दॅट्स वाय दिस CA सर्विक्स, दॅट्स वॉट आय वॉज टेलिंग, की माझ्या रेसिडेन्सीपासून मी आत्तापर्यंत 20 वर्षात तिथंच अडकलेली आहे गाडी आपली.
So I am very happy that in India now the HPV screening is available even at the civil hospital
Yes.
and also in private, where we are getting even more information. Like there are about
Yes, 16 and
HPV viruses, out of which 16 and 18 are the most notorious.
Yes.
So they usually report whether she is positive for HPV 16 and 18, or there are other type of viruses. So
Yeah.
you know how to follow these patients up. Because
So
once it comes positive, it's very, very difficult to counsel the patient and follow them up.
It is like our triple marker and dual marker that we
Yes.
do. You do the dual marker, you don't counsel the patient, and patients come to our OPD to do MTP.
Yeah.
Just because they are high risk, in some 1 in 1000 risk आला तरी
HPV, but it should be
that is what happens, because we do half the thing. That's why anything you want to implement in your institute, see that you have the whole mechanism. ते निगेटिव्ह आलं तर काय करायचं आणि पॉझिटिव्ह आलं काय करायचं, आणि पेशंट शुड बी रेडी टू डू दॅट. दॅट्स वाय ते स्क्रीन आणि ट्रीट अप्रोच जो आहे तो दॅट इज फॉर लो रिसर्च सेटिंग, की तुम्ही पेशंटला केरलामध्ये व्हेरी इम्पॉर्टंट स्टडी त्याच्यापेक्षा चांगला, म्हणजे DNA नाही तर जस्ट लुकिंग ॲट द स्पेक्युलम एक्झामिनेशन. सो द डाऊन स्टेजिंग ऑफ द सर्वायकल कॅन्सर म्हणतात, त्याच्यामध्ये आपण द जस्ट व्हिज्युअल इन्स्पेक्शन ऑफ द सर्विक्स, नॉट बाय डॉक्टर्स. आशा वर्कर, सब सेंटरच्या वर्कर्सना त्यांना ते शिकवलं होतं, फक्त स्पेक्युलम करायचं, सर्विक्स त्यांना फक्त दाखवलेलं आहे, हे असं नॉर्मल दिसतं, हे ॲबनॉर्मल दिसतं. नॉर्मल काय ते बघायचं, नॉर्मल सोडून दुसरं काय दिसलं की त्याला रेफर करायचं, एवढंच शिकवलं होतं. आणि दॅट्स वाय केरला हॅज गॉन डाऊन. सो इट इज मोर ऑफ स्मार्ट थिंकिंग. आपण खूप महागड्या गोष्टी, मॅडम येस.
Since the TVS has come, so what you want to HPV detection, cytology, what first start everyone.
मॅडम हां स्पेक्युलम एक्झामिनेशनचं पण मी एक साधं सिम्पल सांगतो. सगळ्यांच्या OPDमध्ये किती स्पेक्युलम असतात तुम्ही मला नका सांगू, फक्त तुम्ही बघा किती स्पेक्युलम असतात आणि तुमची OPD किती असते. तुम्ही हाऊ मेनी स्पेक्युलम एक्झामिनेशन्स यू डू, तुम्ही तेवढे करता का? म्हणजे ऑन अँड एव्हरेज आता रिअलिस्टिकली 5 ते 10 स्पेक्युलम असतील सगळ्यांच्या OPDमध्ये, आणि OPD आपली 50-100ची असते लिडिंग गायनेकॉलॉजिस्टच्या सगळ्यांच्या. माझी नाही आहे पण बाकीच्यांच्या आहे. तर सो म्हणजे बेसिक गोष्ट आहे, आपण ते ऑटोक्लेव करून वापरतो का नुसतं हाऊ युअर स्टरलायझिंग द इन्स्ट्रुमेंट्स, म्हणजे जे स्टरलायझेशन पण होत नाहीत, मग त्यामुळे वी डोंट यूज इट. सो वी डोंट हॅव दॅट मेकॅनिझम ऑफ लाईक वॉट मॅडम वॉज सेईंग ना, ते वाय पीपल हॅव शिफ्टेड टू TVS. हे सगळं त्याच्या मागचे जे लॉजिस्टिक आहे, धुणं भांडी करायचं, स्टरलायझेशन करा, ऑटोक्लेव करा, हे होत नाही पॉसिबल. सो दॅट इज द बिगेस्ट प्रॉब्लेम. या बट ऑल कम्स डाऊन मॅडम टू कॉस्ट. आपली OPDची फी 200 रुपये असते, तर 100 रुपयाचा डिस्पोजेबल वापरत नाहीत लोक. That's what I'm telling you. We have to change our mindset first. That is the only problem. Now this downstaging what I spoke, speculum madam जे बोलला, हे म्हणजे माझ्या पी जीला क्वेश्चन आलेला आहे म्हणजे 2004मध्ये डाऊन स्टेजिंग ऑफ सी ए सर्विक्सवर आम्ही त्यावेळेस ते असं पाठ करून ठेवायचं की असं आलं की हे सांगायचं की मार्क्स पाहिजे असतात तेव्हा यू वॉन्ट टू स्कोर देअर बट आफ्टर दॅट इट इज वी ऑल रॉयली फॉरगेट and don't do it in practice. So that is what happens. So simple, that's why people come with this testing, no, HPV DNA करा आणि सेल्फ सॅम्पलिंग करा. आता सेल्फ सॅम्पलिंगचं तर एवढं फॅन्सी ॲपरेटस आहे, ते डेल्फी ॲपरेटस आहे विच इज अवेलेबल. US मध्ये काही पण चालतंय असं एकदम हाय फाय. आता काय mRNA टेस्टिंग आहे फॉर दी HPV व्हायरस दॅट हॅज कम. सो कॉस्टली ते त्याची टेस्टची किंमत ऐकूनच आपल्याला चक्कर येते. ते कधी म्हणजे इम्प्लिमेंट पण होणार नाही. बट देर इज अ सेमिनार, त्याच्यावर एक लेक्चर 1 तासाचं लेक्चर होतं बिकॉज तेवढं महागड्या गोष्टीवर पैसे कंपनी स्पॉन्सरिंग. बट हे सिम्पल थिंग्स लाईक व्हिज्युअल इन्स्पेक्शन ऑफ द सर्विक्स व्हेरी इम्पॉर्टंट वी डोंट डू. कॉल्पोस्कोप पण मला वाटतं मॅडम इज गोइंग टू टेक बट यू आस्क हाऊ मेनी कॉल्पोस्कोप द आउट ऑफ 200 गायनेकोलॉजिस्ट आय डोंट हॅव. I am honest on that, but not many people do even do colposcopy with us. So that is the problem that the logistical and realistic problems are different. The guidelines come in different. Like madam is saying 30, I totally agree with you, but the but स्क्रीनिंग देताना त्यांनी सांगितलेलं आहे की आता तुम्ही स्क्रीन कधी करायचं वेन यू स्टार्ट सेक्शुअल ॲक्टिव्हिटी. इफ द लेडी इज स्टार्टिंग ॲट 18 सो शुड यू वेट टिल 30. नो yeah but we that's what we are getting patients early in by 30 also we are getting cancer patients असं नाही आहे. so yes yeah that is the peak madam but what I mean to say is that screen and treat approach जो आहे ना सगळ्या पेशंटचं स्क्रीनिंग करा म्हणजे स्पेक्युलम एक्झामिनेशन तरी करा. HPV फार लांब राहिलं करायचं की नाही आपल्याकडे ते पहिले टेस्ट अफोर्डिंगच होत नाही पण स्पेक्युलम एक्झामिनेशन प्लीज करा. ते सगळ्या पेशंटचं स्पेक्युलम बघा आणि जे हाय रिस्क आहे त्यांना मग देन यू कॅन डू वॉट एव्हर मेथड यू वॉन्ट टू यूज. यू डोंट वॉन्ट टू गिव्ह HPV fair enough, do cytology, fair enough. You want to club with high risk HPV screening, do that, but do some screening. And first important, vaccinate yourself and screen yourself first. That is my take home message. Thank you.
Thank you, Dr. Vijay, for bombarding everybody.
Sorry, it has been a long interactive session, but I want to just continue. Screening for any cancer in India is less than 1%.
Yes.
If we compare with breast, which is almost 60 to 70%, so we are way behind in screening, and we know out of all of us how many we have screened ourselves or our parents. So yes, we need to catch up a lot. So my question here is for this HPV vaccination, like what is the intent of HPV vaccination? To prevent invasive cervical cancer. Am I correct? Now, out of say 100 HPV infections, as ma'am rightly said, how many gets into the chronic HPV infection? Less than 10%? Out of this chronic HPV infection, CIN1 less than 10%, CIN1 to CIN2 less than 10%, CIN2 to CIN3 again 10%, and CIN3 to invasive cervical cancer less than 10%. So to prevent one invasive cervical cancer, how many HPV vaccination we are thinking of?
I think you are talking about number needed to treat.
No.
So like something like that.
To prevent one invasive cervical cancer, how many females we need to vaccinate?
No.
More than 1 lakh.
Like yeah.
More than 1 lakh. So, and whatever data we have about HPV vaccination, that data is for seroconversion. So you do HPV vaccination, you prevent chronic HPV infection. But to prevent, after preventing that chronic HPV infection, how many cervical cancers you have prevented? Do we have that data?
See, that's what what we have to remember is that there will be no realistic data available anywhere for the next 100 years. Let's be realistic. In India, म्हणजे मला माझ्या हॉस्पिटलचा डेटा काढायचा म्हटलं तरी शक्य नाही आहे. So this is not going to happen. So what these all theoretical PSM discussions will happen. On the ground, what we can do, You have vaccination, you have screening.
I know
So
there are
screening, you have to do
guidelines.
all
I have
screening.
my own reservations.
Vaccinated. She needs to be screened.
Yes, yes. So yeah, that is important. Like Madam pointed out, vaccination is a different concept. Screening is different concept. Screening is for all women. So all women should be screened for as far as CS cervix is concerned. For male, it will be different malignancies. But screening, as such, like sir said, we are very poor in screening. Even आपल्या इथं आपण आता आपल्या स्वतःचे stress test करत नाही. So what the point was, you first do it yourself and then you walk the talk जे आपण म्हणतो. So you first do it yourself, then you screen yourself for whatever you are doing in the hospital for screening patient. Have you done it for yourself?
I think we will move on to the next lecture. We can have the discussion later on. Thank you, Dr. Vijay. I invite the next speaker, Dr. Bharti Madam. She is a consultant at Purva Hospital. She is neck deep into colposcopy. She was vice president at SOGS 24-25. She has worked as a chairperson on the preventive oncology committee. She has presented many chapters in various books, and she has also published a book in Marathi, that is a vernacular language.
Yeah, that is Sakshamami
Yes.
Bhakkamami. So thank you, Vidya. No need of a detailed introduction, I think.
I now invite Dr. Bharti for a next lecture.
Thank you very much, and very good morning to all of you. My respected teacher, Dr. Sardesai Madam, who has told or taught us how any work should be done with sincerity, meticulousness, and still becoming happy. So that is what we learned from Madam. And my second teacher, Dr. Rohini Deshpande, she is my mentor and guide in AMOX. She literally made me to work in AMOX, and she had taken a lot of efforts for that. She was constantly behind me, do this, do that, do all workshops and everything. Thank you so much, Rohini, and thank you very much more for pushing me in AMOX. So today, I must thank Dr. Amruta and Dr. Neeta also. Dr. Amruta was always behind me, Madam Kadhi Yeta, for last, I think, 4-5 months. She is constantly asking me, Kadhi Geuya. So I said, anytime you call, because it is my home front and I'm always happy to be in Solapur. The topic given today is quite vast. It's difficult to cover in very short time, but still I will first deal with a colposcopy, unless and until you will not able to understand what this CIN business is. Before proceeding to the talk, I will like to salute these 3 champions of, it's not visible there, slides. 3 champions in cervical cancer field. First one we all know, it is Papi Nicolas. We have heard about now the pap smear and everything. Second one is a father of colposcopy, Hans Hinselmann. He has invented the colposcope. And third one is a Nobel Prize winner, and he is Harold Zurhausen, who invented HPV vaccine, HPV virus, and the team got Nobel Prize for that invention. So coming to colposcopy, colposcopy is not only see the cervix, but you have to see the vagina, you have to see the vulva and perineum, and not only see, but when you suspect any abnormal thing, you have to take a colposcopy guided biopsies also. So this is what colposcopy is. It's a magnified image you get on the screen. And that's why any abnormal area is very nicely highlighted. And nowadays, there is no role of punch biopsies of the cervix. In our student days or in our residency, we used to take a punch biopsy. But now they say the biopsy should be colposcopically guided, because it's very precise area that you can take a biopsy from. This is how the video colposcopy is. It's very handy, very user-friendly once you learn the technique of colposcopy. So the colposcopy detects abnormal epithelium, identifies the area of highest abnormality, and you can take a biopsy from that abnormal area. There are a lot of benefits of colposcopy because it's a basically non-invasive technique. Anesthesia is not needed. You can do it in a OPD. If you just master the technique, you can do it in 10 to 15 minutes. And very important is you can take the biopsies, as I told you. And when you have treated the patient of CIN, then how to follow the patient. So in that cases also you have to do a biopsy. This is called as a test of cure. Say after 1 year or 2 years, you call the patient again and do the colposcopy to see the lesion which you have treated has been cured or not. Though, what are the indications? The book indications are mainly any abnormal cytology. So what is abnormal cytology? Normal cytology report will come as NILM, that is negative for intraepithelial lesion for malignancy. The abnormal will be like ASCUS, ASCH, there may be glandular abnormalities, so on and so forth. So any abnormal cytology report, that candidate will be for colposcopy. And just now we have heard Dr. Pawar saying that HPV, now it has become a primary screening modality. So any abnormal or positive HPV test candidate will be for colposcopy. These are the book indications. But in our OPD, the patients come with many complaints like postcoital bleeding, metrorrhagia, that is intermenstrual bleeding, spotting, lower abdominal pain, chronic pelvic inflammation. All these candidates are for colposcopy, and to achieve or have a good practice of colposcopy, go on doing the colposcopy in all these patients. Don't wait for the smear to become abnormal, or don't wait for her to become HPV positive. So these are the indications for colposcopy. Another is as I told you, women with anogenital condylomas or warts at vulva, vagina, these are also again patients or women for colposcopy. Another important is pap smear, as we have seen. Many times the cytologists report it as an inflammatory smear and repeat the smear after treatment. We treat the patient, we treat the husband, and after some time we again repeat the smear. Again the cytologists say it is again an inflammatory smear. So persistent of inflammatory smear, you have to do colposcopy to look for what is the cause of that persistence of inflammation. So the procedure is very easy, and we all are very well versed with taking consent for each and everything. So for colposcopy also you need to have a consent in the local language, and that consent should include the consent for biopsy. Because why we are doing colposcopy? To see an abnormal epithelium, and if we to see any abnormality, we have to take a biopsy. So in that consent only you take a biopsy. Learn the art of putting a Cusco speculum, that is very important. Because many I see during my colposcopy training students, they just take 10 to 15 minutes to insert the Cusco speculum and have a proper view of the cervix. So start, as Dr. Pawar said, start doing, and madam is constantly saying, start doing speculum examination for each and every gynec patient that comes into your OPD. असंच आता ह्याच्यामध्ये आलं आहे म्हणून सांगते, प्रेग्नंट पेशंट्स दे शुड नॉट बी स्क्रीन्ड. इनिशियली इट वॉज दॅट की प्रेग्नंट पेशंट्स शुड ऑल्सो अंडरगो सायटॉलॉजी, बट नाव द गाईडलाईन्स से डोंट स्क्रीन द प्रेग्नंट पेशंट अनलेस अँड अंटिल शी इज हॅव्हिंग repeated or many symptoms. So don't put a speculum in pregnant patient unless and until it is indicated. So you have now seen the cervix. You clean the cervix with normal saline. The picture becomes very easy. This is the first step of colposcopy. There are only 3 steps of colposcopy. So cleaning with normal saline, visualize the cervix, document your findings. That is the very much advantage of these video colposcopes. It's very handy. You can just see and document the finding. Next step is apply the green filter. All these arrangements are there on the colposcope. Apply green filter. It makes visualization of blood vessels very easy. This is first step is over. Then second step is application of acetic acid. So the acetic acid may be 5% to 3%. Preparation of acetic acid is very important. You have to use a freshly prepared acetic acid daily. Ask your sister to prepare the acid every day, and at the end of the day, whatever the acid is remaining, just throw it out. Next day again prepare it freshly, because the results will be very good when we use a freshly prepared acetic acid. So apply thoroughly, liberally the acetic acid for entire 1 minute and then see what are the changes that are happening on the cervix. So this is the second step of colposcopy, application of acetic acid. Third step is apply Lugol's iodine. It's ready-made, no need to prepare the Lugol's iodine. Apply Lugol's iodine and again see the changes, what are happening on the cervix, and always document the findings. What happens many times we forget to document the finding. करत राहतो आपण हा ॲसिटिक अरे आहे इथे, पण तिथे इमेज घ्यायची आपल्या लक्षात राहत नाही. So train your sister to stand with the laptop and you just ask her to take a image every time you want to have a documentation. So first, saline is helpful in studying the subepithelial vascular architecture, and this is used to visualize mainly the vessels. So with normal saline, everything becomes very clear. So what are we going to do or look in during colposcopy? Mainly is the transformation zone. This is the most important part for the colposcopist, to learn how to identify or how to define the transformation zone. Transformation zone is an area in between the new squamocolumnar junction and the original squamocolumnar junction. I won't go into detail of what is new and what is old, but just remember T's head, we call it as, it's the most happening zone on the cervix, and this is the area where most of the malignant, pre-malignant changes, they start taking place. So one should be well versed with identifying this transformation zone. So normal saline makes our job easy of identification. The columnar epithelium gives its grape-like appearance, and there may be certain changes like large branching vessels, then tree pattern vessels, parallel running vessels. All these indicates the metaplasia. This is how you look the picture after normal saline. This is before normal saline, and this is after cleaning. See the difference, how the junction, or I mean new squamocolumnar junction, is very clearly identifiable in this picture rather than in this picture. So normal saline helps. You can see the vessels very nicely. This is a green filter effect. Then second test is acetic acid. What happens with acetic acid? Why to apply? We know the squamous epithelium is a multi-layered, basal, parabasal, intermediate, superficial layers, and we know the size of the nucleus goes on decreasing as we go from base to superficial layers. So what happens? This acetic acid, the nuclear contains the cytokeratins, they take up this acetic acid. Whenever the cells are abnormal, there is a higher nuclear content, the size of nucleus is more, so naturally the acid taken will be much more. The area will become white, the light won't pass through it, and that's why the area becomes acetoid. This is the simple principle of acetic acid test. As I said, you have to apply it for 1 minute completely. The squamous epithelium will look pale with reduced translucency. SCJ will become more prominent. Columnar epithelium will less dark. Squamous metaplasia will turn mildly white, patchy, and this is again a confusing area for the colposcopist. The white faint area is there. So is it abnormal or is it normal? That we will discuss afterwards. And the mature metaplasia will resemble squamous epithelium, except there will be a Nabatean cyst or Nabatean follicles. Third test is application of Lugol's iodine. What happens? Lugol's iodine is glycophilic. So the cells which are rich in glycogen, we know the squamous epithelium is rich in glycogen, so it will take up the iodine and stain brown, mahogany brown color. The columnar epithelium lacks this, and so it will not stain, but the abnormal epithelium again will remain unstained. It will not take up the iodine, and it helps as a second or as a triage, I can say, for the acetic acid test which was positive. If that area remains unstained, then you are sure that this is some abnormal area. This is how the cervix looks after iodine application. This is squamous epithelium, yellow arrow, and the green arrow is a columnar epithelium. So you have done 3 steps. At the end, you see whether the colposcopy is satisfactory or it is unsatisfactory. What is satisfactory means you are able to see the original and the newer squamocolumnar junction very clearly in 360 degrees. Whether the colposcopy is normal or it is abnormal, and if it is abnormal, whether it is a low-grade abnormality or high-grade abnormality. So one point I want to stress here is, don't give your diagnosis as a CIN1, CIN2 after performing colposcopy. because it is the duty of the pathologist to comment whether it is a SIN 1 or SIN 2, because it is a histological diagnosis. If you submit the biopsy to the pathologist, then only he can comment about whether it is SIN 1 or SIN 2 or like that. So the colposcopist is supposed to comment as whether the lesion is a low-grade lesion or it is a high-grade lesion. What is unsatisfactory colposcopy? When you are not able to see the TZ or squamocolumnar junctions completely, you are not able to see the cervix. Nowadays, we know the incidence of cesarean section is on high. So in these patients, visualization of transformation zone becomes quite difficult. The cervix is pulled up, the cervix is high up. In that case also, if the patient is very sensitive, she will panic when you put the cusco-speculum. All these cases are of unsatisfactory colposcopy. You have to explain the patient and then do the colposcopy. So this is the format of how systematically you should go on doing the colposcopy. 3 steps we have done. Then you assess entire cervix by general assessment, whether it was adequate, SCJ was visible, and define the TZ. Now the transformation zone is of 3 types, type 1, type 2, and type 3. Type 1, obviously, it's on the ectocervix. You are very clearly able to see the transformation zone entirely. In type 2, part of the transformation zone is inside the endocervical canal, but you are able to see or define the TZ completely. But in type 3, majority or most of the TZ is inside the endocervical canal, and here you may face difficulty in seeing the TZ completely. You have to insert the endocervical speculum, open the endocervical canal, and look for the upper limit or the entire transformation zone. And usually in postmenopausal patient, this gives a problem of because there is a receding atrophy and you are not able to see the transformation zone. In these patients, you have to give estrogen cream before performing colposcopy. So you have done the general assessment, the colposcopy. If it is final, very good. It's normal, it's very good. If it is abnormal, then there are certain principles that should be followed, and the scoring system is also there that we will see step by step. In 2011, the International Federation of Colposcopy and Cervical Pathology have given a nomenclature of everything, what terms should be used when you are doing a colposcopy or when you are reporting the colposcopy. Only thing changes, instead of adequate and inadequate, now the term satisfactory and unsatisfactory has been replaced. Rest of the things are very same. So coming to abnormal colposcopic findings, we have to apply general principles. So what are these general principles? You are seeing the cervix, this colposcopy, we can call it as an adequate colposcopy because I am able to see the newer squamocolumnar junction. Somewhere here you can appreciate the color difference. This is the original SCJ, and the area in between is a transformation zone. So this is a type 1 transformation zone, and I will document my findings like this. So what are these general principles? These are mainly to document your or describe your abnormal colposcopic findings. So what are these? Basically the aceto-white area. So any aceto-white area, when you see, you have to consider 4 points for that. First is the location, second one is size. So in location also you have to describe it in a clockwise fashion and in a quadrant wise, in the relation to transformation zone, whether the aceto-white area is in the transformation zone or away from the transformation zone. Then size of the abnormality must be defined by number of cervical quadrants that the lesion occupies and also in relation to percentage of the cervix. So coming to location of the aceto-white area, whether the lesion is in the aceto-white area or it is not in the aceto-white area, for that you have to define the TZ completely. Most of the high-grade lesions, they are located in the transformation zones. Sometimes subclinical infections by HPV are there. They may be away from the transformation zone or away from the squamocolumnar junction. These are called as a satellite lesions. They also must be looked for. Many times there are multiple lesions inside and outside, but the lesion which is in the transformation zone is of significance. Then coming to the size of the lesion, again the number of quadrants the cervix covered by the abnormality should be considered. for this, I will show this diagram. The cervix is divided in 4 quadrants, and you can very well see the abnormal area, the acetowhiteness is in almost 3 quadrants. So you have to mention the thing like occupying 3 quadrants of the cervix, and whether it is 25%, between 25 to 50%, 50 to 75, and more than 75% of the cervix is occupied by the abnormality. So this is how the abnormal or acetohyte area that we have drawn picture here. It looks actually on colposcopy like this. You have see the clock is there. So the lesion, I can describe it from say 5 o'clock to 9 o'clock, again one more lesion from 10 to 11 o'clock, and almost 50% of the cervix has been occupied by this abnormal epithelium. So the abnormal colposcopic findings that are categorized mainly into grade 1 and grade 2. Grade 1 is a minor grade and grade 2 is a major grade. So these nomenclatures have made our job very easy. Either it is a low grade or a high grade, and depending upon that the management of the patient also is decided. So these gradations, they take into consideration the acetohyte changes, blood vessel patterns if there are any, and changes after the application of Lugol's iodine. But remember, acetohyteness is the key or very important finding for the changes to be observed and to be documented. Grade 1 changes, they usually suggest benign conditions. We call it as a low-grade lesions. They may correspond to SIN 1 on histology. So initially when you are doing colposcopy, to be sure that the lesion is a low grade, you have to take a biopsy and then confirm your findings whether it was really a low-grade lesion. So grade 1 or minor lesions, we can call it as, it is a thin acetohyte area that is very indistinct, it is transparent, it is patchy, and it may be again due to not only low-grade infection, but it may be because of inflammation, it may be because of immature metaplasia also. So we have to keep in mind what it may be, and you have to see the acetohyte area accordingly. So irregular geographic border is again another sign of a low-grade lesion, and this is here you can see a thin acetohyte epithelium with an geographic border. So this is, even if it is occupying almost 3 quadrants of the cervix, when at the end when you do a SWIT scoring system, it will come less and it will become as a low grade. So this SWIT score helps us a lot in coming to diagnosis. What happens initially when if I see this picture, I will feel, Aricha, kevda acetohyte area hai. Definitely it's something abnormal. But no, you start documenting, you start calculating the score, and then you will realize, Aricha, this is only a low-grade type of lesion, and what should be done, I will tell you afterwards. This is again a grade 1 or minor type of lesion. Here, the punctations, that is a vascular pattern, it's not clearly identifiable. But remember, presence of fine punctation, fine mosaic indicates a low grade or grade 1 lesion. Coming to grade 2, I am running fast, just let me know when the time is over, because the colposcopy is very dear to me. I will go on talking like anything. So coming to grade 2 lesions, it's a high grade lesion. Dense acetohyte epithelium, which is very distinctly dense, you cannot miss it. It is called as an opaque white area, and the criteria are same. The lesion should be in the transformation zone. It may touch the new squamocolumnar junction. And another important point for these grade 2 lesions is that these lesions, they appear very fast. When you are applying the acetic acid, at that time only you start seeing the acetohyte areas on the cervix. So rapid appearance of any lesion, and they persist. You have completed 1 minute, you are looking for any other abnormality, the lesion is there. So rapid appearance and persistence of the infection indicates the higher grade or grade 2 abnormality or a major change, major abnormality we can say. Another important findings in grade 2 is a presence of cuffed or crypt opening. What is this cuffed or crypt opening? These are nothing but the glands. We know that there are glands in the stroma. So what happens? A normal crypt opening appears as a black dot that is surrounded by a white rim. But any abnormally or enlarged crypt opening will look like a donut. the center and the periphery. The peripheral rim will also be very thick, and that crypt opening is very prominent. What does it indicate? That the abnormality or the infection has reached down up to the level of crypts, because crypts are not in the epithelium, but they are in the stroma. So your lesion has reached deep up to the stroma, and this cuffed crypt openings, they indicate a high grade lesion. Again, the presence of coarse mosaic. So mosaic, punctation, all these are vascular patterns. So whenever the vascularity is increased, these vessel patterns will be depicted on the cervix during colposcopy, and presence of coarse mosaicism is again a grade 2. So grade 2, we know coarse punctation, sharp border of the lesion. Then there are other signs like inner border sign, ridge sign, rack sign, like that. So inner border sign is usually called as a lesion in lesion. There is a one high grade lesion, and inside that there is some low grade lesion also. So these are again few points for the lesion to be a major or a grade 2 type of lesion. Here you can see a dense aceto-white epithelium. We can call it as an oyster white or a grayish white area. Again, the lesion appeared very fast and persisted for a long time. In this picture, you can see the yellow arrow. This is showing a donut-like crypt opening, and that indicates that there is a high-grade lesion. Again, presence of coarse mosaicism, it's very nicely appreciated. So it's a grade 2 or a major change on the lesion. Here, look for the borders. The borders are very sharp and clearly defined. You can make out the lesion from rest of the cervix very clearly, and the color is also oyster white. So this is third time inner border sign, that is a low grade lesion and a high grade lesion seeing together, lesion within a lesion. This is a ridge sign. The aceto-white area is slightly elevated, it is thick. Again, it indicates a grade 2 or major. This is a rag sign. What is this? The cervix, we know it's very friable. Whenever you are applying acid and the area is abnormal, that thing gets, when you are cleaning it, and it gives an ulceration on the cervix. That is called as a rag sign. And one important thing which we commonly describe is erosion. Whenever we see the erosion on the cervix. So now that erosion terminology is not there, we should call it as an ectopy. Whenever we see, when we used to call it as an erosion, but erosion is something abnormal. Whenever the area is easily, you can remove it very easily. At that time, you call it as an erosion. But normally when we see it on the cervix, you call it as an ectopy. So make it a habit to change your terminologies also. This is again grade 1 picture, before acetic acid, after acetic acid, the picture is very clear. Grade 2, again, you can see the aceto-white areas all over the cervix. This is a grade 3, it was there in the past, but nowadays only 2 grades are there. So you can call this as an high grade type of lesion. So changes suspicious of invasion are again vascular. Atypical vessels, fragile vessels, irregular surface, exophytic lesion, ulceration or necrosis, and presence of a gross neoplasm is there. So at the end, you have to calculate the score. This is called as a SWID score. Initially, there were many scores like Reed's colposcopic, modified Reed's, Nelson score, everything was there. They used to take into consideration 3 points, 4 points, 5 points. But now this SWID score, it takes into consideration 5 points, and what are those? This is aceto uptake, margins of the lesion, vessels, and size of the lesion, and iodine uptake. So iodine uptake is very important. Unless and until you have applied iodine, you cannot do the SWID scoring system. So they have given points for that. If the aceto uptake is very transparent or it is not there, you give it 0. If it is very thin or milky, 1 point for that. And if it is very distinct, you cannot miss it, it is 2 points for aceto uptake. Then you define the margins of the lesion. If they are very diffused, 0 point. If the margins are very sharp but irregular, geographic borders we have seen, you give 1 point for that. And if it is very sharp and there is a surface demarcation from the lesion, then definitely it is a 2 points for that. Presence of vessels, fine punctation, fine mosaic, many times we see highly vascular cervix. In those cases, the score given is 0. If the vessels are absent, you give 1 score for that. And if the vessels are coarse, like coarse punctation, mosaic, or any atypical vessel which is having a wide bore, at that time you give 2 score for that. Size of the lesion, if it is less than 5 millimeter, 0. If it is 5 to 15 millimeter or occupying 2 quadrants of the cervix, you give 1 point for that. And if the lesion is more than 15 millimeter or occupying 2-3 quadrants on the cervix and the lesion is extending into the endocervical canal, you give 2 points for that. And regarding iodine uptake, if it is taken up iodine, it has stained brown, 0 points. If the iodine uptake is patchy or very faint, which happens in low grade type of lesions, you give 1 point for that. And if it is distinctly yellow or a saffron color we call it, we give 2 points for that. So how to interpret? You have given the marks, calculate the score. If the score is between 0 to 4, it may be normal. It may be a low grade type of lesion which will correspond to SIN 1. If the score comes as 5 or 6, then it is a high grade type of lesion, but it is a non-invasive. It may correspond to SIN 2. And if the score is between 7 to 10, then definitely it's a high grade lesion. You suspect invasion also, and it corresponds usually to SIN 3 type of lesion. So what is this SIN business is? This is cervical intraepithelial neoplasia. This term we were using very wrongly previously, but this CIN is a precancerous lesion, and that is very much confined to epithelium. It has not extended into the stroma. So 3 important things again as far as cervical cancer is concerned. This is the only cancer in the body which is preventable, which is diagnosed in a pre-malignant phase, and that's why we can treat the pre-malignant phase and prevent that lady to go into the invasive or deep grade 2, grade 3 type of stage 2, stage 3 cervical cancer. So 3 important points for cervical cancer is prevention with vaccination, detection with screening, and treatment by various methods that we have to treat the pre-malignant lesion. So remember, CIN is an histological diagnosis. Depending upon the severity of abnormal changes and degree of loss of maturation and differentiation, it is categorized into 3 grades. For treatment purposes, 2-tier system is followed. SIN 1 and HPV changes are considered as low grade. SIN 2 and 3 are considered as high grade. And as Sir was saying, the incidence of SIN 1 is 2.3%, SIN 2 is 0.5%, and SIN 3 is only 4%. Even if it is only 4%, we have to detect that 0.4% by doing the screening methods. So in this picture, we can see what is SIN 1. Again, only lower 1/3 of the epithelium is involved in SIN 1, whereas in SIN 2, 2/3 of it epithelium is involved, whereas in SIN 3, entire epithelium has been involved by the disease. I think in the afternoon we have one lecture on cytology and histology, so all these things will be more clear during that session. So do we need to treat all these SIN lesions? So you have to see the course of the disease. What happens? The SIN 1, the regression rate is quite high, 57% lesions, they regress of CIN1. Persist, 32% they persist, only 11% progress, and only 1% progress to invasive cancer. Whereas in SIN2, the rate of regression is bit less, 43%. Rate of persistence is 35%. So the persistence of HPV infection is very important. It is not only once you get an HPV infection, then that lady is going to get a cancer. No, it is not like that. Persistence of HPV infection is a causative factor for having a cervical cancer and not having or acquiring an HPV infection. So this SIN2 persists up to 35% they persist, 22% is the progression rate, and only 1.5% they progress to invasive cancer. Whereas in SIN3, the rate of regression is still less, only 32% regress, 56% lesions persist, and that's why repeated screening. If you are doing HPV, every 5 years you have to screen that lady with the screening modality which you are using, and progression to invasive cancer is 12%. That's why again the importance of screening, screening and screening. So for CIN, you should remember low-grade smear abnormalities can very well be followed. Don't be in a hurry to treat. But again, as Dr. Pawar has very nicely said about the screen and treat strategy. So this is mainly for a rural population where you are sure that the lady is not going to come back again. एकदाच करून ती म्हणते बास मला नको परत परत हे. So at that time there is a role, even if it is a CIN1, you treat it. Maybe it may be an over treatment, but we are sure and we want to achieve the goal of WHO of 90, 70, 90. That is the goal WHO has given to achieve till 2030. 90 is vaccination, 70 is screening, and third 90 is treatment of pre-malignant lesions. The scenario in India is very poor, so we all must work together to achieve at least 50% of that goal should be reached by 2050. Not possible till 2030, but at least by 2050 we should be on that line of achieving or reaching to the goal. So persistent of CIN, we are supposed to follow the patients. Even if it is a low-grade type lesion, you have to call the patient after 1 year and do her colposcopy again to see whether the infection has been cleared. As Rohini madam rightly said, majority of the infections they get cleared, immunity is good, the infection is cleared, you see on the colposcopy there is no lesion, then no need to worry. But again the lesion is same, it is persisting. So persistent of CIN1 lesion for consecutively 2 years, then definitely you have to treat that CIN1 lesion. Now there is a confusion between CIN2 and CIN3 amongst the pathologist. He is not able to tell you exactly whether it is a SIN2 lesion or a SIN3 lesion. So at that time there is a role of biomarkers that have been used, and or immunohistochemistry is a new technique that is being used by the pathologist, and this immunohistochemistry they use different markers like Ki67 or P16, and they help to distinguish between whether the lesion is SIN2 or a SIN3 type of lesion. Many times I remember one of my patient had SIN2 on biopsy, but that pathologist, she was not able to give me the proper diagnosis. So she said, Madam, आपण हे वापरून बघूया का? Again, we are always worried about the cost. The patients, they are not affording, and once you say की हे करायला पाहिजे, she will say, Madam, एवढं करण्यापेक्षा काढून टाका ना, कशाला हे सारखं सारखं करताय. But that patient was fortunately educated. She said, okay, we will do it. We did her immunohistochemistry, but the report came as a metaplasia. So there was so much of a difference, and only one test could save us or proceed for further management in that case patient. CIN3 needs immediate treatment, and choice of treatment depends upon various factors like the instruments that are available in your setup, the technique that you are well versed with, and of course if you are a private practitioner, cost of the therapy. So the basic principle why you treat CIN and how to treat it. It is not like that. I have seen an abnormal area and I'm just removing that area. No, it is not like that, because we know the happening is in the transformation zone. So you have treated that area, the patient is having abnormality on screening, then definitely she may develop other lesions also. So it is our duty to treat entire transformation zone. The region should not recur. That's why basic principle of treatment of CIN is treatment of entire transformation zone should be there. And low-grade lesions, as I told, they don't need any treatment, but they need protocol. So in short, SIN 2 and 3, there are two ways of treatment. One is ablation, another is excision. So major advantage of excisional procedure is you have a biopsy with you. You have a documentation and the diagnosis is very clear once you take a biopsy, and that is the advantage of excision. But in ablation, the biopsy is not there. You are just ablating the entire transformation zone. Again, this can be used in rural areas where you are doing camps. There is, you are doing it on a mass scale and you are seeing abnormalities. Many abnormalities are there. At that time, you can use the ablation methods. In ablation, we have thermocoagulation and cryotherapy. Cryotherapy, I remember, madam, we were doing it since our resident days. We were not doing any screening method, but whenever the cervix used to show big ectopy, patient sarki white discharge म्हणून यायचे. At that time, I remember we had a cryo unit in the gynec department and we used to do a cryotherapy since then. Thermocoagulation is a newer technique. Here there are different probes depending upon the size of the cervix, and here the temperature of the probe is raised to 100 degrees centigrade and you destroy the tissue, and the destruction is achieved till you reach the crypts. So almost 7 millimeter destruction is achieved, and that is our aim, that the entire transformation zone is being treated with this thermocoagulation. Also, there are certain advantages, disadvantages of both these procedures, but we have to again see the cost, the technique you are well versed with. Thermocoagulation is also very easy to perform, but the instrument is a bit costly. Another method is excisional method. Here we are having lip, lids and cold knife conization. Here again we have a biopsy for that and the lesion will be treated completely, but this again requires, like a laparoscopy, a bit training. You have to do it repeatedly because whenever you are doing lip or lids, there is a lot of bleeding and the picture becomes very blurred. You are not able to see exactly what you're doing. So you have to learn the technique and then start doing lip or lids. So
Madam,
what
sorry,
usually
last
I
2
suggest,
minutes.
yes. So what I usually suggest is you start taking biopsies with a lip. Small loop is available. So whenever you want to take a biopsy during colposcopy, start doing with a lip procedure. This is my last very important slide. I'm inviting all of you to Kolhapur on 11th to 13th April 2025. It's very prestigious for all Maharashtrians. We are hosting a national conference of ISCCP, that is Indian Society of Colposcopy and Cervical Pathology. Kolhapur Society has agreed to work on it, and it is at Sayaji Hotel. We are having workshops on colposcopy, HPV, lip, thermocoagulation. We will be discussing various case scenarios during this conference, so it will be of helpful for all gynecologists. So block your dates during those periods, and thank you very much for giving me the opportunity. Thank you.
Thank you, madam. And thank you, madam, for very well elaborated in detail about the colposcopy and CIN. Any questions from audience? Then we will proceed. Thank you for the invitation to our conference also. Yes. Now we will going to the next lecture of this session. I will invite Dr. Bhushan Jhade sir for his talk on radiotherapy in CA cervix. He is Director of Department of Radiation Oncology, Ruby Hall Clinic. He has pursued his undergraduate from Nagpur, Radiation Oncology and Clinical Oncology from Tata Memorial Hospital, Mumbai. Completed DNB Radiation Oncology from National Board, Delhi. He joined Ruby Hall Clinic as consultant radiation oncologist, and mainly he is expert in stereotactic ablative radiotherapy for lung and liver tumors in Ruby Hall Clinic, and perineal interstitial brachytherapy treatment for difficult female genital tract cancers. And also he has been a part of bone marrow transplant unit and total body irradiation for myeloablative conditioning. And also he has been a principal investigator and co-investigator of various study protocols. Over to you, sir.
Thank you, ma'am, for those kind words. At the outset, I must thank organizing committee of Solapur Gynae and Obstetric Society. Special thanks to my friend and eminent oncosurgeon Dr. Parag Kumtekar and his wife Dr. Amrita Kumtekar for extending a special hospitality for this event. So let us can we have this screen? Yeah. So I must talk about the title of this particular talk, Precision or Targeted Radiation Therapy for Optimal Outcome of in Cervical Cancer. So generally we get a call from conferences that you need to talk about radiation oncology, and the title is typically latest advances in radiation oncology or latest advances in something else. That's how the very general, and sometimes they only ask us what should be the title. But I was really surprised to see this title, which I find very appropriate, the precision in any fraternity for optimal outcome in that particular entity. So we need to use our modality wisely for the best interest of the patient. So as an oncologist, as a radiation oncologist, when we talk about, discuss about cervical cancer, what comes in our mind? So this is one of the most common cancers in India, no doubt about it. However, the incidence of this particular cancer, if you see in rural and urban India is different. In urban India, actually the incidence of cervical cancer is coming down, whereas it is still high in rural population. And why so? Potentially through HPV vaccination, I have my own doubts because data, all those things we can discuss, we discuss generally just now. But I feel it's because of better personal hygiene in so many ways. So HPV infection or other infections going down with personal hygiene has taken down the incidence of cervical cancer in urban population, whereas it is still very high in rural population. This is one cancer which is easily amenable for simple screening. So yes, screening has a lot of role to play in cervical cancer. Early detection and better outcome. It is treatable and curable in very advanced cases also. Now, what is the most common stage of cervical cancer? What we see is 3. Stage 3 is most common stage. Now, if you compare stage 3 in other solid malignancies, what is the outcome? And if you see the outcome in stage 3 cervical cancer, they are almost curable in more than 60-70% cases, and they are long-term survivors. So this is rewarding to treat cervical cancers, even they are advanced at presentation. Think of other solid tumors, most common otherwise breast cancer. What is the duration of breast cancer treatment? Minimum 6 months to 1 year. Here we are talking about, even in advanced cases, treatment of around 2 months, right? So relatively short treatment with a curative intent and not much of a treatment related side effects. So quality of life is maintained. So cervical cancer, if I see as an oncologist perspective, I see there are so many kind of encouraging things about cervical cancer and common in our country. So before we embark journey into the treatment part, let us few words about complete workup in a metastatic, what we call metastatic workup. Importance of general examination, localization I need not mention because you all are gynecologists here. For us as a radiation oncologist, what is very, very important is per rectal, per vaginal finding and careful mapping of disease. We make a nice diagram because after external beam radiotherapy, when we take that patient for brachytherapy, when we insert our applicator through vagina into the uterus, what we call sounding and the applicator placement, to give a nice dose distribution, we need to have an idea of the pre-treatment disease volume. That's why the examination is very, very critical. Drawing the diagrams are very, very critical. Blood tests, renal parameters, because we know we need to give cisplatin. If the renal parameters are not good, that can be a limiting factor. Sometimes we diagnose some undiagnosed diabetes, so generally we write this basic investigation. Now let us come to local imaging. When we talk about management of cervical cancer in a low resource situation, where we do not have access to fancy PET scans and MRI, even sonography and X-ray chest is good enough. This is one malignancy, a unique malignancy, where you can offer a curative intent treatment with as basic investigation as sonography and X-ray chest with few blood parameters. Of course, we can have a CT scan with contrast enhancement, we can have MR with contrast enhancement, we can have one-stop shop PET scan with a very high sensitivity to nodes and distant metastasis. We do everything, but just to mention, even USG and X-ray chest are good enough, and if you have access to, and especially surgical cases, MRI is very good because of a good soft tissue delineation. Cystoscopy, proctoscopy as indicated, because many times we see bulky tumors. They are just pushing rectum and bladder. Fat planes between rectum and bladders are not visible. They can be potentially invading bladder or rectum. So if you see a potential invasion into bladder and rectum, you must do proctoscopy or cystoscopy to rule out the mucosal involvement. Many times what happened, just on a CT or MR finding, there is a mention of bladder invasion. Bladder wall invasion is not important. That doesn't upstage the disease. It has to be bladder mucosal or rectal mucosal involvement, which has got a treatment implication. Just pushing bladder, just pushing rectum, just loss of fat plane does not change the management. Very, very important thing here. So when we talk about radiation therapy for the optimal outcome, we must define the intent of our treatment. Is it definitive? Are we going to cure that particular patient? Is it an adjuvant treatment? The primary surgery is done, and now we are here to check whether that patient needs further treatment to improve survival, that what we call adjuvant radiation, or disease has already been metastasized and we are offering radiation for some bleeding, pain, or to improve some quality of life. That's a palliative. And one important entity we are talking about, yes, this is a oligometastatic, means a metastatic disease, but few number of mets, 1, 2, 3, bone or some visceral organ, where the patient general condition is good and we can still treat that patient with curative intent in spite of a metastatic disease, what we call oligometastatic disease. Or there is one more entity called oligoprogression, where primarily we have treated cervical cancer. Patient is cured after 6 months, 1 year, 2 years. On a scan, we see 1 or 2 metastatic disease deposits where the general condition is maintained asymptomatic. Oligoprogression, we can intend cure treatment in that particular case also. So this is our intent of treatment or intent of radiotherapy we need to define before getting into the journey of treatment. So let us go stage-wise management, and where as a radiation oncologist I come in. Stage 1, disease confined to cervix. Stage 1A, microscopic form. Stage 1B, macroscopic. Of course, this 3 millimeter less than, more than, you can all read in books. So in short, stage 1A microscopic, stage 1B macroscopic, but confined to cervix. Stage 2, going little, so this is 1B only. Stage 2, going beyond cervix in vagina or in the parametrial tissue. Stage 3, going lower 1/3 vagina, or stage 3B, disease going up to the lateral pelvic wall, or even if it is not going up to lateral pelvic wall, it has obstructed the ureters, giving rise to hydroureter or hydronephrosis. Even a small disease not going into lateral pelvic wall but has got impact on kidneys, it is stage 3B. Stage 4A, bladder or rectal mucosal involvement. Sorry, this stage 3C also. So what has happened, in an initial FIGO staging, if you remember, if you know, the imaging was not really needed. It was more of a clinical diagnosis. So nodal involvement was not known unless until it's been operated. But now the newer FIGO has permitted imaging. So now we know the nodal stages. So if the pelvic nodes are positive, it's stage 3C1, parotid nodes C2, and then comes stage 4A, which is a bladder or rectal mucosal involvement, and stage 4B, we all know, distant metastasis. So let us come to the stage-wise management of CA cervix. Confined to cervix, smaller size. Any controversy here? No controversy. Treatment is surgical. Good surgical skills, I am sure Dr. Parag Kumtekar in his next lecture will talk about the surgical aspect of various situations. Suppose the patient is not operable because of some medical result. That is the only situation where I can come in this stage, otherwise management is surgery, no adjuvant treatment required here. Let us come to the advanced disease, where disease has gone beyond cervix, difficult surgery, margin positive or other complication could be there. Treatment is mostly radiation. In a metastatic setting, treatment is chemotherapy. If there is a bladder or rectal mucosal involvement, we can downstage by giving chemo first and then radiate, still with a cure intent. So here, it is mostly chemo and select radiation. Let us come to this part, what we called controversial area. 1B2 to 2A. This we are going to discuss in detail in subsequent slices. So there has been always a controversy what to do in this particular case, and we talk about hardcore evidence. Like what I feel, what you feel is not that important, the evidence has to be randomized. So if you see the publication, it is 1997, and this is the only randomized data addressing this particular question in this context. So surgery versus radiotherapy in early, means what I call intermediate cervical cancer, not very early, not very advanced, 1B, 2A cervical cancer. So what randomization? Almost 350 patient randomized, equally surgery arm and radiotherapy arm. Now in this surgery arm, after surgical histopathology report, looking at the adverse risk feature, the post-op radiotherapy was given to women more than 4 centimeter tumor, positive cut margin or node positive. These are called high risk features in a histopath report. They were offered radiotherapy as a part of treatment. Look at the number of patients who needed radiation after surgery, 64%. It is not 6 or 10%, it is 64%. Received radiotherapy, a decent follow-up, 5-year overall survival, diseases were identical in both the arms. So surgical arm, radiation arm, the survival, disease survival, ideal, same. But because we use 2 modalities of treatment in surgical arm, the side effects were higher as compared to radiotherapy arm. Now again, criticism, data was old, right? So, and the follow-up was 5-year, and we know in early cervical cancer, the cure rate is so high that 5-year follow-up may not be sufficient, correct? You need 10-year, 15-year, 20-year follow-up. So recently, we have a 20-year update on the same database published by same author Landonis. What we see, all parameters are identical, slight difference but not statistically significant. So overall survival, disease survival, same. The difference is here. And what is this difference? It is adenocarcinoma. So in an adenocarcinoma variety, surgical arm did much better than radiation arm. So if you see adenocarcinoma cervix and if you feel the patient is operable, please operate. Please operate, because of course you can always back it up with radiation, but adenocarcinoma cervix in an operable situation should be operated because that gives long-term cure rate as compared to radiation alone, right? But in squamous cell carcinomas, all the parameters are same, so we have to choose wisely. So this is very, very important. I am not sure whether you can see this chart well. So this is a very important chart. See, this is the 20-year outcome of that particular trial. Surgery arm, surgery plus radiation. So this 2 put together constitute the surgery arm, because from the surgery arm, 64% received, patient received radiation, and this is radiation alone arm. And see the parameters, urologic complications, vascular complications, intestinal and others. If you put all those complications together, almost 30% of patient from radiation arm received, could get into that side effect or complication zone, whereas surgery plus RT, it is almost 60%, and surgery alone almost 40%. So though the survival outcome is same, the side effect profile is higher when patient undergo radiation plus, so surgery plus radiation together, but we have to do it because then only we give them optimum outcome as far as oncological situation is concerned. So, summary, after 20 years of follow-up, patient should be accurately selected for surgery, primary surgery, such as in case of cancer not exceeding 3 to 4 centimeter, to minimize need of adjuvant treatment. So, surgical selection should be there such that the adjuvant treatment should not be needed, and adenocarcinoma, even if adjuvant is needed, please operate. And the conclusion is to suggest there is no treatment of choice for early cervical cancer in terms of survival. So we have to choose our treatment strategy optimally in the best interest of patient. So now I rephrase the same slide. No treatment of choice, we have to choose appropriately. So now coming to the adjuvant radiotherapy. So whenever we get a patient which has been operated, what we see? The histopathology, and we stratify that particular patient into a low risk, intermediate risk and high risk. Stratification into high risk is pretty simple. Node positive patient, margin positive, parameter positive, straight high risk. Intermediate risk, when these factors are negative, we follow this table. This is a set list criteria published. Patient has to fall in either of these 4 categories. Lymphovascular space invasion positive, deep stromal invasion, irrespective of the tumor size, if these 2 characters are met, patient goes for intermediate risk. LVSI positive, but there is a middle third involvement of stroma, then the tumor has to be more than 2 centimeter. This LVSI positive, but tumor is superficial, but then the tumor size comes in picture. And if LVSI is negative, it has to be middle or deep with a large tumor. So patient has to fall in either of this 4 category to call it as a intermediate risk for adjuvant treatment. And if all these parameters are negative, patient is in low risk. And what is the treatment? For low risk, just reassure the patient for a regular follow-up, no need of any adjuvant treatment. For intermediate risk is radiation, external plus brachytherapy. And for high risk, we add concurrent chemo along with primary radiation therapy. Pretty simple. So what are the challenges we face when we talk about radiation therapy in cervical cancer? We know this organ is sandwiched between radiosensitive bladder and highly radiosensitive structure, rectum, and the small intestine around. This is a unique anatomy, like same problem we face when we treat a prostate cancer in male, cervical cancer in female. So these structures are very radiosensitive, and when we give radiation, we have to reach through this structure. We cannot really create radiation there. We have to reach to the cervix through bowel, through bladder, through rectum, and that's where the precision radiation oncology comes in picture. So these are the different common iliac, external, internal iliac, obturator, nodes. These are the different nodal levels as per our guidelines of contouring. So we know cervical cancer will spread to these areas. If node is positive, that is a high risk. If node is negative, that's the situation. So when we do a CT data acquisition, we contour as per the guidelines. We go by the vessel. On a contrast scan, give margin to vessel. If there is a gross node, we give boost. So that's how we follow this strict criteria of what we call contouring, and that's how the radiation plan would look. So this is a simple plan just to highlight the importance of conformal planning. Of course, we can radiate cervix with a good dose, but at the cost of bladder, rectum and small intestine around. If you do a very conformal plan, we can nicely spare bladder, rectum. If you go, we'll get small bowel also. So what we do in conformal planning, we rotate radiation in 360 degree. I'll come to that when I'll show the actual plan. And small radiation doses from each angle makes doses concentrated in one site, and the spillage is very, very low, so that that low spillage can be well tolerated by organs around. And these are the nice conformal plan. We can see the sparing of bowel, sparing of rectum, sparing of bladder, while I am able to give full dose to the area of disease. This is a typical brachytherapy applicator. This is the intact uterus, primary radiotherapy for the cervix, and this is post-op vault where we do the brachytherapy to vaginal mucosa or vaginal vault to prevent the recurrences. So let us come to the real world picture. So this is say 60-year-old lady with diagnosis of CS cervix, and you can see the disease is quite large, going into the lateral pelvic wall, which you can't appreciate here, but we do PAV-PR, and we suddenly know the disease is stuck to the pelvic wall. Treatment, radiation therapy plus concurrent chemotherapy. What we do, I was talking about rapid arc treatment. So you can see this circle, and these angles also serrations, so that spokes denotes each angle of that particular beam which is going around the patient and giving radiation through that particular angle with different shapes. It continuously changes the shape. The intent of changing shape is beam's eye view. So this is a disease. If you look at this disease from this angle, the picture is like this. If you look at the disease at this angle, the picture will be different. So by looking at the disease from different angles, it takes the shape of that disease and continuously modulate the treatment in 360 degree. This is called rapid arc treatment. You see nice conformal plan. You see the response. This was the disease before treatment, complete response after treatment without any side effect to adjacent organs. This is a primary radiation for the cervix. Now, it is not only primary treatment what we do. We see many times something of this sort. When we follow up this patient with PET scan, we really like PET scan because it is one-stop shop, non-invasive, plus gives you a very good sensitivity to the metastatic disease. Now, patients are asymptomatic. 6-monthly follow-up, we do PET scan, and we appreciate these kind of a para-aortic nodal recurrences in an asymptomatic patient. Now, for this particular isolated para-aortic recurrence, would you subject this patient for systemic chemotherapy? You may say yes, because that's maybe one of the treatment options. But for any solid tumor in a metastatic disease, oligometastatic, even if you do chemotherapy, that will downstage, but will not cure. After chemotherapy, there will be again a recurrence. You need to add a local treatment when you attempt cure. Now, this is a regional node. This is not a distant mets. For cervix, para-aortic is a regional. And now, this isolated regional nodal metastasis, instead of giving systemic exposure of chemotherapy, we can think of doing a very high dose radiation there, what we call SBRT, stereotactic ablative body radiotherapy. So we isolatedly ablate this particular nodal disease, sparing kidneys, sparing spinal cord, sparing duodenum, sparing bowel nicely. We can cure this patient in spite of a metastatic disease and defer chemotherapy for further recurrences, because at one point of time when the disease recurrence might be kind of extensive, that time you have no option but to give chemotherapy. But in isolated disease failure, you can do this ablative treatment and defer chemotherapy definitely and still attempt cure with good quality of life. That is very important. No side effect. So these are the recurrences, para-aortic small recurrences, patient is asymptomatic. We ablate that with radiation. This I did on a cyber knife. I'll finish my lecture by this very interesting case. This is CA cervix post-op post-radiation. I treated first in 2014. Now, since 2022, she started having oligoprogression, locally controlled, and few areas of metastatic disease. So I treated this patient twice for liver metastasis and once for rib metastasis. So before this particular last year treatment, I had treated her thrice. Till now, she did not receive any chemotherapy. Now, PET scan in 2023, September, showed 2 more sites of disease progression. So this was a third liver lesion, 2 I had treated earlier, and one very interesting site of pericardial node. Now, treating liver, now with cyber knife, earlier with TrueBeam, very easy for us. How we will address this particular node, which is pericardial. Yes, one option of giving chemotherapy, but again, patient was very keen on radiation because she had already undergone radiation 4 times with me, and she was like, yeah, I still want radiation, no chemotherapy, I'll defer, fine. So, we'll treat this easily. How to treat this? Now, one way of treating, because this is a moving tumor, you must understand. This is close to lung, this is close to heart. This is a moving tumor, though small, but it is moving. How to target this? So we committed, okay, we'll treat. Don't worry, we'll think how to figure it out. Then we were like thinking how to treat this tumor. We realized the tumor is very close to the dome of diaphragm or dome of liver. Now, if we can track the movement of this liver dome or diaphragm, we can easily track the movement of node. So we did simulation. We take deep inspiratory and deep expiratory scans, and can you appreciate this node in this particular angle which is moving with respiration in a deep inspiratory and deep. So this gave us confidence that if we able to track this liver dome with reference to liver dome, we will be able to fire this node. Isn't it interesting? Yes. So then we did it. This is how we track the liver dome. Can you appreciate the liver dome tracking? So this is a typical plan how you would see on a screen of our planning system. 5 millimeter was the only margin. The movement would have been almost 2 centimeters. But because we were tracking, we could reduce our margin from 2 centimeter to 5 millimeter. We did this 5 fraction, so 5 days treatment, and simultaneously we planned the liver also. See the response. After treatment, this is the response evaluation scan. The nodule has completely gone, and the beauty is there is no fibrosis of lung around the treated area. If I would have treated the bigger volume, like a margin for the movement of the tumor, I would have ended giving lot of pneumonitis first and fibrosis later, some potential heart damage, which we avoided by this particular technology. I'll explain how we did it. And the liver lesion, very simple to treat. What the artifact you are seeing here, it is a gold fiducial. So we put a gold fiducial under CT guidance, and that fiducial is tracked with the X-ray cameras, which gives real-time information to the treating robo, which targets the tumor in the moving real time. So this the tumor completely gone. What you see is just a fiducial there. So this is our department. Equipment state of art, TrueBeam STX with 6D couch. This is Halcyon Elite, and this is what I am talking about, CyberKnife, the robotic radiosurgery platform. So thank you so much for having me here, and I'll take just 2 minutes to describe the CyberKnife radiosurgery system. Let me tell you, this is not used primarily for cervical cancer management. This is used to ablate small focus of disease in the body with a radical intent. So the treatment is not 25 days. Treatment is just 3 to 5 days, and the doses are very high. So what this system does, this is the system where this is the infrared camera which tracks the respiration, the rise and fall of chest in real time. These are 2 X-ray cameras which looks at the movement of tumor or movement of fiducial in real time, and that 2 data set create an algorithm which tracks the tumor movement with respect to the respiratory pattern. And this algorithm, what we call the synchrony algorithm, gives information to this robo regarding the position of that tumor in that particular phase of respiration, and the tumor is accurately targeted. This was a technology what we had used in the treatment of that tumor which was sitting in the pericardium. No. So it's beautiful to treat. Do not primarily used in cervix, but cervical metastasis, lung cancer, prostate we are treating big time, neuro cases, acoustic schwannomas, meningiomas, pituitary adenomas, brain metastasis, arteriovenous malformations. So these are the few indications to label where we are using this technology to great extent. Thank you so much. Please, you can bombard me with some questions. Sorry, sir? Sir, it is not necessary as far as staging is concerned. The other staging modalities like CT scan used is enough, but if you have a facility of PET scan, that helps you in a metastatic workup first because it has got a very high sensitivity. And for response evaluation, what happens if we have a pre-treatment PET scan handy with us, we can always compare it with a post-treatment PET scan. What happens, PET is a metabolic imaging. If you compare CT or MRI, which is a grayscale imaging, that will still show you some abnormality after treatment. But you are not very sure whether that abnormality harbors disease or it is just post-treatment fibrosis. If you have a PET scan which is a metabolic imaging, abnormality is fine, but there is no activity, there is no disease. So you are sure that you have done a good job. So it is very popular nowadays, sir. In advanced stages, yes. In early stages, maybe our choice. Generally PET scan, ma'am, because PETs, if you compare cost of a CT abdo-pelvis with contrast and a whole body PET scan with contrast, there is a difference is 20-25% only. It has become so economical, PET scan. It's only 10,000 now for a PET scan. So, and PET scan gives you so much of information. We prefer PET scan. No, because that's again very good question. You should not be doing unless and until you have very high suspicion because of ASCUS. You get atypical cells which are post-radiation normal, and it's stressful situation is created. So unless and until you see something which is persistent or which is progressing, take a biopsy. Take a biopsy. Do not take smears, because smears you will not get answer. It only will confuse you. So we are talking about side effects of treatment with radiation. So it's pelvic radiation. So what pelvic organs we are kind of subjecting to some dose of radiation is bladder, rectum and intestine. So bladder, we may get cystitis around 20-30% patients, may not be needing treatment, but some symptoms, proctitis and enteritis. Now with some lifestyle modification, like take a lot of water, walking is good, no spicy, no constipation. So if you take care of all these lifestyle things, we can cut down to great extent for this side effects, plus conformal radiation. Now when we talk about our old patient having a lot of side effect, probably we are talking about some cobalt radiation where the treatment was two-dimensional, anteroposterior field, everything receives same dose. Probably we are talking about some 3D CRT where the box shape kind of a distribution we had showed. But now with that butterfly shape distribution, the exposure to bladder, rectum, intestine has gone down by 60-70%. Still there will be some side effect. No denial, every treatment there will be some potential side effect. The quantum and severity has gone down significantly.
Dr. Bhushan, is a very interesting lecture. The one case that you showed about the paracardiac node, which was really amazing. I just want to know what was the size of that paracardiac
1.2 or 1.5
centimeter. 1.2 centimeter. That was really amazing because I'm a radiologist, so I know how difficult it is to reach.
Even target. If someone asks you to do a FNAC or biopsy,
I know how difficult it is. So
yes.
I really appreciate that. That's a very interesting and amazing case. Another thing is, do you use CT fluoroscopy for the thing, or is it a real time to place the portal? Now, for example, if you are targeting a cervical lesion, to avoid the bladder mucosa, rectal mucosa, the ports that you place, is it real time or?
I'm sorry, which ports you are talking about? Fiducial?
Radiation ports.
Ports?
Yeah. For radiation, when you do a precision radiation. For that,
Okay.
Is it a real time?
What the simulation process you are talking about is correct. So first, the basic important step is immobilization in a supine position with the knee rest and a vacuum bag. Once we immobilize the patient, we do a CT data acquisition scan. So on that planning scan, we contour, I showed one slice by contouring the nodes, nodal stations, the disease, which parameter depending on stage, and that data set goes to a physics team for planning.
Okay.
So this is not real time.
That is what I want. Whether it is real
This is not real time.
You collect the data first. transfer the data to a
Correct. So
physics
planning
team.
system, then the physics team, then quality assurance, then treatment. But when it comes to treatment on couch, we acquire one more data set, what you call CBCT, cone beam computed tomography. So we acquire that data set when the patient is on couch just before treatment. That data set is superimposed on a planning data set which we had taken on day 1. After superimposition, we get some shifts, what we call errors, X, Y, Z, roll, pitch, yaw. So those 6-dimensional errors are corrected. That's called image guidance. So after the correction, what we had planned on offline data set, the online data set is superimposed and corrected and the treatment is delivered. So now the offline becomes online.
That is really precision.
And the next level is going to be, probably next year we will be having the MR Linac business with us. So what this MR Linac would do, the MR in cine mode will be continuously on when the patient treatment is going on. Continuously on. And what we define the boundaries of our treating target volume, we give some margin for the movement because we know whatever immobilization do, that is external immobilization, internally there might be some movement going on. So if our disease goes out marginally from that margin, treatment would stop. So that we are in the process of acquiring. Probably next year we'll have that MR Linac with us. If you see posterior bladder wall or posterior bladder mucosa is always irradiated. No, mucosa will, because what happens, the disease is in our case is advanced, which is already touching the bladder, and we always have to give some margin. Of course, with all technology we have been reducing our margin, but we are in a no position to make it zero. Yes, I'm coming to that. So when we give some margin, even that some margin is 5 or millimeter or even 8 millimeter, the posterior bladder mucosa is going to get radiated. So, but we are talking about when we have a full bladder mucosa getting radiated versus posterior bladder mucosa getting radiated, that gives less quantum of side effect to patient. However, it's not zero. With other lifestyle modification like drinking a lot of water, exercise, and having some alkalizing agents like cetal and all, we can still reduce the side effect. But at no point of time we can make it zero.
Thank you, Dr. Zade. It
Thank
was
you.
a very brainstorming lecture. It was very wonderful and interesting lecture. It is today that we have learned many new things, and always when we send a patient for radiotherapy, today we come to know what all things
What exactly
are
we
going
do.
on. Yes. Thank you very much.
Thank you, Dr. Bhushan. I think Dr. Bhushan deserves a big round of applause from the audience for how precisely he managed
That's
the case
kind of you.
pericardial effusion, pericardial node, sorry. May I request our chairpersons, Dr. Vidyathirankan Madam, to felicitate Dr. Vijay Pawar, sir. May I request Dr. Meena Gujratikar Madam to felicitate Dr. Bharti Abdankar Madam. I request Dr. Vidyathirankan Madam to felicitate Dr. Bhushan Dhadi, sir. May I request President Dr. Ghate Madam to felicitate Dr. Vidya Dhirankar Madam. May I request Ghate Madam to felicitate Dr. Meena Gunzotikar Madam. After the exhaustive academic sessions and discussion, let us proceed with inauguration ceremony. I request all the faculties and chairpersons to come on the dais for inauguration. I request our President Dr. Ghate Madam to come on the dais for inauguration. Dr. Joshi sir, Dr. Bharati Dhirankar Madam, Dr. Vijay Pawar sir, Dr. Vidya Dhirankar Madam, Dr. Meena Gunzotikar Madam, Dr. Rohini Deshpande Madam, Dr. Baldava sir, please come on the stage. Dr. Parag Kumthekar sir, Dr. Bhushan Zade sir,
अमृता कुमठेकर, डॉक्टर ललिता, डॉक्टर चंद्रकांत.
शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः
डॉक्टर विजय पवार सर.
दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तुते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छां हि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठे गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः
Thank you everyone. I request our President Dr. Ghate Madam to deliver her presidential address.
Good morning, one and all. Cervical cancer is the second most common cancer in India. Today we design the CME on benign and malignant lesions of the cervix, screening of the cervical cancer, and management of benign and malignant lesions. SCJ, squamo-columnar junction. It is the junction between the squamous epithelium of ectocervix and columnar epithelium of endocervix. At birth, it is located at external os. But because of hormonal changes, pubertal changes, pregnancies, endocervix get everted and this columnar epithelium exposed to the vagina and form new SCJ. This is already talked by Abhyankar Madam. This transformation zone is vulnerable for oncogenic effects. Proper history taking, clinical examination of the cervical lesions, very important. Awareness of cervical malignancies and education of the patient about the screening tests need to be done. Primary prevention by giving vaccine is possible. Secondary prevention by detecting early changes in cervical benign lesions can be picked up earlier and treated with the help of colposcope and cryocotry. If at all CA cervix detected in early stage, we can have the help of oncosurgeon and surgical management could be done. If CA detected in late stage, we have radiotherapists to treat cancer. We also have a choice of chemotherapy with the help of chemotherapist. As a gynecologist, we should have multidisciplinary approach to treat and prevent cervical cancer. I am thankful to all expert and esteemed speakers here to throw the light on the topic of cervical lesions, screening and treatment. Before ending my talk, I want to end the talk with one Sanskrit Subhashit. Agnihi Shesham, Runaha Shesham, Shatruhu Shesham Tathaivacha. Punah punhacha pravardhatet, tasmat shesham न कारयेत. ह्याचा मराठी अर्थ असा, अग्नी, कर्ज, शत्रू, त्याच्यापुढं मी ॲड करते की कॅन्सर किंवा कर्करोग जर थोडेही शिल्लक राहिले तर पुन्हा पुन्हा डोकेवर काढतात. म्हणून त्यांना थोडेही शिल्लक ठेवू नये, त्यांना पूर्णपणे समाप्त करावे. इन इंग्लिश, इफ यू लेट रिमेन इवन द स्मॉल अमाउंट ऑफ फायर, लोन, एनिमी अँड कॅन्सर unattended, they will increase again and again. Hence, they should not let open even in small quantity. I am thankful to audience for the patience hearing and physically present for the CME. I am also thankful to online audience for attending CME. Now we'll start with the second session, pre-lunch session. Now I request Amruta to take over the mic.
It is my honor to introduce and request Dr. Sampath Padawal sir and Dr. Rohini Deshpande madam to chair the session. They are the most seniors, academic teachers, very humble, very enthusiastic sirs. Dr. Sampath Padawal sir is a director of SS Baldavan Neuroscience and Women Care Hospital. It is 60-bedded hospital and HOD of OBGYN department of Markandeya Rugnalaya since last 45 years. Sir is also teacher of postgraduate, the institute is a postgraduate institute for DNP and DGO. Sir has attended as a faculty at many national state conferences, won the best paper prize at AMOX 2022 Aurangabad, active Rotarian and life member of FOXD and IME. Sir is a past president of Family Planning Association of India, Solapur branch. Dr. Rohini Deshpande madam, I think both no need to any introduction, but it is my privilege to introduce Dr. Rohini Deshpande madam. Is a senior consultant of in Solapur since last 28 years. She has main interest in imaging of the OBGYN, endoscopic surgery for infertility, perinatology and adolescent medicine. Contributed a chapter on Doppler in PIH in hypertensive disorder of pregnancy and an overview of operative hysteroscopy in a book on Sat Sa hysteroscopy edited by Dr. Osma Saswi and Sushma Deshmukh. Presented lectures, papers at various conferences at state, international, national levels in Maharashtra, Karnataka, Tamil Nadu, Delhi and Kerala. Madam is the president of AMOX. Madam has posted various posts like secretary, treasurers in IMA in Solapur branch. Over to you, sir. Over to madam.
Hello. Good morning. Now I am requesting Dr. Parag Kumtekar for next session. Dr. Parag Kumtekar is MBBS from VM Medical College, Solapur, MA General from Grand Medical College and Sir JJ Group of Hospital, Bombay. First rank all India level in super specialty entrance exam in 2007. MCH in surgical oncology, Tata Memorial Hospital, Mumbai, with gold medal. Fellowship in laparoscopy and robotics oncosurgery from Galaxy Hospital, Pune, under guidance of Dr. Puntambekar in 2011. He is a practitioner of oncosurgery in Solapur since last 2011 with special interest in breast and gynec-oncology. Many times I have worked with Dr. Parag and really it's very pleasure to see his surgery. And taking decision on the table is very, very desirable, very dramatic. Thank you, Parag. I request Dr. Parag to start. Yes.
Thank you, sir, for the kind words. First of all, I thank the Solapur OBGY Society for giving me the invitation to deliver this talk. And I also thank my dear friend and colleague, Dr. Bhushan Zade, who in his busy schedule, he could come and give a very insightful lecture upon the advances in radiation oncology. Now, we'll look at the surgical management of the CS cervix part a little bit. We all know that it is one of the third most common cancers in India and worldwide, and top 3 among the leading causes of mortality. We all know the theory that it is HPV associated with 99.7% of cervical cancers having HPV positivity. And the 2 most common types of cervical cancers are squamous and adenocarcinoma. The difference is that this what we call known as transformation zone. Anything outside this commonly develops into squamous, anything inside this develops into adenocarcinomas. So we know this, the transition of the malignancies from low-grade CIN, CIN1 to CIN2, CIN3, and ultimately invasive malignancy. So this is all theory. We need not go into details as much. Now, when you are treating any malignancy from surgical point of view, the 3 things which we need, the dogmas that need to be answered are whom to operate, which patients should you select to operate. Next is ideally how much to operate, that is what is the extent of radicality of surgery. And lastly, how to operate, that is what your style of operating which you are going to proceed. Now, most of us get stuck on this point only. The classification of FIGO classification, revised FIGO classification of cervical cancer. Because if you can see, there are at least 15 subtypes of subgroupings of classification. And because we are not very much aware of this staging of cervical cancer, our management decisions sometimes go haywire or for a toss, and we are not able to judge it. So, just to simplify, especially for the students out here, what we need to understand is stage 1 is limited to cervix, stage 2 is just coming out of cervix, stage 3 is extensively invading into the pelvic tissues, and stage 4 is metastatic. It's just broad classification. And you must understand this one new stage has been added, 1B3. Initially it was 1B1 and 1B2. Stage 1 is anything that is confined to the cervix. Stage 1A is always microscopic disease detected at the histopathology, and stage 1B is visible disease. Now that is classified as 1B1 less than 2 centimeter, 1B2 more than between 2 to 4, and 1B3 that is more than 4 centimeters. 2A that is involvement of the upper 2/3 of the vagina without parametrial involvement has been now subdivided into 2A1 and 2A2 less than 4 and more than 4. Other stages we all know. One more addition that has come in the recent classification is classification as 3C. That is involvement of pelvic and para-aortic lymph nodes. Pelvic lymph nodes are grouped as 3C1 and para-aortic are 3C2. Other things are as before. So now, if we just look at the broad overview, which patients are surgical candidates, we have to see this side. The red sides are the surgical candidates, right from CIN1, CIN2, CIN3, right up to 2A. Broadly speaking, these are the candidates which will come up for surgery. Beyond that, it is, as sir said, it is either radiation, or if it goes beyond that, it is chemoradiation or chemotherapy alone. So let us start with the earliest lesions, that is 1A1 and 1A2 febrile lesions. Normally the treatment is conization or excision. Conization and excision are interchangeable words. As long as you get good negative margins, either way it is good. Conization, excisions are preferable for patients who are young patients who desire fertility. Otherwise, simple hysterectomy is good enough for them. Most important thing is the histopathology reporting should be done by a good oncopathologist, and negative margins on the histopath report is must. Otherwise, it is not a complete treatment. Now, since we are on this topic of early stage cancers, and now patients are coming at a younger age, and even the age of pregnancy is also getting more and more delayed, we must have a little bit overview about what are the fertility sparing techniques available in management of CA cervix. Now, first of all, if any patient wishes to have a future pregnancy, the malignancy detected has to be either a squamous cell CA or HPV associated adenocarcinomas. Anything other than that, like say sarcomas or some other histopathology or HPV negative adenocarcinoma, you cannot offer them. That is a exclusion criteria. After this is fulfilled, you go for a radiological lymph node staging. Either you do CT, MRI or PET scan. If the lymph nodes are positive, again the fertility sparing technique cannot be offered. That is a full stop. You go to the next step. Now, once the lymph nodes are negative radiologically, you go for the tumor size. So, if the tumor size has crossed to more than 2 centimeters, again it's a full stop. You cannot go for fertility sparing techniques. So, basically please remember, squamous cell carcinomas or HPV associated adenocarcinomas, no nodes on CT, MRI, PET, and 2 centimeters or less in size. Then only you can proceed or think about fertility sparing, otherwise it's a big no-no. Once this is done, you have to do a intraoperative lymph node staging. That is lymph node, either sentinel or lymph node biopsy and lymph node, you do the lymphadenectomy. The lymph nodes, if they are positive, either on sentinel or lymphadenectomy, it is again you have to abandon the fertility sparing technique. Please understand, the lymph node positivity is a total contraindication for fertility sparing techniques. And if the lymph nodes come negative, then depending on the stage, whether it is 1A1 or 1A2, you can go for a conization or a simple trachelectomy with a cerclage. If it is 1B1 tumor, then you have to look for the lymphovascular space invasion. If that is negative, then again you are proceeding with conization or simple trachelectomy. And if it is lymphovascular space invasion is positive, then you have to go for a radical trachelectomy with a cerclage and standard lymph node staging. So, this is a picture of a simple trachelectomy where you remove the whole of the cervix except a 0.5 centimeter of the rim of the cervix where you put your cerclage stitches. And then obviously after this the pregnancy will be a high risk pregnancy. It has to be managed in the dedicated fertility center with a high risk pregnancy management. Similarly, you can do a abdominal radical trachelectomy where you can see the margins of resection are wider, but the upper cut is the same. 0.5 centimeter of upper cervix is left, and then you take a circular stitch here and you do proper lymph node dissection, and you have to do ovarian transposition. Get the ovaries out of the radiation field. As Dushan sir will agree, it's very much easy to spare the ovaries once the ovaries are out of the pelvis, and you can safely radiate the pelvic field. Now, this is a question that comes up a lot of times. We have done simple hysterectomy and you get a histopathology report of CA cervix. Very, very, very common. Now, what are the current recommendations? People get very worried what to do. साधी hysterectomy केली आणि अचानक report असा आता काय करायचं? So, current recommendations are very, very clear. Any tumor that is less than 0.5 centimeters on histopathological reporting does not require any further treatment. Please be understand this. Provided that there is no lymphovascular space invasion, LVSI. This has to be properly reported by a pathologist that there has to be no LVSI. So what happens if there is a LVSI or if there is a tumor is more than this? Then we have to go for a comprehensive lymphadenectomy. That means you have to do a completion lymphadenectomy. And obviously the size is more than obviously adjuvant radiation, chemo will be decided. But please remember, anything less than 0.5 centimeter with no LVSI, you don't do anything. If there is only LVSI with less than 0.5 centimeter, just do lymphadenectomy, that's it. If the margins are positive at resection, then it's a complicated thing. You have to go in and you have to do a vault revision Wertheims. It's a very, very tedious and complex procedure with high morbidity with pelvic lymph node dissection, but it has to be done. So these are the guidelines for instantly detected CS cervix on simple hysterectomy. Now let us go to the next step. 1A, 2 unfavorable groups, 1B1, 1B2, 2A, and as the Bhushan sir was saying, selected 1B3 depending upon the patient morbidity and tolerance to side effects, and some 2A selected 2A cases. The treatment, again I am using the word preferred treatment of choice. It is not standard treatment of choice. It is a preferred treatment of choice after proper counseling and discussion. The treatment is Wertheims hysterectomy, what we call as radical Wertheims hysterectomy. Now historically, Peever's classified hysterectomy as, we know, type 1, type 2, this is Peever's classification, type 1, type 2, type 3, type 4 and type 5. This classification was quite in vogue till now, but now we have shifted to Kurlo-Monro classification. What we are clinically we are doing nowadays are type 2 Wertheims. Very rarely we are, with good radiation and chemo, very rarely we need to do type 3. Type 4 is nearly not done, and pelvic excentrations are only reserved for recurrences or complex tumors. So this is an overview of what we do in type 1, type 2, type 3. It is basically how much of parametrium you resect and how much low down on the vagina you go for margins, that determines the radicality of the surgery. Type 1 is simple hysterectomy, or what we call as extrafacial hysterectomy. Type 2, where ureters are dissected and transected at the uterine arteries ligated at the crossing of the ureters, and you can see that only 1 to 2 centimeter upper vagina is removed in type 2. Type 3 you go right down and remove upper 1/3 of the vagina. In type 4, 5 we are not doing so, there is no point in discussion. Basically you have to remember that where the cardinal ligaments are cut, medial half in type 2, type 3 you take the entire width of the parametria, what we call as cardinal ligaments. So that is the extent of resection, how laterally go in the pelvis and how deep you go in the pelvis, that determines the radicality of the surgery. Now please understand what is the difference between a simple hysterectomy and radical hysterectomy. Can you see this black line? This is your resection margins when you do a simple hysterectomy. And this yellow line, you have to go down, dissect here, come up and go here. That is your margins for radical hysterectomy. If you see from the another angle, this is the ureter. You can see that you are going so wide, again you are coming back, you are again going down, you are going wide, coming up, going down on the vagina, cutting the vagina here, and then the same procedure is repeated on the other side. In normal hysterectomy, you are just taking cut here. So this extra thing is what is called as radical Wertheims hysterectomy. Now, when this is especially students, I think they should understanding the surgical spaces in 3 dimensions is extremely important. This is a top-down approach. The cervix is in the center, the bladder is in front, and the rectum is behind. So these spaces, this is the paravesical space, this is the pararectal space. This can be divided into 2, Okabayashi space and Lasko space, but for all practical purposes, let us consider this as one. So this is paravesical space, this is pararectal space, this is the cardinal ligament. Now it is not called as cardinal, it is known as the lateral parametrium. This is the uterosacral ligament, now it is known as dorsal parametrium, and this is the ventral parametrial tissue. So you have to understand that cervix has 3 attachments: ventral, vesico-uterine and vesico-uterine and vagino-uterine ligaments. Laterally is the cardinal ligaments and posteriorly are the uterosacral ligaments. These 3 ligaments are the ligaments where the tumor spreads along the lymphovascular emboli channels and perineural invasions. So margins, good margins here are paramount. There is no point in just removing this cervix. You have to open up these spaces, you have to free these ligaments and then get good margins. So this is the diagrammatic representation, looks very complex, but just this is the uterus, this is the this is the vesicovaginal space, this is the rectovaginal space, these are the vessels on the side. The ureter is here going by this side. This is the internal iliac artery, which after giving the uterine artery forms the obliterated umbilical artery. And you can see these all attachments have to be taken separately to get good margins. Now, just for just explanation purposes, let us see how we proceed with the Verdymes. Obviously, the first step is you take the clamp and cut the round ligament and you open the peritoneum on the lateral pelvic wall. The most important step is this incision of the pelvic peritoneum and exposure of the, now you can see the ureter is being exposed here and the iliac vessels are being exposed, and here only you get the spaces. So you take the ovarian vessels at the origin so that you can dissect the lymph nodes here. Once you have opened and you dissect the ureter, this is the ureter, you medialize the ureter first. You take it on the medial side, the vessels are exposed and you develop these spaces. This is the pararectal space, this is the paravesical space. And in between this is the cardinal ligament across which the uterine artery is crossing into the into the uterus. Once you open these spaces, the vessels become bare and you can proceed. Now the next step is go medially again. You take the posterior cut in the pouch of Douglas. You go anteriorly and you take the vesico-uterine pouch cuts. So the anterior and posterior cuts are taken. After this step comes the lymphadenectomy. You have to do the complete pelvic lymphadenectomy, starting from here, common iliac vessels, right up to the, ideally up to the inguinal ligament where the femoral lymph node of Clock is situated here, just here. This is the field of your lymph node dissection. You start by laterally taking of the tissue of the external iliac vessels from medially. You go right down, this is the external iliac vessels are completely bared. This is the internal iliac vessels. This is the obturator fossa. Obturator fossa needs to be completely cleared right up to the obturator nerve. You have to go go down, stop at the obturator nerve and then come up. Don't go below that because you will damage the internal iliac and pudendal pelvic plexus. The bleeding is uncontrollable there. So right up to the obturator nerve, you have to completely remove the obturator, bare the obturator fossa. Then come up, now both external iliac, internal iliacs, right up to here is bare. You have to come up to the common iliac and up to the sacral nodes. So this is your limit of dissection. Normally, we normally don't do para-aortic lymph nodes in regular cases. Only if these nodes are obviously positive on PET, we go up to para-aortics, but normally this is sufficient for us. Now, after this, we complete our dissection of the paravesical space. You can see that this is the uterine artery and this is the superior vesical artery. So this is our limits of dissection. You take the uterine artery where it is crossing the ureter, ligate it and keep the ligature long so that it acts as a good landmark for traction. And once you ligate and lift up the uterine artery, the cardinal ligament is bare. So this is our lateral parametrium. Now this is where you are going to take your lateral cuts. So below the uterine artery comes the uterine veins. We know the water under the bridge, classical theory. Once you take the uterine veins, now you can take the the cardinal ligament. So this is now lateral ligaments are now dissected. Now you go behind, again now lateralize the ureter again, go behind and now take the uterosacral ligament in the rectouterine space. You can see this. This is the hypogastric nerve that is there. This obviously gets divided with this, but you have to take it way this uterosacral ligament is taken at least with 3 to 4 centimeter margins here posteriorly. So now laterally you have taken the cut, posteriorly you have taken the cut. Now this obviously you will repeat the same thing on the other side. I am just discussing on one side. So these two cuts are done. Now you come anteriorly. Now you expose the vesico-uterine ligaments. Now the vesico-uterine ligament actually has two parts. One is called as the ventral vesico-uterine anterior leaf or the ventral leaf of vesico-uterine ligament and the dorsal, the posterior leaf of vesico-uterine ligament. Quite complex, but unless you know the anatomy, you are not going to be able to operate in these parts. Now this anterior leaf is what is commonly called, you must have heard as the ureteric tunnel. This is the ureteric tunnel where there are small venous branches, and you have to take this right up to the ureteric insertion into the bladder. So now normally in type 2 hysterectomy, only the anterior leaf of vesicouterine ligament or ureteric tunnel is need to be divided. You don't need to go for the posterior leaf, that becomes type 3 hysterectomy, and because you want to go down more on the vagina. This is enough. Here if you take this, you get 1 to 2 centimeter of margin on the vagina, that is sufficient. So as for theoretical purposes we are discussing, this is the posterior leaf of the vesicouterine ligament. We are way down on the vagina now, and this is rarely done now, because once you go so down, you are going to damage all the pelvic splanchnic nerves and going to cause immense morbidity, bladder dysfunction. So normally type 3 Wertheim's is reserved for extreme cases. So just for theoretical purposes, this is the posterior leaf, and these are the levels of transaction. Still the ligaments are not over. You think this is then there is one more ligament. There is something known as recto-vaginal ligament, which is the attachments of the posterior part of the lower part of the what you call as paracolpium, the posterior part of the upper vagina. It is adherent to the rectum. So these ligaments have to be separated. After all these ligaments are properly transected, now you are getting this good margin on the vaginal cuff. You can appreciate this margin. So ideally 1 to 2 centimeter of margin is recommended. More than 2 centimeter is not recommended because of damage to the parasympathetic nervous system, leading to significant bladder dysfunction. So as we were discussing earlier, your Peever's classification was type 1 to type 5. Now the classification has changed to I don't know how to pronounce this, but Kurlo-Moro classification. Now we classify as type A, B, C and D. Type A is simple hysterectomy, or what you call as extrafacial total hysterectomy. Type B is what is known as type 2 radical hysterectomy that we are doing. Type B is now again subclassified to type B1 and type B2. B1 is which is standard type 2 radical hysterectomy, and B2 is nerve sparing radical hysterectomy. Type C1 is where you go right up to lateral pelvic wall. Posteriorly uterosacrals are taken at the sacral attachments, and anteriorly you go down on the vesicouterine ligament, you go down right on the paracolpium and take the big segment of vagina. These are nowadays not done with advent of good radiation therapy. These surgeries are now getting nearly obsolete. And these type D, that is very rarely used, laterally extended parametrectomy. That is, if you have a large mass in the parametrium, or it's an extended lymph node mass which is sitting in, say, obturator fossa, then you have to go right up to lateral pelvic wall. This is very morbid, very rarely done. So we have to understand that lot of nerves are damaged during radical hysterectomy. So now the new concept is nerve sparing radical hysterectomy, where you preserve the hypogastric nerve, this one going through the uterosacral ligaments, inferior hypogastric plexus, which is going through the cardinal ligaments laterally at the lower leaf, and pelvic splanchnic nerves, vesical nerve branches and ureteric nerve branches, they are anterior in this fold. So one nerve goes from here, posterior attachment, one nerve goes from here in the cardinal ligament, and other nerves are here. So when we preserve these nerves, that becomes a nerve sparing radical hysterectomy. It is preferred for only small 1B1 tumors. Larger tumors it is not possible. As far as possible, at least try to preserve the hypogastric nerve which is going along the uterosacral ligament, and the inferior hypogastric plexus which is going along the cardinal ligaments. This is very important. If you know where to look, you will find the nerves. If you don't know, you will randomly cut the nerves. Now, we might think this is so difficult, let us do it with laparoscopy, we will not damage the nerves, we will not damage this thing, who is going to learn all this tedious surgery. So, a lot of papers came out which suggested that ORH is open radical hysterectomy is associated with significant morbidity. As we know, bladder dysfunction, blood loss, need for blood transfusions, delayed recovery times, and all such things were associated obviously with such a large open surgery. So many retrospective studies came up which showed that laparoscopic surgery causes less perioperative complications, shorter hospital stay, and less blood loss. So based on these papers, laparoscopic surgery or robotic, which is a modified version of laparoscopic surgery, suddenly became a standard of care, and everybody started doing laparoscopy or robotic surgery as per the facility available. Then this trial came, the LACC trial, very landmark trial. The trial is laparoscopic aspect in cervical cancer trial. This was the first multi-centric randomized control trial where this was published in New England Journal of Medicine in 2018, where they approximately 700 patients were randomized to open surgery versus laparoscopy / robotic surgery. Just look at the outcomes. The findings were the patients were randomized to minimal invasive surgery arm had lower rates of disease-free survival and also overall survival. The overall survival was significantly less with a higher rate of local recurrence than compared to open abdominal surgery. So this landmark paper in 2018 suddenly changed everything. Suddenly people understood that laparoscopy or / robotic was not as safe because we can see the data. I don't know if you can see the images here, but the graphs are clear cut. Now this is the disease-free survival. You can see the disease-free survival, the open surgery is maintained, but as time goes by, in minimal invasive surgery, the disease-free survival graph is going down slowly and surely. Look at the graph for overall survival. The upper graph is for open surgery, the lower graph is for minimal invasive surgery. As time goes by, the survival starts becoming poorer and poorer. Again, the same plot, disease-free survival, and the loco-regional rates. Can you see the loco-regional rates? In minimal open surgery, they tend to be relatively flat. But here, as the time goes by, there is a sudden spike in local recurrence rates in minimally invasive surgery. So this is a very important landmark paper which shows that laparoscopy or robotic surgery was not very safe in cases of CS cervix. Obviously, the industry was not going to take it light down. So somebody, this Greg Marchand et al., he did a meta-analysis. Meta-analysis is analysis of all the trials that are available all over the world. So they compile all the data, they put the data in a processor, and then they tabulate the outcomes to find the variability for chance. And this report came out in 2023. The earlier report was, the LACC trial was 2018. So they did a meta-analysis and they showed that there is not much difference between open radical hysterectomy, laparoscopic radical hysterectomy, and robotic assisted radical hysterectomy. So this was a dilemma. Now one trial is saying this, other meta-analysis is saying this. So based on this, the NCCN and also European Society of Gynec-Oncology, the guidelines decided to take a middle path, whom to recommend laparoscopy or robotic surgery. They said that minimal invasive approach may be considered only in low-risk tumors, say less than 2 centimeter tumors. This should be done, laparoscopy or robotics should be done only in high volume centers with surgeons having good experience in performing minimal invasive surgery, and after comprehensive discussion with the patients regarding the evidence available regarding laparoscopy versus open. So they kept it open. You can do it either open or you can do it lap. But it was not done. LACC is now again back. This is the latest. Now this is Journal of Clinical Oncology, 2024 March. Again they have said that, now if you, I don't think we are able to read this, but if you see this is not 5-year data now. This was a publication in 2018. Now the data is now more mature. Now the data is saying that disease-free survival was 85% in laparoscopy arm and 96% in the open group. Secondly, the rate of overall survival was 90% in laparoscopy and 96.2% in the open surgery arm. All these data are statistically significant. If you see the overall survival data, 90% versus 96%, the p value for this is 0.007. For all the students, I must, this is a reminder that statistically anything less than 0.01 is statistically significant. That means this observation is not by chance, this is actually factual. So such a significant statistical difference, 0.007, with a hazard ratio of 2.71, which is a significantly high hazard ratio, with a confidence interval of 1.32 to 5.59. Please understand, for all the students here, confidence interval, if the confidence interval, first of all, you must understand, if it is broad, it is significant, the gap is high. Secondly, it should be on either side of 0, then only it has a significant value. If it is minus 0.5 to 5.59, then there is some statistical error. So for students I am telling this, how to read this? Confidence interval should be on either side of zeros. You can see this. The confidence interval for DFS is in minus 15.8 to minus 6.3. But it is on one side of 0, so it is significant and the gap is high. So this is also significant, and overall survival, the confidence interval is 1.3 to 5. So the gap is high and it is on one side of 0, so again it is significant, and p is 0.07. So with this strong data, now the recommendations are clear. Open approach should be the standard of care for current management of surgical management of CS cervix. There is no two ways about it, or there is no ambiguity left whether we should do, whether we should not do. They have very clearly said now open approach is the standard of care, and laparoscopy should not be done outside of clinical trial settings. So this is the take home message that I would like to give to this. Thank you very much for the patient listening.
Thank you very much, Dr. Parag, for taking us from about the journey of the surgery in cancer of the cervix. Actually, you have brought a very good understanding about what cases to be selected and what should be the approach. You also threw a light on how to deal with the cases of cancer, cases where the simple hysterectomy was done.
Yes, ma'am.
And then later on you found out there was a cancer of the
Incident,
cervix.
yes, ma'am.
And I must say that this also gives a message that we must be doing screening of the cervix before the patients are subjected for any kind of hysterectomy. You also discussed about the limitations of the surgery and where to choose and what are the demarcations for the surgery, the type of the surgery. The important fact that he has brought about is about the LACC trial, which has thrown a light on what should be the standard approach to the surgical management of cancer of the cervix. The last question that I would like to ask you is about the making of a oncosurgeon.
Yes, ma'am.
And any kind of a surgery, for example, in CS cervix, like any importance of cadaveric dissections or anything that you would like to say?
Madam, cadaveric dissections is a very good way to learn, but nowadays with the advent of AI, with three-dimensional models available, with virtual dissection spaces available, now actually the necessity of cadaverics is going down. Okay. So in US and all these centers, the three-dimensional models where actually you can operate on them in real time, and you can make mistakes, you can correct your mistake, go back, and then actually personally, we have worked in Tata, we feel that the best way is to work in a high volume center. Yes. And see the cases, do the cases, see in spite of such high volume centers, there we see lot of what can go wrong, how can manage complications. Because I think in surgery it is not about how to manage complications is more important rather than how to operate the cases.
Absolutely. Thank you very much. Any questions from the audience?
Trachelectomy, no ma'am. We do not routinely do it is only done in dedicated high volume centers with good fertility in IVF setup backups. Ideally it should not be done because you might you might do more damage than good actually.
Dr. Parag has beautifully taken us through all the pictorial representation in the various spaces in the pelvis.
Yes.
And I think that's very important in dissection. So it was a very beautifully narrated.
Yes.
I just wanted to add one point about trachelectomy. Madam asked, it should be done only where endovaginal MRI coils are available. Before doing a decision to do a trachelectomy, you have to identify the tumor size, what is the length of the endocervical canal. These informations can be had only when you do a endovaginal MRI.
Coil MRI, correct.
Only then you should attempt a trachelectomy.
So all the infrastructure should be available to back you up.
Yes, exactly. And endovaginal coils are available in
very few centers.
in the world actually.
Okay,
I doubt
sir.
whether any center in India also has
Correct, sir.
endovaginal coils, MRI coils.
Yes.
We have also seen some cases where there has been lesion in the cervix, especially the endocervical, and then it has given a pyometra or accumulation of the fluid in the uterus and causing enlargement of the uterus as well. So how do you deal with it?
As madam, common occurrence presenting with pyometra, but what I have in renal practice, what I have found is normally these are advanced lesions. They are not amenable to surgery most of the times. Now the problem is with uterus filled with pus, they can't read it also. So in fact, once normally we do DNC and evacuate the pus from below.
It's very difficult to locate the cervix also.
Yes, it's a little bit risky, but once I had a patient whose uterus was so bulky it was coming up to umbilicus. So laparoscopically I did the decompression of the uterus, the pus was removed, and then we referred to radiation therapy.
Okay.
So normally pyometras will have to be drained before we have to, otherwise the complication will be too much. So preferable to do evacuation under GA, so that we have some margin to manipulate, time to manipulate. And with experience, we get the way to open the cervical canal. But that's a very valid question. It is many times that is an impediment to further treatment. Neither chemo can be given, neither radiation can be given. So it's not operable. So we have to evacuate and then proceed. Small collections can be sent directly for treatment, but big ones have to be emptied.
How do we prevent actually leaking of the lymph? Because when you do the lymphadenectomy and sometimes when the drain is kept, it keeps on draining for some time.
Yes.
So how do we prevent that kind of a thing?
There are many trials which try to reduce the lymphocyte formation post-operative. One was you clip the lymph nodes, lymphatics, while dissecting. Other was you try to avoid cautery and do Caesar dissection, but statistically they showed that there is no benefit of doing all these things. The amount of lymph is actually depend on how much lymphatic blockade is there actually, how much disease has spread to the lymph nodes. If the lymph nodes are not much involved, the lymphatic collections post-op are not significant. But if there is a significant tumor burden, the lymphatic channels are blocked, then you are going to get a lot of lymphocyte in the post-op period. So it is not that difficult. We can simply aspirate it USG guided or CT guided. That is not, or put a pigtail afterwards. So that it doesn't doesn't cause much morbidity, ma'am.
Thank you very much. It was very enlightening.
Thank you.
Insightful. Thank you. Now I would like to call upon Dr. Virupaksha Joshi, who is a radiologist. He has completed his undergraduate study from Karnataka Medical College and in Hubli. He has obtained his postgraduate diploma in radiodiagnosis from Mysore Medical College in 1991. So he has honed some preliminary skills in the science of radiology by working in various hospitals and diagnostic facilities in Pune and in Mumbai for many years. Finally, through some stroke of providence, he has landed in the textile town of Sholapur in the year 1995. I'm sure you are happy with it. I'm working, and he is working as a consulting radiologist in Ashwini Hospital since then. Thank you. Welcome, Dr. Joshi.
Thank you, madam, for the kind words. I said because of stroke of providence, because you must be wondering this fellow has come from Karnataka. Why did he end up in Sholapur? So this question many people have asked me. That's why I say it is a stroke of providence or luck or whatever it is. Yeah, anyway, a very good morning to you all. I'm going to need a pointer because I'm an imaging specialist and I have a lot of images to show. This is the one? I need some help. There. F5 button is not operating.
You want this full screen?
Yeah, full screen. Okay.
No, but then it's happening.
Yeah, thank you. For the next 30 minutes or so, I'll be talking about the importance of cross-sectional imaging in cervical cancer. The main purpose of my talk is to familiarize you with how an MR or a CT image looks. Because when some patient comes to your clinic with an MRI or a CT report, you should be able to identify and correlate with what the report is telling. And why not? The thing is, a neurosurgeon knows everything about imaging of the brain and spine. A neurosurgeon knows everything about imaging of kidneys, ureter, and bladder. So gynecologist is justified in wanting to know about imaging in uterus, cervix, and ovaries. So if at the end of this talk, if you can go home with how to identify a normal cervix, abnormal cervix, growth, and how various stages of cervical cancer the images look, and I think the purpose of my talk will be accomplished. At the outset, I like to thank Dr. Amrita for inviting me. One fine rainy evening, I received a phone out of the blue. Dr. Joshi, would you like to give a talk on imaging in cervical cancer? I immediately agreed because imaging of the pelvis is something which is very dear to my heart. Okay. Now, as you all know, cervical cancer is the fourth most common cancer globally after breast, lung, and colorectal cancer. And the imaging is very important in accurate staging and treatment planning, as we have been told. Now, 2018, FIGO staging underwent a reclassification. This staging gave a lot of importance to cross-sectional imaging for accurate staging. And in this 2018 updates, lymph node involvement were taken as an important staging criteria. And MRI and PET CT came in a big way as far as detecting the tumor size and the metastasis. Of course, this is the staging. This is there in every textbook and all over the internet. I don't have to go in detail about it, but just quickly run through this. Stage 1 is tumor confined to the cervix, disregard extension to uterine corpus, important thing. Earlier, it used to be said that if the cervical growth has involved the uterine cavity, it was considered as a very higher stage, but nowadays it is not so. And 1A Stage 1A is stromal invasion, and this is only by microscopy. There is no role for imaging in it. And 1B is when the stromal invasion is more than 5 millimeters. Of course, there are sub-classifications. Less than 2 centimeter is 1B1, between 2 and 4 is 1B2, and more than 4 centimeter is 1B3. Stage 2, here the invasion is beyond the uterus, but not to the lower third of the vagina or the pelvic side wall. Here 2A is invasion is limited to the upper two-thirds of the vagina, whereas 2B is parametrial invasion. In stage 3, we have invasion of lower third of the vagina, pelvic side wall, or causing hydronephrosis. And stage 3A is invasion of the lower third of the vagina, and stage 3B is invasion of pelvic side wall and or hydronephrosis. And of course, stage 4 is invasion of bladder, rectal mucosa, or the distant metastasis. There are some important differences between the classification which was done in 2009 and 2018. In stage 1B was recategorized depending on the tumor size. Anything less than 2 centimeter was 1B1. Between 2 centimeter and 4 centimeter was 1B2. More than 4 centimeter was 1B3. And in 2018 classification, lymph node involvement at the time of primary diagnosis and lymph node involvement detected on imaging was given a lot of importance, and that is stage 3. And again, as you know, it has been subcategorized into 3C1 and 3C2. Stage 3C1 is pelvic nodes only. Stage 3C2 is pelvic node and para-aortic node. In 2018, a lot of importance was again given to MRI for accurately measuring the tumor size and depicting the parametrial invasion. As you have been told already, the tumor size matters a lot in deciding whether to operate or to give radiotherapy or chemotherapy. So how the tumor size measurement is very important, and MRI is very crucial in measuring the tumor size. And of course, the parametrial invasion will go more detail as we proceed further. Now here, this slide is not to, it's the main purpose of this slide is to tell you as to what is the rationale behind reclassification which took place in 2018. In 2018, the stage 1A was, the definition itself was altered. Here, the depth was considered of the stromal invasion instead of width. That was because it was noted earlier that when a histopathologist reported, there used to be a lot of artifactual errors. So to avoid those errors, stage 1A was reclassified. And stage 1B, again, as I said earlier, depending on the size, here, what are the importance, what are the rationale behind reclassification in stage 1B is, one important paper was Matsuo et al. It was a landmark study which appeared in 2018, which said that patients with tumor size of less than 2 centimeters had a twofold increase in the survival when compared with those with tumors measuring between 2 and 4 centimeters. So that is why the tumor size was very important. And in stage 3C, lymph nodes, it was noted that nodal disease is a very important prognostic indicator for 5-year survival as well as local recurrence after the surgery. So it was important to include imaging, lymph node detection and imaging in stage 3C. And again, in cross-sectional imaging has established a role in the depiction of lymph node disease. So importance of CT MR imaging for lymph node detection was very crucial for stage 3C. Yeah. Now, what are the imaging modalities that we have available for imaging? We have MRI, we have CT, and we have PET-CT. MRI, as you know, it has got a very superior soft tissue resolution and a contrast, and it is essential for assessing the tumor invasion, depth, as well as the local extent of the lesion, of the disease. Of course, CT is useful for detecting the nodes and for distant metastasis. Comparable to MRI, in some staging, it is less detailed. I will explain it as I go further. And PET-CT, increasing role in evaluating nodal disease and metastatic spread. Metastatic spread and nodal disease are, as you know, are very crucial, and PET CT has, since it has got an overall picture of the whole body, it is important. Can I just go ahead without the, what happened? My laptop is charged. Yeah, we have got, other than PET CT, CT and MRI, we have other additional tools for staging. IVP, of course, IVP has become redundant now. I don't remember what was the last time I did an IVP for detection of kidney function or ureteric involvement because of the good CT scanners now that we have. And we have got cystoscopy for assessing invasion of the bladder, mucosa, and the urethra. As earlier speaker said, about taking biopsy if there is a mucosal involvement. To prove that there is a mucosal involvement, we need to have a biopsy. So in there, probably cystoscopy has a role. And then sigmoidoscopy, barium enema, this is history. Nobody does these things for vision because we have got such good MRI and CT techniques now. And of course, chest X-ray for metastasis in the lungs. Yeah, now the pictures. Here, you are all familiar with ultrasound. In fact, you are quite good in ultrasound. So this is the abdominal imaging of the cervix, transvaginal, and here we have got MRI in the sagittal and coronal plane. I want you to concentrate on the ultrasound image, especially if you have a very good resolution ultrasound. This black ring that you are seeing, this is what represents the stroma of the cervix. And of course, this is the endocervical canal between the two arrowheads. Now, see how strikingly the ultrasound image resembles the MRI image. This dark ring that you are seeing here, which is called hypointense, that is the term used for MRI descriptions. This is the stroma. This is the stroma and the endocervical canal in the sagittal plane, and this is in the coronal plane. The importance of that hypointense ring, I will say further when we go ahead. This is the same image, much better, much more graphic details. Everything is labeled here. Internal cervical os, external cervical, endocervical canal. And what is important again is the cervical stroma. This ring, dark ring, is very crucial for depicting the stage of the disease. Whether this ring is intact or not decides whether the parametrium is invaded or not. Now, uterus, cervix, vaginal cavity, they look different in different age groups. In a 30-year-old lady, in a reproductive age group, the myometrium, endometrium, cervix, stroma, they're all very graphically represented because of the soft tissue resolution. But the same thing in a 70-year-old lady, after menopause, everything looks like one dark mass. So it's very difficult to differentiate between the various layers. This is important to note when you are reporting an MRI. Now we have got CT versus MRI. Many times, often we get a request, some oncosurgeons or surgeons prefer a CT scan, some prefer an MRI. When they ask for an investigation, some people ask for CT, some people ask for MRI. So I think it's very important for us to understand what are the limitations of each modality and what are the plus points and negative points of both. When it comes to CT, it is not a very useful for primary diagnosis. It's very important to remember. And it is used mainly for lymph node detection. And of course, CT is very useful for advanced disease and distant metastasis. For example, if there are mets in the lungs, for that CT is important. And it is used for guided biopsy or aspiration. So if you have a para-aortic lymph node mass or a collection to aspirate it or to get a biopsy from a lymph node mass, so in that case, CT is very, very important because we have a real time. You can actually see the needle tip going into the mass and then take out a tissue from there. which is not possible on MRI. Of course, there are some centers where MRI guided biopsy are also done. Whereas when MRI is concerned, it's important to note that the disease must be at least stage 1B to be detected on imaging. Anything less than 1B is not detected on even a very good quality MRI. So then MRI is useful for primary imaging because of its आता हे लूज आहे काय MRI is useful for local extent, such as invasion into the parametrium and involvement of the bladder and rectum. Now here we have a primary growth involving the cervix. This is an ultrasound image on the left side, and we have a MRI sagittal image on the right side. As you all know, there is angiogenesis, and so this is a very vascular. When you put a color Doppler, you get a lot of blood vessels there. And we have the arrows are pointing towards a primary growth in the cervix. Another case where there is a very big mass here, occupying almost the whole of cervix and partly the uterus. The same thing on MRI. We have the lesion between the two asterisks is the primary growth. It is involved the wall, the endometrial cavity, quite extensive tumor. Now we have another case here. This is ultrasound, and this is MRI in sagittal plane. Here endometrial canal, endocervical canal, vaginal cavity, and this is the growth. Now there's the same case in axial plane. Axial means transverse section, what we call, that is the same growth is seen like this here on axial imaging. Another case where we have this growth here on the posterior wall of the cervix. This is urinary bladder, fundus of the uterus, endometrial cavity, and then all this is the growth. Now, there is something important I want to convey. What is the role of CT in staging? Since CT has got actually relatively fewer contraindications, it is much quicker and it is widely available than MRI, especially in some low-income countries. And it's very important for staging. Aside from its use in depicting the suspicious lymph nodes, as we discussed earlier, a contrast-enhanced CT plays a very, very important role in depicting stage 3B and 4B disease. Now, we have got almost 92% accuracy for detection of involvement of the ureter, the pelvic side wall, and bladder and rectal mucosa involvement. And of course, depiction of metastasis. However, CT has a drawback. When it comes to local staging, CT is not a preferred modality. That is because 50% of the stage 1B tumors are iso-attenuating to cervical stroma. What do we mean by iso-attenuation? Here, the growth of the tumor tissue and the normal tissue, they look almost similar. It's very difficult to differentiate between that. That's why it's called iso-attenuating. And mark my words, 50% of the tumors are iso-attenuating. So for a primary diagnosis, probably CT is not an ideal modality. And another important drawback of CT scan is that for a parametrial invasion and fat standing, on CT there is a term called as a fat standing. The paracervical fat, which is actually obliterated by a tumor tissue invasion, that is the way we say whether the parametrium is invaded or not. But the fat standing can also happen in infections. So there are some fallacies involved in it. And another important thing is the cervical stromal integrity, the dark ring that I showed earlier, which is seen so clearly on MRI, is not seen so well on CT scan. So for a primary imaging, CT is not a very good modality. I'm just showing a couple of CT scan images to differentiate between how CT looks and how MR looks. Here we have a CT scan image in the axial plane. This is the urinary bladder, this is the cervix with a growth, and there is a necrosis, and then this is the rectum. And you can see that the soft tissue resolution is not all that good. The same growth in the sagittal plane. Here the uterus, endometrial cavity, the cervical lesion with necrosis. Again, the soft tissue resolution is not all that good. Another case, cervical growth, and there are lymph nodes here. This is the urinary bladder and the lymph nodes. The purpose of my showing is that you can, as we proceed further, you will yourself appreciate what are the difference between CT and MR in local disease. Yeah, now this is an important thing that I want to convey, the differential diagnosis. There are many things which in cervix which look like tumors. We should not mistake them for, all of them are not malignancies, obviously. So what are the benign lesions, or what are the mimics of tumor mimics, and how to differentiate benign lesions from malignant lesions? Apart from some very uncommon ones like lymphoma and all, we have very common ones, which is cervical polyp, there is cervical fibroid, and cervical endometriosis. These things should not be mistaken for a cervical growth. Here we have a case of cervical polyp. You can see that the polyp is projecting into the endocervical canal and into the vaginal cavity. This is a classical polyp with a pedicle, should not be mistaken for a cervical growth. And we have a cervical fibroid here. Again, the fibroid is projecting, popping into the vaginal cavity, endocervical canal. Of course, you can see that there are multiple other fibroids on the anterior and posterior wall of the uterus. Then we have cervical endometriosis. This is a endometriosis. It is a T2 weighted sagittal image. Now, we all know that endometriosis contains blood products. Here, ideally speaking, we should also have a T1 weighted imaging, because blood products are better appreciated on T1 weighted imaging. But anyway, this is a differential diagnosis for a cervical neoplasm. Yeah, now while reporting an MRI, there are certain things which we have to tick, like this is done, this is done, this is done. So what are those 6 things which we have to remember while reporting MRI? The first one is the tumor size, then parametrial invasion, the parametrium is invaded or not, vagina is invaded or not, pelvic side wall is invaded or not, whether there is a hydronephrosis or a hydroureter, and whether bladder and rectal mucosa is invaded. And of course, the last one, but very important, is a lymph node invasion. As we said earlier, CT is preferred for lymph node detection and PET CT. When it comes to tumor size, the size of the tumor should be measured in 3 orthogonal planes. What do you mean by orthogonal planes? Axial, sagittal, and coronal, 3 planes. But among all the 3, axial parameters are very important for tumor size. And we all know anything more than 4 centimeters is an important criteria for whether to operate or not. Now here, this is how the calipers, of course we have 3 different cases. One is an exophatic growth here, another one is an infiltrative growth. Here we have a endocervical growth. Now here the calipers should be very accurately placed for as accurate as possible measurement of the tumor size. Now as you can see, this yellow arrow is pointing to, can anybody tell what this can be? If this is a endocervical growth, this has to be the hydrometra or the pyometra, or otherwise called as a physometra. There is collection in the uterine cavity. Now, how does the cervical growth look in various stages? Stage 1B1, as we all know, is less than 2 centimeter. Now here we have a growth here between the 2 calipers. This measured 1.4 centimeter, less than 2 centimeter. That means it is stage 1B1. Then we have a growth here between the 2 calipers. It measured 2.6 centimeters. So it is between 2 and 4 centimeters. So that makes it stage 1B2. We have a stage 1B3 disease, where this growth is more than 4 centimeter. So this is stage 1B3. Now, as far as parametrial invasion is concerned, as we all know, what is parametrium? This is the anatomical space which is lateral to the cervix. And important thing to note here is that the reported accuracy of MRI in detecting the parametrial invasion is 76 to 92%. That's quite high accuracy rate. And another important thing is that MRI has got a very high negative predictive value. What do we mean by a negative predictive value? If the MRI says that there is no parametrial invasion, there is no parametrial invasion. So that is what is meant by negative predictive value. Important thing here, which I want to stress very much, is how do we decide whether the parameter is invaded or not on MRI? We should look at the T2 hypointense ring. I will show that in pictures as I proceed further. That stromal ring which I showed earlier, that is the hypointense ring. Whether that ring is intact or it is not intact, that decides whether parametrium is invaded or not invaded. If that ring is intact, then parametric invasion is ruled out. Now here, again, this is the same slide which I showed earlier. I just want you to notice that this dark ring is the hypointense stroma, and that stroma is intact or not. That is what we should be looking for while deciding whether parametrium is invaded or not. Now this is the case where is a transverse imaging. As you can see, this entire ring is intact here, though there is a growth in the endocervical canal. So here there is no parametrium invaded. Whereas on this side, you can see that there is an interruption here. The ring is interrupted where the arrow is pointing. So here there is definite parametrial invasion. So this is this important to decide whether parametrial invasion is there or not. I've got another case here, important to this thing, whether the entire endocervical canal is actually expanded by a growth, but actually it's a very big mass, almost 3-4 centimeters, but the ring is intact. So that means there is, even though the tumor size is very large, parametrium is not invaded. When it comes to vaginal invasion, how do we decide on MRI whether the vagina is invaded by the tumor growth or not? Normally the vaginal wall is dark, or in radiology terms it is called as a hypointense. When a hypointense wall of the vagina, when it is invaded by a hyperintense growth, then we say vagina is invaded. And of course, as we all know, upper two-third is stage 2A, lower third is stage 3A. Here we have a graphic representation of vaginal involvement. This is a growth and where the growth is projecting into the vaginal cavity. Now here this is an actual case. Here the growth which is rounded by the green lines is the primary growth, and these projections are into the vaginal cavity. And see, this is the vaginal invasion, primary growth, this is rectum. Then we have got stage 2A, where there is upper two-third of the vagina is involved. The disease between these two calipers here, upper two-third of the vagina is involved, and this is stage 2A. Here the lower third is disease-free, so it makes it stage 2A. As you can see, this dark area is the tumor. And we have stage 2B, parametrial invasion. As you can see, the ring is interrupted. There is a big growth here between the two arrowheads. And this dark arrow is pointing towards a fat plane between the bladder here and the cervix. So this fat plane is preserved. So that means bladder is not invaded. We have a stage 3 disease here, stage 3A, where the lower third of the vagina is involved. The arrow is pointing towards a growth where the lower third is replaced by the tumor tissue, stage 3A. Now we have a stage 3B disease here. Can anybody tell what this tubular structure is? This is the ureter. This is the dilated ureter. Lower end of the ureter is encased and obstructed by the primary growth here. So we have a hydroureter, so that makes it stage 3B. And then we have this. Then the same case in the axial plane. This white ring is the dilated ureter. This is the primary growth, and this asterisk is pointing towards the hydrometra, collection in the uterine cavity. Another important thing to note is about the stage 3 part, stage 3C, that is lymph node involvement. Many studies have shown that if there is a positive lymph node at the time of primary diagnosis, the possibility of a local recurrence after disease or overall survival, it is significantly changes if the nodes are positive at the time of primary diagnosis. So it becomes all the more important to detect whether lymph nodes are involved at the primary stage itself. And as many speakers earlier have said, stage 3C is divided into 1 and 2. Stage 3C1 is when pelvic nodes are involved, and stage 3C2 is when para-aortic nodes are involved. And we have these various groups of lymph nodes here. This is a CT image, of course. Sacral group, we have got obturator groups, we have got external iliac nodes, we have got inferior epigastric nodes. We should be looking for these nodes on CT image or MR image. There is an important factoid about lymph node spread in cervical cancer. Cervical cancer is, it is said that it usually follows the lymphatic pathways when it involves, unlike some other tumors which can have skip lesions. Like if you have a para-aortic node involved in cervical cancer, it is almost sure that the pelvic nodes are involved. But in some other cases, like for example, in breast carcinoma, there can be skip lesions. There may not be axillary nodes, but there may be nodes in the neck or other areas, which practically never happens in cervical cancer. And we have this stage 3C1 lymph node involvement. Again, an image here. These are the external iliac vessels. Medial to the vessels, we have this growth here, which is an enlarged lymph node. And this is an obturator lymph node, a big node, which is hyperintense, containing necrotic tissue. So this is definitely a nodal metastasis. The same disease on PET CT, as you can see, this is very clearly FDG avid. This node has taken the FDG, so it is metabolically active. The same node, and the same node here, it is metabolically active, it has taken FDG. So involvement of the pelvic nodes, stage 3C. Now here we have stage 3C2, para-aortic lymph node involvement. We have kidneys here, this node is FDG avid, para-aortic nodes, stage 3C2. Now stage 3C2 on CT scan. Here we have a big primary growth. This is a image in the coronal plane. We have got an abdominal aorta here, and then there is this para-aortic mass shown by the arrows. So this is a lymph node mantle of enlarged necrotic nodal metastasis. So this is the importance of CT for para-aortic node involvement. Then for bladder and rectal invasion, we have got a growth here in the base of the bladder. This growth, primary growth here in the cervix, has actually entered the bladder mucosa. So this makes it stage 4. So this is so clearly MRI can show whether the bladder mucosa is involved or not. Probably no cystoscopy or biopsy is not required in such, if it is so clear. And another thing is rectal invasion. We have a growth here which has involved the rectal mucosa. Now stage 4B, another case where the bladder mucosa is affected. Here one important thing to remember, as Dr. Parag said earlier, there may be times when the growth can just push the bladder or the rectum to one side, and it may not actually, mucosa may not be involved. So and it may be tumor-induced edema, can look like a tumor. So in that case, we need to probably a biopsy, cystoscopy and biopsy is required. But in this case, it is quite clear that the bladder mucosa is involved, so it makes it stage 4B. Now stage 4B, pelvic lymph node and hydronephrosis. This is the dilated ureter, a lymph node here, obturator group of lymph node, which is metastatic, and that is the primary growth. Here, we have a case where pelvic side wall is invaded. All this dark tissue outlined by the yellow line is where the pelvic side wall is infiltrated by the cervical growth. And this is how the primary growth looks on MRI, and the primary growth is so FDG avid on PET CT, and we have got a lymph node here, obturator lymph node, which is FDG avid, and this is the same node circled is the FDG, is the nodal metastasis. And incidentally, we have a presacral node. Dr. Parag touched on this fertility saving surgery, which is actually more of a theoretical importance for us, because hardly we see any imaging, nor do we any surgeries, but for the sake of completion, But here, the fact that I wanted to highlight was to detect stage 1B disease, which is necessary for a trachelectomy. We need to have an endovaginal MRI coils. Only then stage 1A2 and 1B1 tumors can be detected on imaging, and then a decision to do a trachelectomy or not can be arrived at. Of course, the lesion has to be sub-centimeter sized tumor. And as I said earlier, endovaginal T2 weighted MR with diffusion weighted imaging plays a very important role in detecting the smaller growths. Then some example of endovaginal MRI. Here, this is the endocervical canal. This arrow, I don't know whether you can see, this is the such a small growth. It is hardly 10 millimeters. This growth was seen on endovaginal MRI. The same thing looks dark on diffusion weighted imaging, where there is this is called ADC maps, which is dark on ADC maps. Some more images of the endovaginal images. This is the growth here, diffusion weighted imaging here, restriction, and the same thing on ADC maps, dark. And this is the specimen, resected specimen of the cervix, where the size of this lesion, tumor, is almost exactly corresponds to what was seen on MRI. But having said that, this endovaginal coils for MRI are available in very few selected centers, and I have not seen one till now. But it's important for a young woman who is struck with a cervical cancer but who wants to conceive. So in that case, probably it may be a very important thing. Thank you.
Thank you very much, Dr. Joshi, for a very brilliant presentation. I must say that we have understood quite a bit of now CT, MRI, and PET scan, which you have taken us through. And what I really appreciate about Dr. Joshi is whenever we have referred a patient to him, he will always communicate directly with us and explain. So that actually makes the decisions very easy. So thank you very much for being with us.
Welcome.
Yes. Very nicely you have explained when MRI is to be used and when the CT is to be used.
My main purpose was that. You all know theory. I am a radiologist, you are a clinician. My purpose was to make you familiar with the images.
All images are very excellent.
You can put it on the view box in your clinic and then just see the images.
Definitely no.
Yeah, that is my purpose of the talk was.
Thank you. Any question from audience?
Thank you, respected speakers. I invite Chairperson Dr. Sampath Baldavar sir to felicitate Dr. Parag Kumtekar sir. I request Dr. Ghate madam to join. Rohini Deshpande madam. I would like to request Dr. Rohini Deshpande madam to felicitate Dr. Viruprakash Joshi sir. I request Dr. Ghate madam to felicitate Chairperson Dr. Sampath Baldavar sir. Dr. Rohini Deshpande madam. Dr. Amrita to proceed. Please, only 5 minutes. Please be seated.
In the context of today's topic, we would like to felicitate Dr. Vidya Tirankar madam and her team for conducting vaccination program at our government hospital. Madam and her team have conducted 250 plus vaccinations, both male and female, in civil hospital, and these vaccines are available at very low cost, that is only 1,200 rupees. They are available at 43 number OPD at subsidized rate at civil hospital. And I would like to felicitate Dr. Vidya Tirankar madam and her team, Dr. Prachi Jain and Dr. Shivani Godse. Please come on stage. They have conducted awareness programs at various colleges such as VMGMC Medical College, Vairag PHC, Shirvar PHC, Shivdare College, Indian Model School, Dayanand College of Arts and Science, and also conducted vaccination programs. So I request audience to give them a big round of applause for their great work. Thank you, madam. Before we go for lunch, we have a small presentation by our academic partners, Crystal Developers. So I request them to come on stage and deliver their presentation.
दिसत नाही असं त्याचं म्हणणं आहे बघा बरं दिसत नाही असं त्याचं म्हणणं आहे पण 11मध्ये असेल तर 11मध्ये दिसायला पाहिजे बाबरे म्हणून काहीतरी केलंय त्यांनी हां हे बुरबुरे सॉरी दिसतंय की काय
So, hello everybody, I am Samved Burbure and here I am representing on behalf of Crystal Developers. So, let's start with a bit of introduction about the firm Crystal Developers. The firm was started in the year of 2018 and the three main pillars of the Crystal Developers are Mr. Sunil Burbure, Mr. Lakshman Kodi and Mr. Sunil Konda and our supporting partner Mr. Pradeep Sinha Lonawat. The company had started with 0 grounds in the year of 2018 and now it has reached to that heights that it doesn't even need an introduction. Just a minute please. So, why Solapur? This must be the question. Whenever we people think of investing in the properties, we people think of investing only in high-tech cities, or metropolitan cities, without realizing that we have far more better opportunities to invest here in Solapur itself. Currently, Solapur is emerging as a hub for growth, and Solapur people are adopting the better lifestyle. And to mention specifically that we even have some good facilities, including transportation, which has airport, which is going to be soon starting in Solapur, and yes, has better road connectivity than any other cities in Solapur. There is a significant increase in demand for properties in Solapur, and as per the projection for 2024, there is a rapid rise in the growth of value. There is a rapid growth in the value for properties in Solapur, giving better opportunities for the investors to invest and even for the residents to reside. So this is the current market analysis of Solapur real estate, and it is shocking to see that the real estate market has boomed from 20-30% to 100% in the past few years. So without taking much of your time, here I represent you a very new project, Crystal Dream Space. This is the layout of our very new project, Crystal Dream Space, which is spread in 14 acres and also been divided into 3 different phases. Our site is located at very prime location, that is at Bade, near Vasant Vihar. From here, the residents have access to multiple hospitals, bus stand, and also to the railway station. And yes, we also have an easy access to our daily need shopping center, that is D-Mart. Our project Crystal Developers has all the top-notch amenities, which you won't even find in the amenities of the other high-tech cities too. So, our amenities include temple and yoga center with a walking track around it. And yes, let me mention you that that the temple is being designed and constructed by professional team so as to make it a unique structure. We also have a lake viewpoint and an amphitheater area and also children's playground and also turfs. So, there must be a question in your mind going on that why only choose Crystal Developers, and are the amenities really be going to provided by us in the society or in the project? Okay, so let me tell you, I have the answer for it. Now, so let me tell you that our firm has successfully completed 9 projects with a 0 record of negative reviews. And I'm happy to tell you that we have happily staying residents in our past projects and also happy investors too. And our founders of Crystal Developers are people of words. They don't just say it, they do it too. So, you can blindly trust us and book your dream house and plot in Crystal Developers today. Okay, and I would just like to take few more minutes of yours. There's a walkthrough video of us which will show how exactly the site is going to be.
या लहान व्हिडिओमध्ये तुम्हाला अंदाज आला असेल किंवा क्रिस्टल डेव्हलपर्सनी कुठल्या पद्धतीने एक पुण्या मुंबईच्या धर्तीवरती किंवा बेंगलोरच्या धर्तीवरती आम्ही जे सपोर्ट जे आहे बेंगलोरचे आहेत, तर एक ग्रीन सिटी ह्या हिशोबाने आम्ही ते ग्रीन ह्या बेसनी आम्ही हे तिथं डेव्हलप करत आहोत. सगळ्यात महत्त्वाचं सांगायचं की तुमच्या ह्या फील्डमध्ये हे वेगळं फील्ड आहे थोडंसं तुमच्या, पण आपल्याला एक प्रत्येक माणसाला एक इन्व्हेस्टमेंट पार्ट हे फार महत्त्वाचं असतं. आपण शेअर्समध्ये करतो किंवा दुसऱ्या गोल्डमध्ये करतो, पण आजच्या तारखेला तुम्हाला सांगतो की लँडमध्ये इन्व्हेस्टमेंट जर केली तुम्ही राईट टाईम, तर तुम्हाला इतके पैसे मिळतील याच्यामध्ये की तुम्हाला बिलीव्ह होणार नाही की मी इन्व्हेस्टमेंट काय केली नाही असं वाटायला लागेल. आणि आमचं सगळ्यात मोठं वैशिष्ट्य याच्यामध्ये हे आहे की आम्ही कुठलेही डॉक्युमेंटेशनमध्ये आम्ही कुठेही तुम्हाला कमी पडू देणार नाही. 90% ह्याचा लोन होईल. तर तुम्ही एक 25 लाखाचा जरी प्लॉट घेतला तर तो फार तर तुम्हाला महिन्याला 25 लाखाला फार एक 25,000 रुपये तुम्हाला फक्त हप्ता बसेल या 40,000 रुपये हप्ता बसेल. तुमच्या रोजच्या प्रपंचामध्ये एक लहानशी इन्व्हेस्टमेंट जर काढली, थोडंसं शांततेने विचार करा की पुढच्या 2 वर्षामध्ये 25 लाखाचे 40 लाख झाले तर कसे वाटेल तुम्हाला. कारण तुमचं प्रोफेशन असं आहे की 24/7 हे तुम्ही आहे ना कॉन्स्टंटली पेशंट, नंतर ते हॉस्पिटल मॅनेजमेंट किंवा त्याचे ते नंतर जे इश्यूज सगळे त्याच्यामध्ये अडकलेले असतात. पण हे विषय असं आहे की थोडंसं शांती आपण जर विचार केलो की आपल्यासोबतचे आता तुम्ही वेल क्वालिफाईड लोक आहात, पण तुमचं जे ग्रोथ रेट जे आहे ना इन्कमचं, जोपर्यंत तुम्ही हाताने काम करत नाही किंवा क्लिनिकमध्ये जात नाही तोपर्यंत तुमचं मीटर डाऊन होत नाही, हे लक्षात घ्या. आणि शेअर्समध्ये आहे ना आपल्याला ती माहिती नाही, रोजच्या रोज आपण मार्केटचं फ्लक्च्युएशन बघत नाही. तर आम्ही तिथं आहोत की जिथं तुम्ही आहे ना की एक ब्लाइंडली फेथ ठेवू शकता आमच्यावरती की तुमची इन्व्हेस्टमेंट ही थोडी होईल. महिन्याला 50,000 रुपये होईल, 40,000 रुपये होईल, जे काय होईल ते होईल. पण ॲट द एंड तुम्हाला एक 2 वर्षात 3 वर्षात जे काय तुम्ही थोडेफार पैसे घालत 20-25 लाख रुपये घालणार आहात, ते पुढच्या 2 वर्षामध्ये नक्कीच 40 लाख 50 लाख होईल. ते सायमल्टेनियसली इन्व्हेस्टमेंट प्लॅन म्हणून सुद्धा तुम्ही जर ह्याला विचार केला तरी खूप सुंदर आहे. आणि जी दाखवलेली ॲम्युनिटी ते 100% आम्ही तिथं आहे ना फुलफिल करत आहोत. ॲट प्रेझेंट जवळपास 40 ते 50% डेव्हलपमेंट तिथं झालेली आहे. आणि हे राईट टाईम आहे की आत्ता तुम्ही घेऊ शकता. एकदा लँड डेव्हलप झाली ना तर रेट आहे ना एक अप साईडला जात असते. तर माझी एक रिक्वेस्ट आहे की तुमच्यासाठी हा वेगळा विषय आहे कारण तुम्ही मेडिकल फील्डमध्ये आहे, आम्ही बिल्डर लोक इथं काय करतो आहे. पण आज प्रत्येकाची गरज आहे. आता माझ्याही घरात माझी मुलगी डॉक्टर शिकते. पप्पा माझं किती, आज माझ्या ना 30व्या वर्षी मी सगळं हे होणार आहे, पुढं माझं भविष्य काय. मी म्हटलं बेटा काळजी करू नको, तुझ्या नावाने 4 प्लॉट घेतलेले आहेत. तर आता तुम्ही आलात इथं 40 लोक आहात, तुमचे सबऑर्डिनेट आहेत, ओळखीचे आहेत किंवा हे खूप व्यवस्थित आहे, सेफ इन्व्हेस्टमेंट आहे. आणि इतकी आम्ही ग्रीनरी मेंटेन केलेली आहे आणि दाखवल्याप्रमाणे प्रत्येक गोष्ट तुम्हाला आवडेल. तर तुम्ही एकदा कधीही व्हिजिट करा. बँकेचे फायनान्स फॅसिलिटीज सगळ्या अवेलेबल आमच्याकडे आहेत. तर क्रिस्टल डेव्हलपरकडनं आम्ही तुमचे थँक्स म्हणतो की आम्हाला हे प्लॅटफॉर्म आम्हाला उपलब्ध करून दिला आहात तुम्ही. तर
And he is got the gold medal in the MD pathology, Dr. Satish Magai, sir. And also I would like to invite Dr. Vinit Birazdar. He is working as an oncosurgeon at the Birazdar Hospital and also has an attachment at Nargis Dutt Hospital, Barshi and Ashwini Sahakari Rugnalay. Over to you, Chairperson.
Welcome all delegates for the first post-lunch lecture in today's CME. The first lecture is on the topic of chemotherapy in focus, new horizons, and the speaker is Dr. Vipul Doshi. Dr. Vipul Doshi is a consulting medical oncologist, DM Medical Oncology. He has done DM Medical Oncology from Tata Memorial Center, Mumbai. He is gold medalist in May 2017. MD Medicine from LTT Sion, Mumbai from May 2013, MBBS from LTT Sion, Mumbai 2009, postdoctoral work from July 2013 to July 2014. He has worked as Assistant Professor, Department of Medicine, GMC Solapur. From August 2017 to July 2018, Specialist Register. He has worked as Specialist Register, Medical Oncology, Tata Hospital, Mumbai. He is member of ISMPO, Indian Society of Medical and Pediatrics Oncology. He is member of ASCO, American Society of Clinical Oncologists. He is member of European Society of Medical Oncologists. I welcome Dr. Vipul Doshi and request him for his talk. Thank you.
Everybody. I would like to thank chairpersons for a kind introduction. I would also like to thank Solapur Obstetric and Gynecological Society to giving me an opportunity to put an overview of how the chemotherapy works in cervical cancers and what are the new concepts in or what are the new advances in chemotherapeutic in cervical cancers. So what I would like to present in next few minutes is to how a medical oncologist looks at a cervical cancer case and how he approaches it and like how we decide on treatment. The most important is the prevalence of cervical cancer is very high, especially in India. It is roughly amounts 20% of global burden. The incidence was rising in last 20-25 years, and now it is going to near a plateau of cervical cancer incidence in India. It is second most cancer among the females, and it is second leading cause of death because of cervical cancer as compared to all cancer-related mortality, and it is 9.1% as per Globocon 2020. The majority of cervical cancers are diagnosed usually at locally advanced stage. Roughly 60% patients are diagnosed at the locally advanced stages. And this is very important to know because it's a what we can call as a potentially preventable malignancy where we can have a screening program in place. Now we have vaccination in place. So this is a potentially preventable malignancy. So that is why we have to look at the statistics. We have to act to catch the patients at earlier stages, even pre-cancer stages, and to prevent this much incidence of cervical cancer. So when we look at the cervical cancer case, a diagnosed case or a suspicious case, we look what is the clinical stage of the cancer, what is the exactly histopathological diagnosis is, what is the physical condition of the patients, and what are the expertise available at our place, and what is the financial conditions of present. And based on this, we decide how to go forward with the treatment. So very important to know, as we already have discussed the cervical cancer staging in the prior talks, the earlier stages, stage 1, stage 2, is usually by the clinical examination. That's a PV and PR examination, and it gives the earlier stages. The imaging helps us in advanced stages of cancer, like in stage 3C, where the lymph nodes detection is important, or stage 4A or B, when there is a spread to local organs, and in case of metastatic diseases. Imaging also helps in prognosticating cervical cancer cases. For example, some imaging like FDG PET-CT, if there is a high metabolic value or there is a high SUV uptake, it suggests that it's a poor prognostic malignancy. Even a local spread indicates a poor prognosis. Even the presence of lymph nodal involvement suggests a poor prognosis. For the diagnosis, or any imaging is like optimal, a CT or an MRI, even in ultrasonography and X-ray scan in earlier stages, we do prefer doing FDG PET-CT. And what we say is like FDG PET-CT is absolutely indicated when we see, we suspect metastatic cases, especially PET-CT is absolutely indicated when we has a clinically palpable supraclavicular nodes. There are some suspicious lesions on the X-ray. And if there are bone pains along with at the presentations, in that scenario, PET-CT becomes an absolute indication to decide the further treatment. Once the imaging decides once, then we come across the histopathological evaluation. So it has like 2 pages. Once the post-surgical cases. So post-surgical cases, histopathological evaluation should include, or what we look at, like how is the dimension of the tumor, how much is the stromal invasion, how much is the differentiation, whether it's a well differentiated or poorly differentiated, what is the presence of the lymphovascular stromal invasion, status of the resection margin, status of the parametry and vaginal curve, and number and status of the lymph nodes. And all these things decide whether how much is the risk of developing the recurrences. And based on these factors, we decide like how adjuvant treatment is required to prevent the further recurrences. In case of advanced stages, we require a biopsy, and a biopsy also we need to specify which subtype of cancer it is, because cervix cancer is a mixed bag of tumor, where the most common is a squamous cell carcinomas, which also has subtypes like keratinizing, non-keratinizing, sarcomatid, microinvasive, which has a poorer prognosis. There are also small percentage of glandular tumors like adenocarcinoma, and there are some rare subtypes also like sarcomas, adenoid cystic one, melanomas, small cell carcinomas, and neuroendocrine tumors. And it is very important to know what subtype it is. Sometimes a simple pathological examination helps us to getting exact histopathological diagnosis. Sometimes we need immunohistochemistry also, especially if the diagnosis is suspicious, when we suspect like neuroendocrine variety or small cell cancer, or like cancers other than squamous and adenocarcinoma, melanomas. These needs immunohistochemistry. So decision of whether to send sample for immunohistochemistry is after discussion with the pathologist, what he thinks it could be. And this all has its implication in the managing and its prognostication. So once we decide on the, so now we look at the global incidence of differential histopathological subtypes. Those with the blue is the adenocarcinoma, those with the orange is the squamous cell carcinoma, and those with the gray is the other. So most common variety is the squamous cell, small percentage of adenoxia, and very small percentage of other cancer varieties also. But with we go on like experience, we see other varieties also. Like recently we had seen sarcomas of cervix, we had seen rhabdomyosarcomas, we had seen melanomas. Small cell carcinomas also a bit commoner than other. And these histopathological diagnosis makes a lot of impact in prognostication as well as managing the further treatment. So this is the most important part, like the management of cervix cancer is a multidisciplinary integrated management. So it needs the active participations from all aspects, from the gynecologist, from the surgical oncologist, from the radiation oncologist, from the pathologist, from the imaging. When the cases are locally advanced, when they were suspecting rectal infiltration, then the gastroenterologist also get involved. When there is a urinary bladder infiltration, or when there is a presence of hydroureteral nephrosis, the urologist also come into the picture. In all the cases, the nutrition and nursing part comes into the picture. So like it's a multidisciplinary management, and we always like to take opinions. We'll always like to decide the management as a team. It helps in both. The patient gets the benefit of integrated approach, plus even we us as a physician or as a surgeons, we get a lot of confidence in treating the patient that we are going on the right track. And we do involve multidisciplinary team at different phases of the treatment, at the initiation, at the end of the first phase of the treatment, at the end of the completion of the treatment, even at the time of the recurrences, we do involve multidisciplinary team to decide on the action. So this is a brief review. Already we have discussed by Dr. Parag sir, like in early stages of cancer, we can give a local therapy. In a slightly further going, we can go ahead with the radical surgical approaches. And if further go on, we can have a concurrent chemoradiotherapy. And after that, it's the metastatic disease. It's either a chemotherapy or a palliation of symptoms only. So this is a summary of available treatment options, where there is an early stage managed with the local therapy, then the slightly advanced managed with the surgical, then this locally advanced disease managed with the chemoradiotherapy concurrent, and in a metastatic disease, it's like chemotherapy, immunotherapy, targeted agents, and palliative care. So when, as a medical oncologist, we look at the patient before starting chemotherapy, we always look at how is the physical fitness of the patients, and we do use this ECOG performance status scoring to decide on the physical fitness of the patient, where the 0 is fully active, is stage 1, performance status 1 is slight restriction of activity, performance status 2 is ambulatory but requires slight help in day-to-day activities, performance 3 is capable of only limited self-care and majorly bound to help, and 4 is a completely disabled one. And so depending on the physical assessment, if it's a 0-1, we can go full treatment, nothing compromise is needed. If it's a borderline, if it's performance status is 2, then we can modify some treatment. We can reduce the doses of the chemotherapy, and we can make it giving supporting care, and we can improve the performance status, and we can go ahead with the full therapy. In performance status 3 and performance status 4, we usually do avoid giving chemotherapy. We actually give only supportive care. If we see the ECOG performance status improves, then we can add on the chemotherapeutic agent or a radiotherapy or this supportive thing. Because what we have observed is the performance status is low, a general condition is low, the patient tend to develop more and more side effects related to chemotherapy and radiotherapy, and it becomes miserable or it becomes more devastating for the patients to survive beyond. So the Karnofsky performance status is another way of assessing of physical fitness. It is commonly used by the radiation oncologist. Then this is again a very important thing, a geriatric assessment. Even in our medical oncology, we have a separate assessment scoring system for geriatric, which includes the functional status, what is the comorbidity, what is the psychological state, what is the nutritional status, cognitive function, how is the social support, and what are the concomitant medications. Because the geriatric population is at risk of developing a lot of chemotherapy-related side effects, and we have to choose a patient to whom to give, whom not to give, whom to give a reduced dose. So the geriatric assessment is very important before deciding on treatment. So moving on to actual treatment of chemotherapy. So one is the role of adjuvant chemotherapy post-surgery. So this is what do we mean by adjuvant is the definitive treatment has been done, and we are doing this for prevention of the recurrences or to reduce the risk of recurrences. And what we use usually is to give cisplatin concurrent with the radiotherapy. The idea behind giving adjuvant chemotherapy or a radiotherapy, because there is a small micrometastasis circulating tumor cells which are left there and which are not picked up by the imaging and which subsequently go on developing the malignancies. And the risk is higher when the margins are positive, when the nodes are positive. So these are the absolute indications to giving chemotherapy concurrently with the radiotherapy. There are some relative indications also, like the histopathological variety like adenocarcinoma, small cell or neuroendocrine variant, or poorly differentiated morphology like a sarcomatoid variant, or presence of an lymphovascular stromal invasion or perineural invasions. So after surgery, in a histopathology report, we actually look for all these things, and if we find it's a high risk of recurrence, then we do consider using concurrent chemoradiotherapy. The commonly used chemotherapeutic agents are cisplatin and carboplatin, and cisplatin is the preferred one, but it's a toxic agent as compared to carboplatin, and so we decided depending on the physical fitness, age, comorbidity, and the renal function or creatinine clearance. So now it's neoadjuvant chemotherapy. Neoadjuvant chemotherapy or induction chemotherapy means this is prior to definitive treatment. The mass is big. The size has to be reduced, the local infiltration has to come down. In that scenario, we do use neoadjuvant chemotherapy, where there are absolute indications of neoadjuvant chemotherapy is stage 4. It means either bladder or rectal invasion, and it has been given for the prevention of the fistula formation. What we have seen, when the bladder or bowel rectum is infiltrated and we start radiotherapy or we start definitive treatment, there is a lot of risk of development of rectovaginal fistula or vesicovaginal fistula development. And once we start with the chemotherapy, the mass reduces down, the mucosa and the structures get healed, and the risk of fistula formation becomes less. And there's one more indication, the presence of bulky para-aortic nodes, because giving radiotherapy at the para-aortic nodes is a difficult job because there is both kidneys are nearer to the para-aortic levels, and those are very radio sensitive structures. So to reduce the size of the para-aortic nose, we do give neoadjuvant chemotherapy. Neoadjuvant chemotherapy prior to surgery is now controversial or absolute. It's rarely considered when it is a bulky, early stage, but it's a bulky disease, we can consider. It is specially considered small cell neuroendocrine tumors because it's the small cell neuroendocrine tumors are high proliferative tumors, and they are at high risk of distant metastasis. So even if a small tumor is at risk of distant metastasis, so in that scenario, we do consider chemotherapy first, followed by a definitive therapy. Most commonly used agents are taxanes and platinums for the neoadjuvant chemotherapy. And this is what recently has come is a interlaced trial. So initially, the treatment approach from 2B onwards to 4 was directly we used to start with the chemo and radiotherapy. So what this trial has designed, keep giving induction chemotherapy, weekly small dose of paclitaxel and carboplatin for 6 weeks, and then doing a radiotherapy at a standard doses, followed by brachytherapy at the standard doses. And this is published in 2014. And this has suggested a good improvement in recurrence or progression-free survival at the 64 months follow-up data. Even it has improved in overall survival. So now the recent guidelines mentions induction chemotherapy should be considered as a new standard of care in the locally advanced cancer, and it is feasible across the diverse healthcare setting. Let us tell you our examples also, like we also have recently started this protocol, and what we were thinking, giving chemotherapy prior to radiotherapy will increase the risk of side effects, the neutropenias and rest of the side effects, which can hamper the delivery of radiotherapy, which is very important as a definitive treatment. But what we had seen in 10, 12 patients, actually it is not there. Like it is a pretty doable treatment, and more than 90% of patients able to complete the treatment without any pauses, without any interruptions. So it's pretty doable. So we are also waiting for more and more data, more and more evidences or experience from the real world data to follow this practice. But this is what came, and this has changed almost like the guidelines for last 15 years, what's there. So this is new in this scenario. So now we move on to palliative chemotherapy, which has been considered in recurrent and metastatic cancers. In a recurrent and metastatic diseases, we consider palliative chemotherapy with the intent that it will cause a symptomatic improvement, it will improve a quality of life, and it improves better survival. But at the same point of time, we have to look at the side effect profiles of the chemotherapy, whether the patient is able to take the chemotherapy, whether it's able to take the side effects, whether will it hamper the quality of life of the patient. So all these considerations we take, and then we plan a palliative therapy. In some case scenario, like advanced cervical cancers with bilateral hydroureter nephrosis, with rising creatinine, sometimes we do take a call, like we'll not treat this patient and let's do only the palliative and supportive treatment, or the only nursing care is needed. Because sometimes it happens that if we go on aggressive treatment, putting stents bilaterally or putting a PCN bilaterally, giving chemotherapy makes the life miserable. A lot of like seniors, even our books also mention the death due to uremia is less stressful rather than because of the side effects which is due to the treatment. So even that is also case. Even in some cases where there is always already developed rectovaginal fistula or vesicovaginal fistula, even in that scenario also, sometimes we try to give only palliative treatment and supportive treatment and not push them for this toxic chemotherapeutic agents. The chemotherapeutic agents in this scenario, we usually use either taxanes or platinums or 5-FU or gemcitabine or liposomal doxorubicin, and it tend to have its own side effects like the hair loss, nausea, vomiting, anorexia. Some may develop neutropenia and other complications also. Now we look at what are the recent advances like a targeted therapy. So there is one targeted therapy, bevacizumab, which is actually a VEGF inhibitor. So normally a cancerous tissue requires a lot of angiogenesis it depends on the food and nutrition and the oxygen supply, and it requires a lot of angiogenesis. And if you can able to reduce the angiogenesis with this agent, the risk of metastasis, even the tumor burdens get down, and it helps in deep responses and longer survival. And the good thing is it is much better tolerated than chemotherapy, although it has its own side effects, like it's an angiogenesis inhibitor, and angiogenesis is required for normal tissue repair. So when the bevacizumab is ongoing, the normal tissue repair is also hampered. So we usually don't plan any surgeries during this therapy. Even a simple healings get delayed because of this thing. But apart from that, it is a well tolerated than chemotherapy. Initially, 4 or 5 years back, cost was the big issue with this drug, but now with the presence of generics, with the presence of biosimilars, it is easily available, and now it is there in the government schemes also. So now it is accessible to all. So now the use of bevacizumab is increasing day by day. And there is a good amount of real world evidence also that it actually works in cervical cancer, improving the life. If you look at the progression of the chemotherapy from 1985 to 2013, so it was in a stage 4 metastatic cancer. So it has improved 6 months to nearly 18 months in 15-20 years with the help of these newer agents, chemotherapeutic agents and VEGF inhibitions. Additional molecular testing is done in cervical cancer because few number of cases do positive for the PDL1 or CPS, which is a marker of immunotherapy, MMR or MSI, which is again a marker of immunotherapy. NTRK gene fusion is there in roughly 1% of patients, and it has its own targeted agents available, which is less toxic and equally good effective. And this TMB testing, tumor mutation burden, again it helps in deciding whom to give immunotherapy or not. The immunotherapy is actually the recently approved drugs are pembrolizumab and nivolumab, which is actually a PD and PDL1 inhibitor. What happens is in a normal tissue, normal immunity has its own action against the cancer cells, and this immunotherapeutic agent, it increases the anti-tumor response to cytotoxic T cells and NK cells, and thus it is used in a metastatic disease alone or along with the chemotherapy. Again, it is fairly well tolerated type of therapy, and some patients may develop some autoimmune side effects. But apart from the cost issue, it's a very fairly good tolerated therapy. Then this is a new drug. This is actually a tisotumab vedotin. It has again recently came in last year, and it is an antibody drug conjugate. So what it has, one component is an antibody against tissue factor, which is highly expressed in the cervical tumor cancer cells. So, and it has been attached with a microtubular agent, which is a chemotherapeutic agent. Its mechanism is this antibody helps this to get attached to the cancer cells, then it gets assimilated, and this microtubule inhibitor or chemotherapeutic agent kills the cell. So it's a very specific type of therapy with a less side effects, is currently available in foreign countries. It is currently not available with us, but it's a good way to forward to look at the less toxic therapy and more specific therapies. In the end, I would like to also support in the metastatic setting or a palliative setting, the supportive care is of equally most important. The patient do suffer a lot of anorexias, fatigue, the disease-related side effects like the bleeding, discharges, infections, recurrent urinary infections, and even the chemotherapy-related side effects, pain, which is also there. And we have to manage this supportive plan along with this treatment. Even in the terminal cases also, we have to see like how much how much we can help them to become more and more comfortable. Even now we do have a team of some brothers and sisters who can go home and treat terminally ill cervical cancer patients. Even we do provide treatments like morphine or fentanyl, even IV fentanyl at home also, so that they can have a better end of life rather than suffering from this care. I think that is all from my side. Thank you for the patient listening.
I must congratulate Vipul for delivering a comprehensive talk on chemotherapy in cervical cancer. Now the floor is open for questions and discussion. I have one question for you. Can chemotherapy can be used as a bridge therapy when the patient is pregnant to delay in later in third trimester? So, can it be used?
That can be pretty much used. What we have seen, the chemotherapeutic drugs has a lot of teratogenic potential, but especially when given in the first trimester. In the second and third trimester, it is quite safe to give chemotherapy. Even we have given some, not cervical cancer patients, but in breast cancer patients, we have given chemotherapy to delay the definitive treatment. So yes, it is doable. Like chemotherapeutic drugs we have given, we have experience using second and third trimester. First trimester we tend to avoid. Usually we can delay it by 3 to 4 months. That's it. Like one cycle will take 21 days. We can give 4 to 6 cycles at the max to delay the definitive treatment like radiotherapy or surgery. So like it depends on like what is the indications. So like we usually do give standard chemotherapeutic agent that's we give in non-pregnant woman. But just we seek like if it crosses 12 weeks or 3 months, that's the only thing because that is what is standard of care. These new fancy drugs, but we don't have much experience like how they behave in a pregnant woman. So we do have a lot of experience of using chemotherapy in pregnant women, but not these new drugs. So we don't know like how it behaves.
In non-pregnant patients, what kind of a drug do you use in your practice?
So like we have discussed, when the surgery is done or when the patient is planned for adjuvant chemoradiotherapy, in that scenario, cisplatin is the preferable drug of choice. And if the patient is not fit for cisplatin because of age, because of some comorbidities, because of this general condition, or because of low creatinine clearance or slight renal failure, in that scenario, we do prefer carboplatin. In some cases, if the performance status is not that good, we do avoid giving chemotherapy at all. Like we ask them to continue radiotherapy alone.
So out of these three, first will be the chemotherapy, then radiation.
Yes. So no. These are the drugs we use along with the radiation. And there are another set of drugs like taxanes and platinums, which we give prior to surgery or prior to chemoradiotherapy to decrease the burden of the disease. And in that scenario, taxanes and platinums we use.
What's the approximate cost that the patient has for this chemo?
So let's talk about this. Cisplatin carboplatin is very cheap molecule. Everything comes somewhere in the range of 1,000 to 1,500, and even this taxane platinum combinations comes in the range of 5 to 6,000. And most of these drugs are like taken care by the government schemes. So like there is nothing to worry. Apart from this fancy stuff in the last immunotherapy, the rest all come into the scheme.
You give immunotherapy to all or?
No. Like in very specific subtests, it's a very costly therapy. And in very specific subtests, we do test, like we have mentioned, the PDL1 testing or MMR testing. And if it comes positive, then we ask them, like, this is what immunotherapy does. These are like cost of the treatment, and this is what we expect from immunotherapy. And it depends on the patient choice and the finances we decide. Let me give you a number, only 3 or 4 cases in last 5 years. In a cervical cancer, I have used immunotherapy. So that is the number.
And how was the response?
It is like more or less a stable disease, good symptomatic improvement, and patient will survive in the range of 8 to 12 months. So that is what is expected.
Thank you.
Thank you.
Thank you, Vipul. Now, I would like to call upon Dr. Nitant Vora for his next talk. His topic today is decoding cervical cytology and histopathology, current guidelines. Nitant has done his MBBS from Mumbai University. He has done his post-graduation in MD Pathology from St. G.S. Medical College, KM Hospital, Mumbai. He has worked as a senior resident in surgical oncopathology at Tata Memorial Hospital. Currently, he is practicing in Solapur for the last 15 years. He is owner of Dr. Vora Pathology Lab, and he is consulting histopathologist at Yashodhara Hospital. And his lab is the first private lab in Solapur to start immunohistochemistry for CA breast, that is ERPR and HER2, with Ki67 testing. Over to you, Nita.
Good afternoon, everybody. Thank you, respected chairpersons. And I also like to thank the organizing team for inviting me for this wonderful CME. The topic given for me today was decoding cytology and histopathology in cervix, current guidelines. So in this, I will talk more about cytology because the guidelines are more in cytology, and last few slides about histopathology. Here I will discuss mainly about, firstly, introduction overview, about history of pap smear, what is the Bethesda system, what are the various terms used in Bethesda system, basic preparation and fixation techniques for pap smear which are required, and then for histopathology I will talk about the current guidelines in reporting and what the changes, what are the things we should look for in a histopathology report. So the aim of this presentation for me mainly is to understand the diagnostic tools for screening as well as effective optimal management for patients with CA cervix. So which are the diagnostic tools? So I would talk about two tools. First is the cytology, that is the pap smear, and second is the histopathology, that is tissue study and diagnosis. I won't go in detail about the incidence, and you may have known this since morning. So screening is basically, why is it important? Because the cancer of cervix has a predictable sequence and the precancerous changes are not visible to the naked eye, but these are detected readily in cells sampled by the papanicular smear. So screening is important because which are not visible to the naked eye. In short, I will let you know what is the history of pap smear. These two, this is the couple which you should know. He is Dr. George Papanikulov and his wife Mary Papanikulov. They are the ones who started this pap smear about 70-80 years back. For those interested, this is a very interesting article, The History of Pap Smear and Odyssey of George and Andromache, that is Mary Papanikulov. So what they did was, they were the two who started the study about the pap smear, and this test became, they published the article in 1941, and after that it became very famous all over the world. So what did this occur? Because he was basically, Dr. George was a scientist and he was studying about X and Y chromosomes. For this, he needed to harvest some eggs for ovulation. He found out that the size and shape of the skin cells in this fluid correlated with the ovulation. But the problem was, he didn't have a medical license to collect the human samples. So what happened? His wife Mary, she began collecting her own samples, and she did this for nearly 21 years. So this study was nearly a 21-year study, and she collected her sample for 21 years, and she also recruited some of her friends in this. Later, when some of the women recruiters in the study developed cancer, Dr. George had the data of all the women. He went back, he found the positive cells, and he published them in an interview. So this was his original publication. You can see the date. 2nd August 1941, so this was his original publication which was published in 1941, the diagnostic value of vaginal smears in carcinoma of cervix. So after this was published, finally everybody was knew about this pap smear, and it became slowly famous all over the world. So this is how the pap smear was started. Various classifications have been developed for pap smear, for the CA cervix in the initial days, starting with the Reagan's classification, which was in the 60s and 70s, which was divided into mild, moderate, severe, and dysplasia, as well as carcinoma in situ. This was further went to Ricard's classification, where severe dysplasia and carcinoma became SIN 3, that is cervical intraocular neoplasia 3, and remaining SIN 1, SIN 2, and SIN 3. It became that way. And finally, the Bethesda system, it was divided into two types, L-cell and H-cell. SIN 1 became L-cell. L-cell is low-grade squamous intraepithelial lesion, and SIN 3 and SIN 2 became high-grade squamous intraepithelial lesion. So it has become a two-tiered system now. So what is the basically Bethesda system? Initially, before the Bethesda system started in the 60s and 70s, every hospital, every lab, they had their own format for presenting, for giving the report. So some points were there, some points were not there. When the patient went to some other institute, the report was different. Then he went to some other country, those reports were different. So there was no reproducibility of these reports. So to overcome this, few of the experts in the field of cytology, they met at Bethesda, the National Institute of Health, Bethesda, Maryland in 1988, I'm sorry, and they devised a format for uniform reporting of cervical cytology. As this was in the city of Bethesda, they named it as the Bethesda system of cervical cytology. So this was first conceived in 1988, and after that there have been various updates of this from 1991, 2001, 2014. The last major update was in 2014. After that, there have been minor updates, and they keep updating those minor updates according to those. But in the initial stages, when it was started, it was not readily accepted by most of the gynecologists there, because many of them were comfortable with their old classification. So in the 90s and 2000s, still very few hospitals started using this. But after the 2014 classification, it was more simplified. And after that, slowly everybody started using this classification. So a CAP survey in 2016 showed that 67% labs in US have started using this, while in the 2019 CAP survey, it showed that nearly 95% of labs started using Bethesda system for reporting. So it slowly became more and more common. Even in Indian scenario, the survey in 2018 showed that 85% of big labs, big hospitals and big labs have used pap smear for the reporting. Even the Indian government national program as well as the IAC, that is the Indian Association of Cytology, they also recommend the Bethesda system for reporting the pap smear. So what is this basically a Bethesda system for classification? It provides a framework for consistent interlaboratory terminology for the reporting of cervicovaginal cytology specimen. They have some fixed names, fixed terms which are globally acceptable everywhere. So these terms are very important. It is a model of standardized reporting in cervicovaginal cytology, and it reflects the most current understanding of cervical cancer. Also, the important thing of this is its clinical relevance. Each category, which is properly named, has clear clinical implications which are based on solid evidence and worldwide census. Also, the authors keep on updating newer revisions in this, and the newer technical advances are also included in the Bethesda system. Some common terms which are used in the Bethesda systems, which the clinicians must be aware. These terms are globally accepted everywhere. We'll come to these terms later. The first few terms, as you all know, are for the squamous carcinoma, for the squamous cells, and the last two, AGC and AIS, for the glandular cells. These are the terms which are used in all the reports of Bethesda system. This is few format I wanted to show. How is the format? They have a fixed format for reporting, which includes a short clinical history, the type of specimen, whether it's a conventional pap smear or whether it's a second type of pap smear. The evaluation is also important, the specimen adequacy. It is said that the specimen adequacy is an important part of pap smear. You have to mention whether the smear is satisfactory or unsatisfactory for evaluation. They have a fixed criteria for those, I will come to that later, but every report should mention whether the specimen is satisfactory or unsatisfactory for evaluation. Then you have to give the microscopy in just 3 to 4 lines, not in detail, just important points. And finally, the interpretation, that is negative for intraepithelial lesion or malignancy. This is the normal report. And only this is the format which should be used. Similarly, one more report here for the LCIL. And this is the format where we have used your microscopy. We can see these large cells with high NC ratio. And we have given as low-grade squamous intraepithelial lesion. And we have suggested colposcopic evaluation and biopsy. So these are the format which they have given. This is a fixed format used all over globally. For those who want to know the details, there is a site link by the IARC, the cancer screening, where they have the digital atlas of all types of lesions, starting from the normal lesions, LCIL, HCIL, and they keep on updating these lesions. So those who want to know about these lesions, some newer pathologists who have just passed out, or even the older ones who are not knowing about this data, they can also visit this site, they can see the slide, they can see the atlas, see the images, and learn new things of this. So it is completely free, this link. And you can see all the slides. And also this is updated. They keep on updating your images in that. As I have mentioned, the specimen adequacy, this is mandatory. It can be either satisfactory or unsatisfactory for evaluation. Basically, the satisfactory, the criteria is quite tough in this. They say it's minimum 8,000 to 12,000 cells, but practically speaking, we don't see this much cells every day. But they have also said that it's the lab's discretion finally to see what is satisfactory or what is unsatisfactory. But they have made one exception that if you can see any abnormal cells here, then even the cells are less, this should be considered as satisfactory. Some examples of unsatisfactory smear I can show. This is mainly blood and only 1 or 2 epithelial cells here. So if we can get such a thing, then it's not possible to report this case, and we tell that this is an unsatisfactory smear and you should report it and repeat it. One more, you can see abundant inflammatory cells. You can't see the morphology of the epithelial cells here. This is also an unsatisfactory smear. Some common cells we have like to show you. The various types of squamous cells, the superficial cells, these are the intermediate cells, the parabasal cells. This is a group of normal columnar cells. These are the metaplastic squamous cells and polymorphous inflammation. One more thing in pap smear is it is not only used for screening of CA cervix, but we can diagnose few infections also through pap smear. Some common ones which we have seen which can be diagnosed are starting with the Trichomonas vaginalis. You can see this pear-shaped organism here. These are the Trichomonas vaginalis. These are the Candida. Candida, you can see this pseudohyphae and this budding yeast cells. Some others, the clue cells in bacterial vaginosis. This is the actinomyces. And rarely you can even see this viral infection like herpes inclusions inside the cells, and rarely parasitic infections. So just for the sake of completion, I am showing you these slides. So these can also be used in addition for screening of cancer. So pap smear has this one more use. Some other criteria, if anybody wants to know, this is the ASCCP criteria, the American Society for Colposcopy and Cervical Pathology. They have given this 2019 criteria, and they have also made some updates in 2023, which are available online. Those are basically more for the Western population, the criteria, because they use more of HPV DNA and all those things, which is clearly not possible for each and every patient here. But we can get an idea of how is the criteria for this. This is the updated in 2023 further. Coming to the terms which I had told you regarding the pap smear, the first one is the most common, the normal pap smear report, which is called as NILM, that is negative for intraepithelial lesion or malignancy. This is basically the squamous cells are adequate in number, they don't have any intraepithelial lesion, and there may be some other findings like reactive changes or even inflammation. So for this, no treatment is required, just follow-up is equal. Second is the LCIL, which is the low-grade squamous intraepithelial lesion. These are generally, example I can show you here. So these are the cells, these are normal cells where you can see few cells have perinuclear halo is seen here, few large endonuclear. Here you can see few binucleate cells. These are some examples of low-grade squamous intraepithelial lesion. So what are these cells? These are eosinophilic squamous cells with a perinuclear empty cavity surrounded by cytoplasmic thickening and nuclear enlargement. We call these cells as a coilocytes. So when you see these coilocytes on the peripheral smear, we call it as a low-grade squamous intraepithelial lesion. It was SIN1 in the earlier category, which has now been called as a low-grade squamous intraepithelial lesion. So what to do when you get a report of LCIL? It is according to ASCCP criteria, if the woman is less than 30 years old, nothing should be done, just follow up. If of more than 30 years, you can go for a HPV test, or you can just go for a colposcopy. If there is nothing in colposcopy, you can just follow up. If you find anything on colposcopy, then you can take a biopsy. In pregnant women, they say it can be deferred until 6 weeks postpartum because it's a slow process and it can be waited until the delivery occurs. So waiting for 6 weeks postpartum is acceptable in pap smear. One more term which you should know is the ASCUS. ASCUS, as the name suggests, is atypical squamous cells of undetermined significance. The name, this is also a globally accepted name, and the U, as you can say, the U in ASCUS stands for the undetermined significance because it is unclear how much of this may resolve to become negative and how much may persist to become LCIL. So it is basically a term which is used between LCIL and normal. Most of the cells are normal, some of them are large, some of them, like you can see this here you can see most of these cells are normal, but one or two large cells are seen here. But though there are few, they should not be ignored because they are large cells. So this should be informed in the report. So these cells are known as SOGS. So these are cellular changes which are suggestive but not diagnostic of the low-grade squamous intraepithelial lesion, and they may not always progress to LCL because sometimes some other causes like irritation, candidiasis, sometimes hormones, or even air drying artifacts while collecting the pap smear. These may cause one or two cells to become large. So they may not always progress to LCL, but it's important to note them in the report. So how to manage this case? According to those ASV guidelines, they have two schools of thought. Some of them say you just repeat the pap smear after 4 to 6 months and see what happens, while some say you can go for immediate colposcopy. But few Indian studies have been done on that. They say that it's not required to go for colposcopy immediately. You can wait, you can repeat after 4 to 6 months. If those cells are reduced or if they are absent, then wait. And if you can see some more cells, then you can go for colposcopic evaluation for that. So just wait and watch in cases of SOGS. Next term which you should know is the ASK-H, which is the atypical squamous cells cannot exclude HCl. This is the term which is basically between the LCL and HCl. There are few cells which are large, but which cannot be called as HCl because HCl is a very sensitive term. I'll come to that later. So before that, this is a term which is ASK-H. These are the atypical squamous cells cannot exclude high-grade squamous metaplasia, and they are just suggestive of HCl but insufficient for a definitive interpretation. Only few cells are then. Generally, this occurs when the cellularity is sparse. The pap smear has very less amount of cells, and in those cells you can see such large cells. You can see these are large cells here. If there are few amount of such cells and the cellularity is less, it should be called ASK-H instead of HCl. So what to do if you get as ASK-H? It is said that the recommended management is you should go for colposcopy, and whatever you see on colposcopy, generally if ASK-H is there, if you will find something on colposcopy and take a biopsy, and that way further management can be done. So what are these ASK cells? As we have discussed, ASKs and HS. As we know, everything is not black and white in cytology. This is a continuous process. So there are few limitations. These are the gray zones which we call the ASKs. The ASKs and HS are the products of limitations of light microscopy and diagnostic capabilities. It also conveys the uncertainty of gynecologic cytology and also provides a comfort level. If these cells have inter-observer receptivity, and as cervical carcinosis is a continuum process, there is no sharp dividing line between these different categories. Hence, these terms are used because there is no sharp dividing line, and these are well accepted and widely used all over the world by the cytologists and are also familiar to the physicians. So these terms are used for routine reporting. Coming to the last term, the HCl, it is a clinically actionable lesions encompasses, that is, it contains moderate dysplasia, severe dysplasia, SIN2, SIN3, as well as carcinoma in situ. These account for 0.5% of all pap test results, and it's a highly sensitive term. The pathologist must be absolutely sure to call it HCl, because if you give it HCl, this is a clinically actionable lesion. You have to take some action on this. So you should be sure that this is HCl, and you have to report that because it is a good positive predictive value. These are the slides of HCl, large cells in clumps everywhere. These are also so large cells. They look like parabasal cells but are very large. These are examples of HCl. One more HCl. So what they say in HCl, if the colposcopic evaluation is inadequate, you have to go for the excisional procedure. And if on colposcopy, you have to look for biopsy. And if biopsy shows SIN2 and SIN3, then you can go for the ablation or excision. So it's a clinically actionable lesion and some action should be taken. Squamous carcinomas can be seen sometimes, but when the background shows lot of inflammation and necrosis and large cells, we call it a squamous carcinoma. This is one more article for those who are interested by the Foxy GCPR, where they have given details about screening and management of pre-invasive lesions, and it's readily available on the internet. This was all about squamous. One or two slides about glandular forms, that is for adenocarcinomas. There are the two types, the OTPA of glandular cells. These are the OTPA of glandular cells, and this is the adenocarcinoma in situ. So what to do, adenocarcinoma here. So how to do if the report comes as AGC, that is adenocarcinoma or the, sorry. So when the report is AGC, then what to do? You have to do a routine colposcopy for the transformation, from the transformation zone, as well as you should do for endocervical sampling in these cases. And if the patient is more than 35 years, you should also go for the endometrial sampling, because those are all adenocarcinoma cells. Both may look similar on cytology, so you should go for endocervical sampling as well as endometrial sampling. So if the result pap smear is the AGC, in addition to the routine pap sample, you should go for this further sampling. So these are the, as we have discussed, the globally acceptable terms used in the Bethesda reporting system. In short, about the preparation of patient for pap smear, ideally the screening should be scheduled when the patient is not menstruating. Patient should avoid vaginal intercourse, dousing tampons, or no use of any vaginal creams for at least 24 to 48 hours prior to screening. And as you all know, transformation zone is the important thing to collect the samples. The screening must focus on sampling the cells at the transformation zone to adequately detect the presence of dysplasia. While collecting the pap smear, two things should be important. So one is either after collecting the pap smear, you put it in a fixative in the Coplin's jar, or secondly, some of them use air drying fixative. So important thing here is you should prevent the air drying in this. As soon as you take the specimen, you should fix it either in the alcohol fixation in the jar, or you can use the fixative, and it should be done immediately, because if air drying occurs, the morphology of the cells changes on the slides, and few cells look large, which may mimic a typical cell. So it's important to prevent air drying in these cases. And for spray fixing, it is said you should be done from an angle of 45 degrees and a distance of 6 inches from the slide. This is the ideal distance for collecting the pap smear. One or two slides regarding the LBC, which is another procedure. The routine procedure which we use is known as the conventional pap smear. This is the second, which is known as the LBC. This is also a bit of different technique for which the slides are not prepared by the gynecologists. They just collect the sample, put it in the jar. They have these jars which have media, and put the sample in this, which are then processed inside the lab. There is a procedure for that. They have a cytocentrifuge machine is there, the pressure gauge is there, through which they prepare these slides and stain it, and that way the reporting is done. These are actually costly, routinely not done, only done at bigger institutions where the workload is more. And conventional pap smear is still very commonly used everywhere, because a study shows that for those cases where with diagnosis of LCIL, the both LBC as well as the conventional pap smear, they have similar sensitivity and specificity. So not much difference other than few confounding factors like blood and debris. Those things are less seen in LBC, and the quality of slides are better in LBC as compared to the CME. But those who are known to report on pap smear, generally the sensitivity and specificity of both types are actually same. Also, in addition, both these types are considered acceptable by the American Society of Obstetricians and Gynecologists. They are generally of two types, two companies, thin prep and sure path. Both have those advantages and disadvantages. I won't go in detail of that. So what are the various limitations of pap smear? As you know, this is not black and white. There are many gray areas in pap smear. It is not a diagnostic test, it is a screening test. So everybody knows that it is good and it has decreased the incidence of cervical cancer by over 50%, but it has its limitations. The sensitivity of one pap smear is less, approximately 58%. There is lot of intra-observer and intra-observer variability. False negative cases are also high. In some studies, nearly 30% false negative pap smears have been done. It may be due to various causes. Some of them are maybe due to inadequate sample, because the sample from the transformation zone is not taken, from other areas taken, and so we don't get those dysplastic cells on the slides. So false negative is also there, and sometimes it is said that HPV testing may increase the sensitivity. So while reporting pap smear, it should be remembered that this is just a screening test. It is not a diagnostic test, with its pros and cons. In short, few slides about the histopathology now. As we all know, the squamous carcinoma is the most common type of carcinoma in cervix, predominantly due to HPV 16 and 18 viruses. Prognostically, tumor stage, age and depth of invasion are very important, and you can see the disease-free survival stage. Stage 1 is 95%, while it decreases to 5 to 15% in stage 5. There are various morphological variants of squamous carcinoma. Some have good prognosis, some have bad prognosis. Lymphoepithelial and verrucous have good prognosis. Sarcomatoid variant has a bad prognosis. It's a broad description, detail. Morphologic, as I told you, there are various morphologic variants which should be told in the report. Commonest is the keratinizing squamous carcinoma, and there are those other types. It is important to write which type of carcinoma it is, because the chemosensitivity and radiosensitivity differs upon whether it's a keratinized carcinoma or a non-keratinized carcinoma. These things should be reported. Some diagrams which I wanted to show. This is normal squamous epithelium. Here you can see large tumor, high power view of this squamous carcinoma. Second common is the adenocarcinoma, nearly 5 to 25%, and they are also due to HPV infections. And two common types of this are the usual adenocarcinoma, which is represents 70 to 90%, and second is the mucinous adenocarcinoma, having similar prognostic factors. Some common diagrams of the adenocarcinoma here. So, staging of for cervical, as you know, the AGCC, that is American Joint Committee of Cancers, TNM classification, and the FIGO staging has been commonly used everywhere for this classification. This has been discussed in the previous slides. I won't go in detail, just to underscore few things which are important, so that those things are required in the histopathology report, like the size of the tumor, the depth of invasion, how much is the depth, these should things be mentioned. Then here other things which you should know, whether the parametria are involved or not. These things is important. Which nodes are involved, pelvic nodes, as you can see, pelvic node metastasis 3C1, para-aortic nodes becomes 3C2, and whether the lower third of vagina involved or not. So these are things which should be required for pathologists to write those in a histopathology report. Regarding regional leads, so there is one category is known as N0I+, where there are isolated tumor cells in the regional lymph node which are less than 0.2 mm in size. Otherwise, rest all are same. So regarding the histopathology report, what are the things oncologist or a gynecologist should see in a histopathology report? Those are the things which should be required. Starting the gross, important things here are the tumor location, the size of tumor. It should be in 3 dimensions, considering the length, breadth, as well as the invasion, the stromal invasion, that is the third dimension. Where is the tumor, whether it extends into the vagina or corpus, how long, far are the vaginal cuff margins, any lymph nodes in the main specimen, or some other lymph nodes which have been shown. These things should be mentioned in any histopathology report. Second important is the sections. So here is you should mention properly the codes as to which tumor sections margins are there on which. This is important because, as you know, most of the cases go for the oncology, tertiary care centers, oncology hospitals, and in many bigger hospitals what they do, they have to, they review the case from their in-house pathologist. In that case, what happens, the in-house pathologist does not know which section is taken from where. So for this, it is very important to write which are the tumor sections, which are the other sections. For it becomes easier for him to understand where the sections taken, and he can report accordingly. Finally, in microscopy also, the things which are important are the type of tumor and its variant, the grade of tumor, whether it's a high grade, low grade, the depth of tumor invasion, margins, lymphovascular emboli, perineal invasion, whether the parametrium is involved or not, what are the nodes which are there, which are the positive nodes, is there any perinodal extension, what is the status of the adnexe, and finally the TNM staging and the FIGO staging. So these all are the things which should be mentioned in every radical hysterectomy histopathology report, and which this helps for further treatment for the oncologist and the radiotherapist. Some institutes have such type of format which helps them, which is easier for them to not to miss anything in the reporting. Finally, the last slide is just like the gynecologists have a few things which a pathologist should know. Here are some requisition forms which a pathologist expects from a gynecologist. We have seen many cases where we don't even have written, the patient's full name is not written or anything is not written, and it becomes difficult for us to report. So this is on behalf of all pathologists, this is just to tell you that please spend 2 to 3 minutes in just filling the form. It does not take more than 2 minutes to fill this form. You should have your assistant may write the following things, but you can just check it and mention the other things. The patient's full name should be there, patient's age should be there, referring doctor's name should be there, because sometimes in a multi-specialty hospital, there are many gynecologists, so we never know who will have done this, and we don't know who to contact if we want to know the details. A short clinical history in relevant menstrual or radiological findings, any relevant blood investigations like tumor markers, and also any previous biopsy or cytology report. So you can just mention these much things in a HPR equation form, and we would be grateful for that. So summarizing the things which we have seen here is, as you all know, the pap smear has become the most followed format globally. The Bethesda system has become the most followed. Everywhere it started being used all over the world. The pathologists as well as the gynecologists need to be aware of these various terms used in the Bethesda system and their clinical relevance. It should be remembered that this is just a screening test, and there are many gray areas in that. Both should be aware of their uses as well as limitations. And regarding histopathology, we should keep ourselves updated with the latest guidelines of reporting for better treatment and management of the patients. Thank you.
Thank you, Dr. Nitat. You have nicely elaborated all aspects of cervical cytology and histopathology for CA cervix. You have detailed the history of pap smear, also the Bethesda system of classification, and all microscopic pictures are very high class quality.
Thank you.
Congratulations for your nice talk. Now I hand over to the audience for questions and answers.
Any questions or comments are welcome. Thank you, ma'am.
This lecture should have been earlier,
Okay.
I thought. That should be the suggestion. Such lecture should be kept obviously, it should be like cytology, then later on HPV testing. It should have been included there. That is what I thought. But very nicely presented.
Thank you. Yes. Okay. Thank you.
I request our chairperson, Dr. Satish Magai sir, to felicitate Dr. Vipul Doshi. Dr. Ghate madam, please join them. Dr. Vinit Birazdar sir, please join. I request Dr. Vinit Birazdar sir to felicitate Dr. Hora sir. I request our President Dr. Nita Gate madam to felicitate our chairperson Dr. Vinit Birazdar sir. Also request to felicitate Dr. Magai sir. I concluded with the thanks note that I thanks to our esteemed speakers, Dr. Vijay Pawar sir, Dr. Bharti Abhyankar madam, Dr. Bhushan Zade, Dr. Parag Kumtekar sir, Dr. Virpaksh Joshi sir, Dr. Vipul Doshi sir, and Dr. Nitat Hora sir. I also thanks to Dr. Chairpersons, Dr. Vidya Tirankar madam and Meena Gunjotikar madam. Then Dr. Rohini Deshpande madam and Dr. Sampath Baltawa sir, and also Dr. Vinit Birazdar sir and Dr. Satish Magai, sir. I also thanks to audience for their patience learning.